Namaste, everyone. A very warm good morning. I'm Dr. Amit Joshi. I come from Nepal, and it's my privilege to come to this Patna place second time because I was born and brought up right next to Bihar border in Birganj, Kalaiya. So this place is very close to me, and it's a privilege to talk on, the topic which is very most talked about. And then I was told to talk on various techniques of meniscal repair. So we all know that till date we have various types of meniscal repair system. These are all inside out, and the outside in. Let's quickly go through these all types of tear and some technical things. So you see this animation, inside out repair of meniscus is very, popular. So you pass your sutures, which is attached to the needle, and then you tie it. So what is important to understand here is if you do all inside out meniscal repair, so once you apply in the superior surface, the inferior surface tends to open. That's why it is essential to apply the sutures in the inferior surface as well, until unless you have achieved a circumferential with inside out technique, which is possible in certain cases. So this is the video of this technique. You need a specific zone-specific cannulas to identify and put your sutures into the various zones. So this is the suture needle, which is attached with number 0 ortho cord. And then once your zone-specific cannula is inside, then you pass the needle from it. And then it depends upon your comfort. Either you pass into the capsule first or into the meniscus. Then you push the needle. So since this was on the more on the medial side, I didn't give a safety incision, but this is one of the limitation of all inside out technique, that you need a safety incision, especially when you are doing into the posterior horn. Then once one needle is passed, then you pass the second needle. Make sure that you have not removed the zone-specific cannula. And with the second needle, then you go into the periphery, the meniscocapsular junction, and then you pass this second needle. Once you pass the second needle, then you pull it from the outside. If you have given safety incision, pull that from the safety incision. Otherwise, even if this needle comes from two different places, you can give incision afterwards based upon where it is, and then pull the suture. The inside out technique is ready. So once this has been done in the superior surface, it is important to place your suture in the inferior surface as well, because I said that it compresses the superior surface and distracts the inferior surface. So placing it in the inferior surface is extremely important, and this can be done by the similar technique, which is nothing specific on this one. Now, all inside technique, which is very popular, and then this is one of the demonstration of all inside technique, which has almost the similar disadvantages, but it has several advantages of doing it very fast. You go through the meniscocapsular junction, deploy your anchor, you pull it out a little bit and pass deploy another ankle and pull the suture so that it fixes your meniscus. This is very quick. This is pretty safe as well, but unfortunately, this is again what it closes either on the upper surface or in the inferior surface. So if you have applied all inside suture in the upper surface, it's mandatory to apply in the inferior surface as well, so that you can close it all together. So this is just a technical video. You can see that longitudinal tear of the medial meniscus. So it's important to prepare the meniscus, which probably we'll discuss during our practical session. The preparation of the meniscus is very essential, for healing of the meniscus. So I do low suction or no suction, shaving. We can use diamond rasp as well, so that you make it a bleeding surface. This is very important in any type of meniscal repair. Say it is inside out, all inside, or outside in. So this is a half pipe, which is essential to pass first, and this is very important tool. This will guide your needle without injuring the surrounding tissue. Device is into the desired location. Then you take out your half pipe, and this is the first pass. Then you fire your anchor from the Smith & Nephew. This is Smith & Nephew device. Then this is the second pass, second throw, and then fire so that your anchor is deployed, and then you pull it down. So this is both the anchor has been, deployed, and now there is one suture which is lying outside. Just you pull it so that you compress the, tear, and you can see that it lifts up, which indicates that there is an opening on the inferior surface. So you can cut this suture and then you have to pass on the inferior surface as well. So this is important when you go with your knot pusher and cutter, you give adequate tension, and then you cut the knot. So this is one suture applied, and you can see that the inferior surface has opened up. There is another suture already applied on the other side. So we have to go into the inferior surface. It's same in the inside out, now same in the all inside technique. But this all inside technique is very handy. It's very simple. It's easy to apply. But this is what, this comes with a little bit of more cost than other one. So outside in technique, which is my preferred technique nowadays, in outside in technique, what we do is we use a epidural needle, and then from outside you go inside, and from the superior surface of the meniscus you pierce with this epidural needle. You can use this curvature to pierce that and pass this Prolene suture. You can see this blue one is a Prolene suture, and use this to shuttle the zero suture or 2-0 suture, whichever you like, and then you shuttle once. Then you have to make a second pass. Remember, the previous pass was from the superior surface. This pass is from the inferior surface without taking the meniscus, and then you shuttle that, and it will provide what I just wanted to show, that it will provide a circumferential compression, which is very, very essential for a good healing of the meniscus, which has been described by Seliman by various technique, and this has been proved that if you achieve a circumferential compression into a longitudinal meniscal tear, it's going to heal well compared to the other devices. And this outside-in technique that we have described was published in, I'll not go into this video of the same technique because you can get it from the arthroscopy technique, which we published in 2020. There are several disadvantages and advantages of these outside-in technique as well. What I'd like to conclude in my concluding remarks, that there are several techniques available for us, and we as a surgeon, we have to be judicial to decide which one is best for this particular patient, rather than propagated by, for posterior horn, you need an all inside technique. For middle portion, probably inside out, and just for anterior horn, it is outside in, but it is not so, You can apply all these technique, even for the posterior horn, inside out can be applied, and the outside in also can be applied. So it's just surgeon's prerogative to decide which is going to suit for the patient. Thank you very much. Thank you.
Thank you very much, sir, for such a great elaboration of all the technique. So we'll be doing workshop here. So those who have registered, kindly come for the workshop. That will be hands-on. On one table, Dr. Bineet Jain and Dr. Bhushan Sabnis will be the guiding us. And on another one, Dr. Subramaniam and Dr. Ankit Goyal will be here.
ये वाला
Check. Hello.
छोटा ग्रुप है, सबको सुनेगा। अच्छा, तो भूषण भी है यहाँ पे। हाँ, so wherever is possible you should try to do a meniscus repair. ठीक है, and it's a tricky business because sometimes these tears are big, they are old tears which come to you at a later date. You got old age patients, and you the results may not be very good all the time, but we need to understand that an attempt has to be made, best possible attempt has to be made to repair the meniscus. और अगर वो फेल भी करता है, you can always do a meniscectomy somewhere down the line. That sometimes become tricky because most of the patients want a one-time solution and they're not happy if it fails. But you need to explain it to them. ठीक है? So again, when you start thinking in terms of doing a meniscus repair, you should be able to identify them. So practically, जो मेरे को एक issue शुरू में लगता था, that is that lateral side opens up nicely. You are able to do lateral side repair, but medial side you have an issue because the joint space appears to be pretty tight. ठीक है? That is an issue which most of the people face in the initial part of their practice, that how to create space in there. The video seems pretty nice, but if you see the video clearly, you see the joint has opened up nicely on the medial aspect, something which you do not see or you're not able to do when you do a case. So all of you should be able to do pie crusting of the MCL. ठीक है? You do a pie crusting of MCL, the joint opens up. And to tell you honestly, when I started doing it, sometimes the MCL used to give way. It was frightening that, it was just like that I have torn off the MCL and how this is going to behave. But believe me, nothing happens. They heal up very nicely. 6 weeks down the line, the knee is totally stable. So do not be afraid of that. But you need to practice pie crusting of MCL to create space on the medial aspect so that you are able to do meniscus repair. Uske bagair, it will be very difficult for you to do a meniscal repair on the medial aspect. So this is one practical tip. You have different options available. You have got all inside, inside out, outside in. Theoretically speaking, inside out remains the gold standard. It is cheaper also. It remains the gold standard. कंपनी के लिए वो प्रॉफिटेबल नहीं है, मगर शुरुआत के लिए आपके लिए वो बेहतर है, because that gives you an option that if you want, you're not happy, you can pass the needle again, you can take a bite again and again. Is not something desirable, but yes, if you're not happy, you can do it again. ठीक है? एक चीज याद रखनी जरूरी है, you can do inside out even for the posterior horn on the medial aspect, but on the lateral meniscus you should not do an inside out technique between the posterior horn and till the popliteus tendon because of the vessel and the nerve which is passing behind it. So if you're repairing a lateral meniscus, you have to do an all inside technique only. But on the medial aspect, you got different cannulas which take you away from the vessel, so you can safely do inside out repair on the medial aspect from the posterior horn till roughly about middle third, and anterior to that you have to do an inside out outside in technique. Okay, these are few practical tips. So start with one. You have got, for doing an inside out, you have got cannulas. You have got single lumen cannula, you have got a double lumen cannula, and now the companies have come out with something like this. These are known as Jones specific cannulas, and these are meant to be used with preloaded needles with thread. Okay, so you have got, these are the preloaded needle with threads, and you have got needles which are just an eye, which you can pass again and again. You can multiple. These are single use and throw sort of needles, but you have needles which you can use again and again. You can load a fiber wire or a 2-0 ethibond, and you can do a repair. So you see the curve in them. The curve is both, it is a curve in two directions. So this helps you, navigate the knee in an easy way, and this takes you away from the posterior structures. So I will just show you how to use them.
So they are called zone specific because they're they can hear me.
No, sir, actually, it is on
Online.
So they are called zone specific because they're designed to be used for various zones. So there's a central, anterior, central, and posterior. The anterior one is quite difficult. So generally speaking, we limit ourselves to mid and posterior. So essentially, what you're doing is you're going to pass this needle through the cannula. It's going to come out from here. We'll use this one. Iska angle thoda zyada hai. And that happens on table also. You'll struggle to get the needle out sometimes.
These are flexible needles, so they will come out and they
Carry
will not
over.
break.
See if it goes through. So these needles will pass through like that. Okay. So it takes a bit of force in the beginning. So when you start, your needle has to be almost at the tip. You put it inside and you pass the needle in. Now you saw how he was struggling to push the needle in. Now imagine something to push it in. That's what this zone specific is. So this navigator is. So there's a hole on one side. There's a hole on one side where you can, and it's designed so that the needle will go in, and this is a trigger which can be used to push it in. So
This basically allows a single person to operate.
so
Otherwise, you need two persons.
you saw the needle coming out. Okay. Now I can pull it out slightly to begin again. Sorry, I forgot. So you can use it to go forward or backward. I always struggle to get it back. Nikal the numbers. Oh. Yeah, well done. So he is expert in this. Okay. So which is anterior, which is posterior, guys? Makes sense. You can see the fibers going before the PCL. So let's just say this is the medial side, this is the lateral side. There is no differentiation in this case. So let's say we have a tear here. Okay. Now, whenever you're doing an inside out repair, you need a small incision on the medial aspect of the knee or the lateral aspect of the knee, wherever you're doing. And that's something like a safety incision that you would do. It's about 1 inch incision in line with the medial epicondyle going just behind the MCL. You have to clear the space between the MCL and the POL. Cut that interval and go put your fingers behind on the capsule. So you're releasing the adhesions between the POL and the capsule, and your sutures are going to come out anywhere they want. Ultimately, the knotting is going to be done on the capsule. Am I making sense, everyone? So you have passed it through your normal anteromedial portal. Now you've already done a pie crusting of the MCL, so you've got decent joint opening. Now there are various types of suture alignment that you can do. So what I'm doing is I'm pushing it in now, and you will see the needle coming out on the other side. Okay. So once the needle is out, your assistant pulls it out from one side. Let's pull. So these are flexible needles. So you can hold it with the artery clip and pull it out. So that's your first stitch done. Okay. Now you have options of various kinds of sutures alignments. This is a vertical suture. This is a horizontal mattress suture, or this can be an oblique suture like that. So whichever you are comfortable with. Now, statistically and evidence-wise, the vertical has the best pull-out rate from all the sutures. So generally speaking, you can do multiple vertical sutures. So the first one, let's say this is, so there's no capsule here. So I'll just go here now, which is slightly above the first cut I've done. So now we put a second needle in. Again, bring the needle all the way to the tip. Once you're there, you need to take a bite in the meniscus such as that.
See, by tailing it becomes easier for you to manipulate.
Yeah, and then the best thing is you can lift it up or pull it down, whichever way you want. And then again the same way, the needle comes out. And once it's outside the skin, your assistant is going to pull it out. So you don't need to worry about the struggle you're seeing here. In the model, it's very difficult to show these things. Okay, so now you got a complete suture. So let's. So essentially, what you got now is a suture which is gone through and through on the meniscus, and we are on the capsule here. Our cut is somewhere here, so we have dissected out everything. So what we'll do is we'll put a probe inside and pull the sutures out through the interval we have created and tie a knot on top of this. So this is the way in which you do inside out meniscal repair. Now, when you start doing this, what will happen is the posterior part of meniscus will lift off because all your suturing is on anterior. What you can do is put another suture under the meniscus, taking the inferior part of meniscus and the deep capsule. So it will also push the meniscus down, making it flat on the tibia. So it's as simple as that. It's one of the easiest way of doing meniscal repair. So till up to this end, you can do it. So all the way till posterior horn of medial meniscus, everything is amenable for inside out. As he said, this is the only area where I won't do it. Generally, beyond the popliteus again is safe area for you.
You can do it, but you know, you could dissect it out from area, isolate the nerve, see the vessel. So practically speaking, you should do an all inside technique for the little meniscus with the popliteus. On the medial side, when you come out, most of the times it will come out where you have the semimembranosus tendon attaching. Okay, so just isolate that area. It requires a bit of practice, bit of dissection, but ultimately it's a sort of, you can say, forgiving thing. You can pass the sutures again, you can do it again. So you can do that. And you know, sometimes all inside I would recommend that you shift to all inside once you're comfortable with inside out, because all inside they're a bit costly devices and they are not forgiving. You fire them, and if they fail, then you have no other option. Will do, and sometimes you end up just doing meniscectomy because the all inside devices failed. So be comfortable by doing an inside out repair, and once you are comfortable with dealing with and inside out repair, shift to doing all inside. It's easier doing in the lateral meniscus. It's a bit difficult doing on the medial side. So this is the all inside device which comes from Arthrix. Now this device is slightly different from the device which is marketed by most of the companies, because this is an all suture based device. Most of these will have a peak anchors through which the thread passes. Now this has a all suture, just like you have an all suture anchor in the shoulder. This is an all suture anchor inside. The flip side of that the needle, piercing needle, is slightly more, it's a slightly bigger diameter as compared to one which have a peak one. So this will leave a slightly bigger hole in your meniscus. So it's slightly less forgiving as compared to other devices. Okay. So you have few things in this. This is the piercing needle, which comes in usually 2 or 3 different angles. So you got the up bevel up, which is the most common bevel that you have. Then you can see the slight angle. You have got a straight angle, which is hardly used, and then you have got a one which got a bevel down. Okay, so people can say you can use it down, but yes, there makes a difference if you're using for it repairing the inferior flap of the meniscus or the upper flap of the meniscus. Then you got this shaft. This shaft is basically to allow you how much you go inside. So this acts as a stopper from you penetrating into the meniscus too far, and you can adjust this by using this. So this is a length adjuster. Okay, you can sort of change this. So usually it is kept at around 16 to 18 millimeters. You have got depth gauge measurement probes, which you can use to just measure how much length you are supposed to maintain. But usually it is kept practically between 16 to 18 millimeters. So you can adjust this. And as you saw in the video, once you're going inside, you have to use a half pike so that this doesn't entangle in the fat pad that you have from your portal. So you put that, and then you go, you have that. So supposedly you have this. So you do not insert your device like this. You insert with the bevel down again, so that it does not get entangled into the fat pad. So you go it down, take out the half pike, and then now rotate it. So, and then you choose again, the principle remains the same. You can choose a vertical mattress which has biomechanically more strength, or you can put an horizontal mattress which gives you a wider area of coverage. With all inside device, I am tempted to use more of a horizontal mattress because of the cost involved. But yes, a vertical mattress has more biomechanical strength. So if cost is not an issue, putting in a vertical mattress makes more sense. So got a simple device. You pierce it like this. So we have kept it at around 18. You go like this. It's hard tissue to pierce. There it won't go in. ये soft है. So let us try on this. Yeah, this is softer, but still won't go in. So what it comes in out here, different devices have different deployment techniques. You need to study them. You need to ask the company representatives, see their educational videos on the website, how they are deployed. So in this, you roll it forward.
So this shout, is it safe?
Yeah. So 16 to 18, we had fixed it at 18. This much is safe. Forward roll करना है. So this comes out and then go back and you hear the click. Okay. Then you come out. So you can see the thread. This is an all suture thing. So when you're coming out, you need to be very cautious because sometimes it takes a bit of effort, and you apply too much of a pull, you might come out of the joint. If you come out of the joint, it's a mess because going it again from the same hole can be problematic. So be very slow when you are taking it out after taking the first bite. Okay, you have to be very gentle. It can be time consuming, but be patient, do it very gently. Should not come out of the joint. Then taking a horizontal mattress, you go in again. Oh, so here we are. So take it back. This comes out, then again forward, and then you come out. So this device is slightly different from the other devices. You see a loop in here and you see a thread. Most of the devices will have a thread. So in this, you pull on this loop. So you see this thing. So once it goes in here and the other thread starts moving, you have achieved full tension. Then you take this out. Now then you pull the single thread. And this goes in. Okay, so this sort of prevents you from putting too much tension, because if you put too much tension, the thread might simply cut through the meniscus. So you see this, both the anchors have deployed and you've got a repair in here. Okay, so this is what I just has told you, that this is an all suture thing. People mostly use a peak in this, and because this all suture thing, this is slightly more, have a bigger bore diameter as compared to the devices. But the basic principle remains same in all of them. And you should be familiar with the technique of deploying, how the anchor is deployed, because it varies from company to company. Okay. The advantage of this is that you have a tactile and a haptic sensation, and you've got a sound. Once you hear the click, that sort of you're sure that this has been deployed. So anything else do we have to show? Outside इनका भी कुछ है हमारे पास. चलो ठीक. You guys want to try it out on this? Can they practice?
Sir, inside out, when tying, how much knot we should?
It's not that how much knots that you have to apply it. So just like you do it in a shoulder, people use a sliding knot and you put half inches beyond that. You can simple put half inches or you can simply tie it. So 2 to 3 knots, just like you use otherwise, they are usually good enough.
5 minutes.
Sir, inside out, sir, you said that once we go up, sir, the inferior one open up.
Yeah.
So we again go to the inferior and put the circumference.
Inferior डालना थोड़ा सा मुश्किल होता है because of the shape of the meniscus. So you can easily put it below, थोड़ा सा मुश्किल होता है. So you need to manipulate a bit to go through the meniscus and then go through the capsule.
With this, I can manipulate, sir. Here also it's all inside, sir. Same thing here also it will.
You can.
So then what we'll do for the inferior?
Again, the same thing. जैसे you fix it superiorly, you fix it inferiorly.
So, one gun we can. One gun, how many shots we can?
Well, this has only one shot. There are few companies who have got multiple shots also. But they can be tricky sometimes.
What makes you can teach us avoid a misfiring of all inside?
Well, with the best of hands, misfiring happens. First thing you need to know that. In the best of hands, misfiring happens. Okay? So the only thing you can do from your end is be conversant with the technique of firing a particular device.
Every device will have different way of firing. Learn the technique.
Yeah, and again, just like most of the orthopedic procedures, you stay with one company, you get more familiar with the firing of one device. You keep on changing companies, it becomes more difficult.
When you want to do outside in, that's what we are trying to show you. You can put a needle from outside to in, pass a suture in. I don't think a suture will come in, but if it does, that will be good.
जो अमित ने दिखाया कि एपिडुरल नीडल वो यूज करते हैं. You can use a simple 16 gauge needle. You can use an intracath. You can use
cheapest way of doing meniscal.
Yeah.
So all you need is a good suture. Simply speaking, you pass one needle, get the suture out, pass a second needle, pass the same suture from a loop for the second suture, pull it out. So you get a bite on the meniscus, tie a knot on the outside, just exactly as we saw.
मगर हाँ, इसमें ध्यान रखना है कि अब आपने स्किन से पास किए हैं, give a small incision slightly above or below from where you have passed and retrieve your sutures from that so that now you tighten the capsule. ठीक है? If you sometimes give an incision in between the threads, you might cut the threads. Then you are in a soup. ठीक है? जैसे अगर आपने यहाँ से पास करे, थोड़ा सा उसके ऊपर एक छोटा सा incision दे दो, and with the probe you can sort of tease out both the thread ends from there and then tie it. Threads के बीच में incision नहीं देना, because sometimes you might just cut the thread.
All the needle tips are pretty sharp.
Well, these zone navigators have made it easy. A single person can sort of use that. Simple devices, you have got double lumen and single lumen cannulas, which are pretty cheap, and you've got needles which eyelet. You can use them again and again. They're pretty cheap. So you can have them in your armamentarium, because sometimes you do not expect a meniscus tear, not to put it in MRI. Otherwise, you go inside and you see a meniscus tear and you want to repair that. So you can do it easily with these devices. The only hitch is that you need an assistant who can sort of push it down gently. With this device, you can do it on your own. Though these are disposable cannulas and handles, but you can use them few times. Okay, so a single person can simply use it to fire. दूसरे में you need somebody who will just push the wire in.
Sometimes on medial side, postoperative to quick posterior on repair. On pie casting, there is also not opening the space.
तो यानी वो एमसीएल आपने पूरा खोला नहीं. अगर आपने एमसीएल की पाई कास्टिंग सही करी है आपने, तो वो खुलेगा. इसके अलग अलग टेक्निक्स हैं. व्यूमेडी पे देखो, बांचा ने एक टेक्निक दी है. सो you go along the posterior border of the tibia, go just above the joint and the femur, put your needle in, and give few people say you just make multiple holes in there. I give an intero posterior, I scrape the femoral condyle, and you can hear a sound of the MCL cutting away. And while giving a valgus stress all along, it simply opens up. क्या करें?
Trying to cut that suture with a sharp end. Okay. Okay. So when you're doing outside in, you put two needles parallel and pass the suture back inside. So do that. चलो चालू करते हैं.
And they can put in a table behind, somebody wants to
हाँ,
do
वो
that.
बाद में- बाद में कर लेंगे.
You can do that.
चलो चलो.
Thank you.
Okay. And we always here. That you want to ask us something, you always welcome.
This is the diameter of the patient, huh? This much.
Thank you, all the moderator and all the participants. So we are moving to the welcome message by Dr. John sir and followed by inauguration. John sir, please.
From the edge, slightly beyond that, where you want the anchor to be deployed, any chances of all the settings are too high.
Good morning, everybody, and welcome to this course, which is really based on knee preservation techniques, including arthroscopy and osteotomy. As you all know that there's been a huge resurgence of interest in the preservation of the bout by some of the bad results of total knee replacements in young patients, and of course the developments in the techniques and understanding of various osteotomies, the development of various cartilage regeneration techniques, and the importance of the mechanics of the knee joint over a long period of time. So I think this session today should be useful for all of you who are interested in preservation of the knee joint, and I hope you find it a useful and rewarding session today. Of course, I think, as you know, Arvind is the main person who's organized this meeting, and we shall go along the day and see how useful it is. Today's program is a bit changed because of the Prime Minister's visit to the city. So please bear with us on the various modifications we've had to do because of that. So with those few words, I'd welcome all of you today and hope you have a rewarding session here today. Thank you.
Thank you, sir. So we are moving to the inauguration part. Dr. Alam sir, please. Dr. Bhushan Sabni sir, Dr. Benish sir, Dr. Subramanian sir, Dr. Ankit Goyal, Dr. Bhattacharya sir, Dr. Srivastava sir, and Dr. Manish sir, please. And Dr. Anil Ram sir, Dr. Rakesh Chaudhary sir, Dr. Vinod Thakur sir, Dr. Praveen Tittal sir, and Dr. Joshi sir, kindly come on the stage. Dr. Himanshu sir and Sheetal Gupta sir also. Thanks. And Dr. S.P. Gupta sir, Dr. Abhishek and Dr. Rajiv Bhatt, please.
वक्रतुण्ड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा. वक्रतुण्ड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा. वक्रतुण्ड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा।
सिंदूर लाल चढ़ायो अच्छा गजमुख को, तुंदिल लाल विराजे सिक गौरी हर को, हाथ लिए गुड़ लड्डू साई सुरवर को, महिमा कहे न जाए लागत हूँ पद को। जय देव जय देव, जय जय भी गणराज विद्या संधाता।
Thank you all. So we'll be moving to the first session, that is meniscus session. Dr. Vikas.
Good morning. Our next session, meniscus session. I invite Dr. Rajeev Bhatt, sir. Please, sir. Hand over to Rajeev.
A very good morning, all delegates and faculties. So we are starting proceedings today, and the first session is meniscus session, and I invite Dr. Bhushan Sabnis, Dr. K.N. Subramaniam, Dr. Rakesh Chaudhary, Dr. Anil Kumar, and Dr. Praveen Sahu to chair the session. Thank you.
Good morning. Good morning, everybody. Welcome you all for this first early morning session. Expecting a very interesting session on the meniscus. Expecting all the speakers to be on time because we know we have to end up a bit early. So thank you very much. So straight away starting with our first topic, may I request Dr. Rajeev Ranjan to talk upon bucket handle tears meniscus. Please.
So, very good morning to everyone. I will be discussing an interesting case of medial meniscus tear. So, it's a 22-year-old male having 8 weeks old RTA. Injury, the patient's knee was locked in around 15 to 20 flexion since 6 to 8 weeks. He presented to us in this condition. The X-ray was not having any obvious bony lesion. So, he got the MRI done. MRI has clearly shown this bucket handle tear of the medial meniscus. The ACL was completely torn. The root was probably intact. On the coronal sections, we can see that the meniscus has come into it's displaced and it has come into the notch. It's sitting in the notch. So coming to some of the basics of functions of meniscus, it just helps in transmitting the axial load of the body through the knee. So it converts the axial load into hoop stress, but it converts the axial load into the circumferential tensile stress, which minimizes the stress on the cartilage portion. That is the hoop stress. If we, the importance of the meniscus lies if we just remove it, then the chances of developing the arthritis is almost 80 to 90% after 14 to 16 years of that. And the medial meniscus itself reduces the stress around 100%. And if we remove the lateral meniscus, then stress on the articular cartilage increases by 200 to 300%. So by this, the meniscus has an important role in sharing the stress. How it does, because the femoral condyle is convex and the tibial condyle is flat. So if you just imagine, so that it creates a point contact, which increases the stress exponentially. But this meniscus is concave and it increases the surface area. So thus by increasing the surface area, the stress on the point contact stress is not created, and it protects the cartilage in that way. So coming to the case, after the MRI, we have planned for the surgery. I went for that, and through the anterolateral portal we have viewed, and we can see this is a double. In fact, it's a triple bucket handle tear. It has detached from the capsule, and there is a tear in between the substance, and also on the central part there is a separate tear. So it is more or less a triple bucket handle. So it's 8-week-old triple bucket handle extending almost from the posterior horn to the anterior pass. So should we try for preservation, or we can just easily do the meniscectomy and run away with the case, and we are done within 10 minutes or 15 minutes are done with the case. And luckily I just said, because the patient was also having the ACL tear. So what should be the plan for this patient?
Hello. Yeah. So nice case. This is what we normally see in our practice as well. The key points here is a associated ACL tear. So
Yes.
chances of healing are much better if you repair it. Second thing is, even though it's a double bucket, if it's reducible, then the chances of healing are much better. And there should not be a radial tear in the middle. If there is a radial tear which is cutting the meniscus into two parts, when you're reducing it, that increases the chances of failure much higher. But of course, we'll try and save it.
Here, luckily the radial tear was not there.
There is no doubt that we have to preserve it.
Yes.
And only one downside that I would think, if it keeps on prolapsing, even after reducing it, if you just extend it, if it keeps on prolapsing and the tissue quality is very, very bad, then you think about doing partial excision, even that also not full excision. That bad tissue will be excised, the remaining tissue will be preserved. So this is a peripheral tear. So
Yeah.
it is in almost the red zone area.
Yeah, it's
And red zone
around 2
area
to 3
is
mm from the capsule.
chances of healing is very, very good. And along with the ACL you are going to do, then it will definitely heal very much. So no doubt that we have to preserve it.
Yeah, along with the ACL, if it is there, the chances of healing is around 83%. If the ACL is not done, it's around 50%. So the chances of healing here is good. Sorry, again, it has come. So we proceeded with the repair, and we have freshened the margins. We can also do trepanation in at this stage, but here it was. Here we can see that the area visible is very less, and gradually it's increasing. It's just because we are doing the pie crusting, and at that time we are also visualizing the intra-articular part. So we can see how the pie crusting has helped in increasing the access to that portion for the repair. So we tried reducing it. It was very difficult. It was again coming back to the notch. So finally, we planned for a reduction stitch by inside out technique. We have inserted two reduction stitches. We have first switched the weaving portal from the anterolateral to the anteromedial side, and we have started working from the anterolateral side, anterolateral portal. And this is the first reduction stitch we are inserting from the inside out technique. Trying to reduce it. And then we have inserted the needle on the face in the substance of the meniscus. Inserted another reduction stitch. And then we moved towards the posterior horn and fixed that with two all inside stitches. After that, we moved to the middle portion and then inserted four all inside out stitches. And the tear was also extending up to the anterior part. as it was the medial meniscus, we have also planned for that outside in repair. This is after the placement of the stitches, but we have not tied it so far. We just did the meniscal balancing with the central most part because the chances of healing was very less in that portion. So we just trimmed off that portion. Then this is the anterior part. So we proceeded with the outside in technique. Just 1 minute. And finally, all the stitches has been given. The tied knot has been given. And then we proceeded with the ACL reconstruction. So this is the final picture. So any more questions or?
Very nicely done.
Yeah. Thank you.
We were about to tell that white zone area also exercise is also good because
Yes,
we
sir.
know that's
So
not going to heal. So the
that
exercise.
pie crusting has helped us a lot. Without that, it was not possible to reach that area and without scuffing the cartilage.
Point to take is, it doesn't matter how many number of stitches you are doing, but you have to make sure it gets approximated very well. That's what you have done.
It should be nicely sitting over the capsule. And thank you so much.
I think we'll call next speaker, Dr. Praveen Tittal, for presenting his case on meniscus root repair.
पूरा फाइल का है फोल्डर दिया था उनको पूरा फोल्डर है पूरा डेस्कटॉप पर है वहाँ पे दिया था किसी ने वीडियो गया ना तो सेम उसमें होंगे तो तभी चलेंगे ये नहीं चलेगा वीडियो फोल्डर दिखाओ चलेगा सर वीडियो चलेगा वो डाल दिया यस फोल्डर So good morning, everyone. Meniscus root tears. So bony avulsion of a meniscus root or a radial tear within 1 centimeter from its attachment should be classified as a meniscus root tear. And why is it important? Biomechanically, it is almost like comparable to a total meniscectomy. So causes, if we speak about lateral meniscus, root tears are usually traumatic and commonly occurs with ACL tear. Medial meniscus root tears are usually degenerative. Iatrogenic root tears can happen. Posterior roots can be injured during a PCL reconstruction, and the anterior root can be injured during ACL reconstruction or during a tibial reaming for a tibial nail. So historically speaking, meniscus root tears were treated by a total meniscectomy or a partial meniscectomy. But the current concept is to repair these meniscus root tears to restore the joint kinematics, joint pressure, and thereby delaying the early onset of osteoarthritis. So we have already covered, I think, the biomechanics of these. So root tears are classified by Lepard in 5 types. Type 1 is partial tear. Type 2 is a tear close to 3 mm, 6 mm, or 9 mm from its attachment. Type 3 is a root tear with bucket handle tear. Type 4 is a oblique tear with a root tear, and type 5 is a bony avulsion. So in order to do a anatomical meniscus root repair, we need to understand the anatomy of a medial meniscus posterior root. So we are looking posteriorly. This is the tip of medial eminence, and the root is attached approximately 1 centimeter posterior and 1 to 2 mm lateral to the tip of lateral eminence. So this is the side where your guide wires need to come out if you're planning to do a meniscus root repair. For lateral meniscus root is very close to lateral eminence. So this is the tip of lateral eminence, and it is approximately 1 to 2 mm behind this. So this is a 45-year-old female presented with a severe pain on walking and on deep flexion. There was a severe tenderness at the posteromedial joint line. Her MRI showed a complete tear of a posterior root of medial meniscus. So classically speaking, the meniscus root tears usually present as in a sagittal plane. It shows as a ghost sign, which is a disappearance of a posterior horn of medial meniscus but the anterior horn is visible. In the axial plane, there is a vertical linear hyperintense signal close to the posterior attachment of the root. And in the coronal plane, there is a vertical linear hyperintense signal, also called a truncation sign. So her diagnostic arthroscopy showed a complete tear of medial meniscus posterior root. This is a type 2A tear with a minimal changes of cartilage degeneration. So good visualization is a key to any meniscus root repair. So, and this can be achieved by using a spinal needle approximately 1.5 centimeter behind the middle epicondyle, just above the joint line, and just a few pokes, and you can see how nicely the joint is opening up. And it has been shown in a number of studies that superficial MCL release heals well after a certain time, but cartilage will not if you damage these cartilage during your repair. So once you have run the visualization, all you have to do is the removal of a cartilage, adequate cartilage at the insertion site, because you want your meniscus root to heal on the bony bed and not on the cartilage. And this is achieved by using these ring curettes, angle ring curettes, which is one of the wonderful instrument to use for a meniscus root repair. So once you have prepared this site, take a bite through a meniscus posterior root. I usually prefer to take at least 2 bites using these self-catching devices, which makes things a little easy. So this is the first one. This is the second one. So now your sutures are there and you have to drill your tunnels. So you can drill these tunnels using a ACL zig, as we have all done in the past, but these zigs are a little difficult to negotiate in a tight space over there. So these are the special zigs which are commercially available for meniscus root, and you can easily drill these tunnels using these low profile zig. I usually prefer to drill at least 2 tunnels. But you can also do a single tunnel technique. So once your tunnels are there, you can dilate these guide wires by appropriate size reamer. But I usually don't do this. I pass these are 2.4 mm wires, and you can easily pass a 18 gauge needle through it with a PDS suture. And this PDS suture can then be retrieved to shuttle these meniscus sutures out through a medial cortex of tibia. So these sutures can be pulled out through medial cortex of tibia. So once your sutures are out, all you have to do is tie these knots over the medial cortex of tibia. So it is always advisable to tie these knots over a cortical button, because these sutures have a tendency to get loose if you tie directly on the soft medial cortex of tibia. So it is always advisable to tie these knots over a cortical button, and this is final fixation after tying the knot. So this is the second case. Here I have used a different zig. This is a arthritic zig with a marked. You can pass your wires at appropriate length at 5, 7.5 or 10 mm. And you can drill all these guide wires at the insertion site. And it is very low profile, easy to use. Again, a nice fixation and nice compression at the insertion site. You can also do a single tunnel technique, but always pass at least 2 sutures through it. So 2 tunnel technique is the preferred method in most of the studies these days, and because it increases the surface area of contact for healing with good compression at the site. Bungee effect is, earlier there was a concern of a bungee effect causing the loosening of these sutures, but it has been shown in multiple studies that the meniscal root repair fails at the meniscus suture interface rather than the bungee effect. So it is always advisable to pass at least 2 sutures so that the force is distributed equally over the posterior root tissue. So non-operative treatment nowadays is not an option, but you can try it in an elderly patient who are not a candidate for a surgery with a diffuse high-grade osteoarthritis. Meniscectomy again, very rarely done for these cases, but you can try in a patient who have a persistent mechanical symptoms like locking or clicking. For a lateral meniscus, the entry should be better approach to a separate incision over a Gandhi's tubercle. It is very difficult to reach this point using a medial ACL incision, especially if you are drilling a ACL tunnel along with a lateral meniscus tunnel. So another important thing is, this is a ACL attachment and this is a lateral meniscus root. You cannot put a suture over there and pull it through a ACL tunnel. You need to have 2 different tunnels. This is again a final fixation. Speaking about results, the meniscus root repairs gives a significant improvement in pain, function, and activity level. There is a significant improvement in postoperative clinical scores, and rate of conversion of TKR is very low as compared to a meniscectomy or a conservative management. Thank you.
You have to add the HTO at the same time. So making 2 tunnel with HTO or making 2 tunnel with ACL, do you find any problem in that?
So all you have to do is just pass a guide wire. I'm not making a tunnel. I'm just passing a 2.4 mm guide wire. So it is very easy to pass a spinal needle through it. You don't need to dilate it with a 4.5 mm.
But finding the space, suppose this is for the medial meniscus root, 2 tunnel for this your root and 1 tunnel for the ACL. Do you find any problem with that? No. Because most of the time root is associated with either ACL or in degenerated you have to do it.
Medial meniscus is usually always degenerative, rarely associated with the ACL tears, but lateral meniscus definitely is. So for lateral meniscus, you can use a separate incision laterally.
Okay, thank you. Bhusan sir, for lateral meniscus, do you put on the lateral side or it's on the medial side only?
I still come on the medial side. The lateral side of the tibia is sloping quite acutely.
Quite accurate.
If you remember, tibia is like a right angle triangle. So the lateral side is almost vertical face. It's very difficult to get because if you're drilling it, a lot of times your bead pin or guide wire skives on the posterior part. So I come slightly medial, maybe just medial to the tibial tubercle.
And ACL is more medial to that.
ACL is much more medial.
For medial meniscus, it is root is medial and ACL is little bit.
There is a cleverly described technique by one of the British surgeons. He drills the ACL tunnel, and through the ACL tunnel, he drills another small tunnel going for the root. So all the sutures are retrieved through the ACL tibial tunnel only, but the root is coming as a separate suture with a separate tunnel through the ACL tunnel itself. So that's something I want to try once in a while now. Let's see.
Thank you, sir.
Thank you, Dr. Praveen. Next paper is Relieve Meniscus Repair. Dr. Himanshu Gupta.
Hi, good morning, everyone. And thanks, Dr. Arvind and John, sir, for inviting me in this conference. So I'm Dr. Himanshu Gupta. I'm based at Ghaziabad, which is NCR now. So already bucket handle and the root tear has been covered. So I'll keep my talk on the other kind of tears that we encounter in our routine practice. So this is just a brief slide to tell about the orientation of the collagen fibers in the meniscus. And it is significant as the pattern of the tear is mainly governed by these kind of fibers. So we have three kind of fibers. The common ones are the circumferential fibers, which are oriented circumferentially. And these are the most important ones, which are responsible for making the hoop stress. And the radial fibers, which run across that. And along with that, there are perforating fibers. And the vascularity of the meniscus comes from periphery to the central part. So we often encounter mainly four kind of tears. The common ones are the longitudinal or the vertical tears, the horizontal tears, radial tears, and there's a combination of various patterns leading to complex tears, along with that bucket handle and the flap tears. So when is the meniscus, we say it's repairable. So for in my practice, anything which you can repair should be repaired. But ideally, anything which is in zone 1 and 2, which have a good blood supply, heals well. All younger patients and all acute tears are the one which should be addressed in almost all of the cases. Certain degenerative tears with concomitant arthritis, complex tears in white zones, poor quality tissue, and stable partial tears can be neglected skillfully, and they can just simply be divided into a stable meniscectomy. So we have various repair techniques. We have shown, we have been told that in the workshop also, we have inside out, outside in, and total all inside techniques. And it's usually a combination of all the three that we use to repair our meniscus. But classically, we see the posterior horns are better dealt with all inside technique. The body part and the anterior part, they can be dealt with inside out or an outside in technique. So coming on to the longitudinal tears, these are the most common type of tears, and they have a high association with ACL tears. So these are certain videos that I've put on the right side. The down video that we have started here is the suction test, which is demonstrated on the lateral meniscus. As soon as we open the suction, the meniscus comes in. We see a longitudinal tear, which is being addressed with an all inside horizontal mattress. So we have choices of putting a horizontal mattress or a vertical mattress stitch depending on the configuration on the tear pattern. So ideally, I use a one horizontal and one vertical mattress to stabilize most of my longitudinal tears. This is another video where the meniscus is unstable in the posterior horn. A meticulous pie crusting has been done, and an all inside technique has been done to reduce the meniscus to its original place. So often when we put two horizontal mattresses, there is always a tendency of the meniscus to get lift off from the articular surface. So that is dealt with putting in another stitch on the inferior side to compress the meniscus. So this is how, and the one important tip that I want to tell to all the younger colleagues is that you need to have a clear accessibility before you start putting your all inside devices. So you need to have a clear track before you start your meniscal stitching. Now, this is a radial tear, which is a vertically oriented tear extending from inner edge of meniscus towards the periphery. This can be a complete tear or an incomplete tear. And these are the tears which drastically affects the ability to resist hoop stress. And it actually, the meniscus completely acts like a meniscectomy when you have a radial tear. So deeper the tear, the more drastic is the biomechanical consequences. So in this video, the white zone of the radial tear is being resected, and the trephination and the meniscal rasping is being done. And then an all-inside device is used in both the flaps. So we can use a horizontal mattress kind of a configuration to stabilize a radial tear. Often, two all-inside stitches are required to stabilize. We can use it in simple horizontal patterns, or we can use it in like a crisscross or a hashtag kind of a pattern also. And these tears are often sometimes in acute injury, we see a double radial tears on the lateral side. One is towards the posterior part and other towards the body. Now coming on to the complex tears, they are more common in chronic meniscal lesions and in old degenerative patients. So here the pattern of the tear is in different planes. So we can have a combination of a horizontal tear, we can have a combination of a flap tear, and left side video shows that this is a kind of a complex tear. Right side we see that the posterior horn of the medial meniscus is completely torn. I usually do pie crusting in all my cases on the medial side to get a better access towards the posterior horn and to avoid any cartilage scuffing. Once you debride the complex tear, often you see there is a horizontal cleavage kind of a tear, so fish mouth kind of a tear, which can be easily dealt by just putting certain vertical stitches on the upper surface and inner surface. So in my practice, I usually do all inside and outside in techniques. I'm not very fond of doing inside out techniques because it's just inefficient to put those safety incisions on the medial and the lateral side, and it saves a lot of time. Though it increases the cost of the surgery, plus sometimes it is really difficult to have an access with all inside devices also. So this is how a complex tear is being dealt. This is another complex tear pattern, which is dealt with a different kind of a technique. Here the tear is in the body. The white zone has been resected, and we can see there is a lift off from the menisco tibial surface. So my antegrade suture passing device like a first pass mini or a knee scorpion is being used. Two sutures have been passed in the meniscus, and a transtibial tunnel is made at the footprint. Both the sutures are pulled down, and over that all inside device is used to stitch the meniscus in a crisscross pattern. So this stabilizes the meniscus in this complex kind of a scenario. Definitely we need to have something to enhance the biology in this scenario, because these are degenerative tears and the prognosis in certain cases is something which is very variable. So we can use, I prefer to inject a GFC injection at the same time when I'm doing this. I'm not practicing fibrin clot. In my hand, it doesn't work well, but I am giving growth factor concentrate injections post my meniscal repair. So this is how a complex tear is being dealt in this situation. There's another video showing another complex tear where the tear is debrided in the white zone. We can see there is a lift off of the meniscus from the inner side. So again, it is sort of a partial extrusion of the meniscus from the tibial articular surface. The knee scorpion has been used, and the multiple stitches have been passed in the substance of the meniscus in the body zone. I have passed 3 sutures in this scenario and used the transtibial tunnel to reduce it back. Along with that, when you see there is a meniscus posterior part which is coming inside the joint, it's not reduced properly. So I used another all inside device to stabilize my meniscus on the posterior horn side. This is a fiber stitch from Matrix. It's a sort of a mattress suture configuration which comes in all inside devices. So coming on to the ramp lesion, I'm just briefing the ramp because Sheetal is going to take a talk on the ramp lesions. We can have a complete ramp or an incomplete ramp. And these are dealt like a Bankart lesion in shoulder. So a posterior medial port is being made. There's a meniscocapsular separation, and we have to use our suture shuttling devices as we use in shoulder. The capsule and the meniscus are taken as a common bite, and the sutures are shuttled, and they are tied from the posterior part. So Just take 20 more seconds. This is another video showing that once you see the apparently normal meniscus is a small ramp tear on the backside, which is dealt with all inside devices. Though we have to be very careful in using all inside for our ramps because the capsular part is very thin and the pull out strength is not good. So sometimes you see your sutures, they come out when we do this. So that's all. My take home is you have to plan your meniscal repair very well. You have to execute stepwise and you have to follow your patients regularly. Thank you, Arvind, for inviting us again.
Dr. Gupta, it was very nice demonstration of various kinds of tear and their repair. In some of your videos, you showed a bit of lift off, which you tried to reduce. How much of lift off would you accept? Or is there any guidelines for it?
So anytime when I see a tibial articular surface, for me, it's a partial, it's a kind of lift off. Try to reduce it, my meniscus over that. So there's no criteria of how many millimeters. It's just that if you can see beyond your tibial articular surface, it's better to reduce it well.
Okay. And one more question I have to the chairperson. In these complex tears, do you have any experience of going again inside for this particular reason or any other reason and see how much of these complex tears that you have repaired has healed?
So can I just answer it one? It's for the panel, but I have re-scoped two of my patients. Actually, there's a lot of fibrosis which happens at that side, and the peripheral side, it heals well. Only the white part that we repair is sometimes it is just, I would say, just gone off, but the meniscus is usually stable. I have scoped two of my patients for various other reasons, and I found that. Your question.
I have had one case where I had to go in for a different reason because the patient came for a revision ACL. The meniscus was sutured some 3 years ago, and you could make out only some suture materials were there. Almost meniscus was healed also. So that all depends on the age group where the tear was, even though it was complexity. So there was a young patient. I think a majority of them do heal also. And other way of seeing is if in case we are excising it totally, then the options left over is without meniscus number 1 or going for like graft options, allograft or peroneus graft. This one is better than doing a graft. You're doing a peroneus longus graft for meniscus. That's also not a meniscus issue, but this is a meniscus. If it heals, even if it partially heals, it still function better than another graft. That's the other way of seeing it.
I think over the age of 40, the success rate is around 80%. So I would say about 1 in 5 is going to fail. But it's been shown that even if it fails, it's not the whole meniscus which fails, as you said. It's only part which does not heal. And even if you end up excising, it's normally half of what you have repaired. So it's still a win-win situation for most patients. The only caveat is we should not be repairing tears which are unsalvageable. So you should not be trying to cobble things together in a shredded tissue if this is it's not reducible, or if it's looking completely dead tissue, then it's not worth repairing. But having said that, anyone under the age of 30, 40 with decent cartilage is an ideal candidate for meniscal repair.
So it's worth giving a chance to meniscus, provided doing a good counseling to the patient.
Yeah, so I tell my patient there is 1 in 5 chance it will not heal when I'm doing a repair, even in young people also. But it's always better than having no meniscus at all. And most people agree to that.
Nowadays, I think it's other way around. The patient comes and demands that my meniscus should be repaired.
So
irrespective of the type of tear or the quality of tissue, they just demand that meniscus should be
I
repaired.
work with Anand Joshi, his famous talk on meniscectomy. He says that previously we used to come out with a small sample pot with a completely excised bucket handle tear of meniscus as a trophy. Nowadays we have to hide it and say, unfortunately I had to excise the meniscus.
So patients are being over demanding and they keep on getting their MRIs every 3 months, 6 months to see whether the meniscus is healing or not. And that's the biggest
That's the most important point. Don't do MRIs for 1 year at least.
So that is the primary surgeon who advised not to do an MRI, but he goes to any other person and tells about the knee problem. The first thing they advise is an MRI which shows a re-tear. Because most of the radiologists, they will say it's a re-tear. So then again, it's a problem. So we need to prognosticate them very well that we are taking a chance whether it heals or not is the secondary thing.
I don't know how the experience in sports injury center, because I get a lot of sports people who come and ask for MRI. After 4 months after the meniscus repair, sir, please do MRI, we'll check whether the meniscus has healed. I totally abstinate them. not to do anything for 1 or 2 years. Until then, you still see the.
That's what the primary surgeon always tells. But the second he goes to any other person, the first thing they advise is an MRI. That's a problem.
So when you are repairing a tear in the lateral meniscus, just next to the root part. So when you use the all inside device, so how do you, what precaution do you take when you put that?
So actually that is the area which is the accessibility is often an issue because there's a tibial eminence which comes in. So you need to track it well. So I usually keep my the leftover handles from my previous cases, get the HTO done. I just check whether my accessibility is correct or not. Second, I usually keep my depth of 16 or 18. I don't go beyond 18 because the vessels are a little nearby on that side. Apart from that, there's barely anything that comes in as a problem.
Try to put that button behind the capsule or just at the behind the meniscus. You flip it behind the capsule or just behind the meniscus.
No, that depends. So if you're taking a vertical stitch, you have to flip it behind the capsule only. If you're taking a horizontal mattress, then you have to use the meniscus and the capsule together to flip it on the other side. It has to go on the
There is
capsule.
any way to actually judge the distance between the, how do you, well, there is any technique you can judge the distance 16 millimeter or 18 millimeter. Can you measure
So
it?
that's on the device. That's on the device. The needle depth is on the
But
device.
how do you previously judge it, that where should I set it? You just randomly put it at 16.
So
or
the
18.
distance is not much. 16, 18 millimeter is it's a significant length that you get it. So it barely creates any problem. So you can go only in 16, 18. That's not a problem. Yeah. Thank you.
Yeah, now yes, we are moving towards now expert lecture. Dr. Sheetal Gupta exploring the hidden lesion of meniscus. Dr. Sheetal Gupta, please.
Thank you, Arvind. Thank you, John, sir, for the invitation. So very good morning to all of you. Today I'm going to speak on exploring the hidden lesion of the meniscus.
I was saying when Sheetal is speaking, we should not be sitting here, we should be sitting down there.
So hidden lesions are the lesions which are often missed on MRI and the arthroscopy. These are basically lesions in the posterior aspect. So these are basically essentially the meniscal capsule lesion. On medial side, this is a ramp lesion. And on lateral side, this is the zip lesions. So ramp lesion is a tier of peripheral capsular attachment of posterior horn of the medial meniscus, either at the meniscocapsular junction or meniscotibial junction, or sometimes both. So the ramp mechanism, if you see, it is capsular arm of semimembranous which is attached by the loose adipose tissue, and there is a pivot which lead to anterior translation, and there is a sudden contraction of semimembranosus to reduce the tibia, which leads to this classical ramp tear. So ramp tear is secondary to the pivot, leading to translation and then reduction. So increased rotational stability will lead to increased ACL graft failure rate and accelerated degeneration of the cartilage in the medial compartment. Incidence of 15 to 30% with risk factor of chronic ACL, bone contusions, and slip tibial and meniscus slope. MRI, you can clearly see the meniscocapsular ligament and the meniscotibial ligament attached to the posterior capsule, and the fluid signal, bone bruise in the posterior medial tibia and irregular margin will give you the judgment of ramp lesion in MRI. So once you do the diagnostic arthroscopy, I am doing the probing on the top surface, on the inferior surface, everything looks perfectly normal. But once I enter into the posteromedial compartment, you can see a huge ramp lesion. So always enter into the posteromedial compartment. And to enter into the posteromedial compartment, you have to do the Gilchrist maneuver. Enter into the triangle between the PCL, MFC, and the tibial spine. Do a valgus force, first in flexion, then in extension. And just slight internal rotation will give you a good visualization of the meniscocapsular area. And once you are into the posteromedial compartment, do a needle test using a transillumination method in the posterior superior quadrant. Using this needle, we can see that whole of the meniscocapsular area is absolutely normal. But make it a routine, do it in all cases. In this, everything looks normal, but once you do the needle test, this is the classical hidden lesion. By doing a needle test, you can see there is a huge ramp which needs to be addressed very well. Thunet is classified into type 1, type 2, type 3 is a belt lesion, 4 is complete tear, and a 5 is a double tear. Once you keep on exploring the posterior compartment, you can actually go ahead and see all Thunets type 1, 2, 3, 4, and 5, and probably many more. So surgical options are a single portal, single posterior technique in which you take a bite using a suture lasso, first from the capsule side and then from the meniscus side. It comes with a preloaded fiber wire. You have to just relay the fiber wire and just simply do a alternate half inches. Sometimes it is difficult to pass, then pass it in 2 stages. First, take a bite through the meniscus, relay the fiber wire, and then you can simply use an integrated suture device like Scorpion. Take a bite in the capsule and then just simply do half inches. The only problem that we realize using a single posterior technique is the repair is good, repair is quite stable, but only issue is that repair is sometimes incomplete. I've done everything. Once I move on to the posterior compartment, looking from the high posterior portal, my repair was not adequate. So that I have gone into the low posterior portal using a suture lasso, then I completed my ramp repair. To counter this problem, we have developed a technique and which has been published. It's a no implant pass, park, and tie technique. So we make 2 portal in all our cases, low posterior portal and the high posterior portal. Now I will shift my portal to the high posterior area. My probe is coming from the low posterior portal. Now a Scorpion is taken a bite from the meniscus. Now take a bite from the capsule in such a way that you cover both the meniscocapsular as well as the meniscotibial portion. Once this is done, you will just pass and you will park it in the anterolateral portal. The advantage of parking is now you can take a second bite quite easily. You got a lot of area because you're not done the knot tying till now. Take a bite from the meniscus, take a bite from the capsule again. Your Scorpion device is coming from the low posterior portal. Again, I am parking it in the anterolateral portal. Depending on the size of the tear, you will keep on doing it unless your repair is complete. So the 3 suture I have passed from the low posterior portal. So my visualization is better. I can see whole extent of the ramp from the high posterior portal, which you can miss from the anterolateral portal, and just simply do alternate half inches 1 by 1 from medial to lateral. Once you do that, you can see that I've done the repair without using a fast fix kind of a device, which what Himanshu was trying to show. It's very difficult to capture the capsule, but in this technique, under visualization, you can take a bite of the capsule as well as meniscus, and it's like look like doing a Bankart repair with a very good stability. We have further modified our technique and published in AJSM as a shoeless technique, in which rather than using a 3 suture, we use a single suture. And with single suture, we take a bite first from the meniscus and then take a bite from the capsule. Now there are 2 ends. So one end we will keep on passing alternatively through the capsule, through the meniscus. Just one disadvantage is there may be suture tangling, but with the practice you can manage. And with the single suture, you can alternatively tie in the meniscus and the capsule. That gives more of a watertight closure and a good approximation as compared to any other technique. And once you do side-to-side stitches, it looks like a shoelace. So that's why we give the name of a shoelace technique. And then you can just do alternate half inches over it. So the posterior portal will give you advantage. Always use a 2 posterior technique. A shoelace and the pass-by technique is inexpensive implantless. A zip lesion, which is equivalent to a ramp lesion on the lateral side, it is a longitudinal vertical tear. It looks like a zip in the MRI. So that's why it was named as a zip lesion. But you see very limited literature are there, and that too in the MRI and radiological literature. So if you see the normal meniscocapsular junction, which looks normal on the top as well as on the bottom, but once you start exploring your posterolateral compartment, which you are going to do, so see everything looks normal, top of the meniscus and the bottom of the meniscus. Now go into the intermedial portal, enter into the posterolateral compartment, do the same thing on needle test, and you can see this huge zip lesion. This zip lesion on probing looks stable, like Himanshu has shown a suction test. Even on the suction test, you're not able to see that meniscus is moving at all. So this lesion you can only identify once you go to the intermedial portal, enter into the posterolateral compartment, put a needle through the low posterolateral portal, and do the probing. You can see a huge zip lesion with exposed lateral tibial condyle as well as exposed popliteal, which require a repair. So we were seeing this from last 2 years, and we have done the first classification ever published for the lateral meniscus zip lesion. And we are classified into type 1A and B as a partial zip, complete zip, double zip, and the T-type zip like in the ramp. So the partial zip are stable. That doesn't require a surgery, which is further we are classified into type 1 and type 2. Type 3 and B is a complete zip, which require a repair, which can be through the meniscocapsular junction, or sometimes it is just 1 to 2 millimeter at the junction of meniscocapsular, which again we are classified as a zip because biomechanics remains the same. Type 4 and type 5 is a double tear and the T-type lesion extending into the capsule. You can use a simple all-inside devices like this to do a repair because the accessibility or more in lateral meniscus. But my preferred technique is not this all-inside, even for the zip. I use this posterior suture lasso technique. So from low posterolateral portal, my passport cannula is coming, my suture lasso is coming. I'm doing a relay. Now through this, a fiber wire will come. I pass the fiber wire. Again, I will not do a tying. I will park it in the anterolateral portal. So I'm looking from the anteromedial portal. I'm into the posterolateral compartment. My suture lasso is coming from low posterolateral portal, which is having a passport cannula. And what you to do is just simple alternative half hitches and a huge repair. Same thing technique you can use for repairing the posterior horn of the lateral meniscus from the posterior aspect. The one more option is you can use anterior scorpion. So shoulder scorpion goes very well up to the capsule. So you can take a bite from the capsule using a shoulder scorpion and to the meniscus using a simple knee scorpion. Do alternate half hitches and then the repair will be complete. Depending on the extent, you can do a further. So this 3 methods you can use. So to conclude, look for the zip lesion from anteromedial portal, explore the posterolateral compartment, classify your zip into type 1, type 2, which is stable, type 3, 4, and 5, which can be repaired with a posterolateral hook or the scorpion method. Thank you.
Thank you, Dr. Sheetal Gupta. And now second expert lecture. Dr. Kanchan Bhattacharya, discussion making in meniscus injury. We have a discussion time of 10 minutes after second expert lecture.
Good morning, everybody. Thank you, John, Arvind, and the rest of the organizers for inviting me here. You'll have to pardon me if my presentation appears to be basic, but I'm still reeling from what I've just heard Himanshu and Sheetal describe and show. And this is so, I mean, it warms the cockles of my heart to see the youngsters doing so well. We always knew that we have a huge pool of bright-eyed and bushy-tailed youngsters, but now they've really matured to great heights. I think we're talking about decision-making in meniscal injuries. We got the first start when Bhushan said he works with Anand Joshi. And you ask Anand Joshi and he'll say a well-done, shaved meniscus does very well for the patient. The patient goes home very happy. Now, meniscal injury is one of the commonest injuries that we encounter. About 61 cases in every 100,000 have meniscal injuries. And in the United States, the commonest surgery is meniscal surgery. And mind you, that's not repair. It's mostly shaving and fiddling with it. And 35% of everybody beyond 50 years will have a meniscal injury. More than 2/3 will be asymptomatic. And if you have a grade 3 osteoarthritis, every one of us is going to have meniscal injury. It could be traumatic, degenerative, and most actually do not require any intervention at all. The importance of meniscus, we all know, it's load sharing, gives it immense stability. And you realize how stable, how it contributes to stability when you do a total knee. You cannot dislocate the knee unless you've taken the meniscus off. That's how important it is. And for all of us who have been doing meniscal repairs with ACL reconstruction, if you see your own patients later, and this has been shown in literature, that the meniscus remains more stable, that the ACL reconstructed knee remains more stable when it has a good meniscal repair, as opposed to the one where you've taken the meniscus off. To evaluate a meniscal injury history, do not forget history. History tells you a lot of things. It tells you if there's a meniscal injury. It also tells you if it requires any active intervention in the means of taking him to OR. A lot of them need to be conserved and conserved well, because we have a huge population grade coming to us, the weekend warriors, the young players, and each one has a different set of demands, and exactly how you're going to reach it is very important. Physical examination, again, the forgotten arts of doing a McManus test, a Paris test, squatting test, those are almost completely lost, but they're very, very important, because this also gives you an idea of where you're going and how you want to treat the patient. Imaging has become the mainstay. You still need an X-ray to rule out any bone injuries, to rule out the presence of osteoarthritis, but MRI is the mainstay. And it's a very good thing that the youngsters are very, very good at reading MRIs. I do not hesitate in taking my MRI plates to the radiologist and helping me and showing me things that I have not been able to pick up, which I think is there. As has been mentioned, that the commonest one is the longitudinal vertical tear that you get, which can progress onto a bucket-handle tear. And in the vast majority of the patients that we encounter with ACL, it's either a vertical, it's usually a vertical horizontal tear of either the medial or the lateral meniscus. A parrot beak tear is one, it's a flap tear, the erstwhile flap tear, and you get it more in degenerative knees. Now, horizontal tear, again, in degenerative knees, we've already seen it. And this is something that we used to call it open book once upon a time. We did not know how to deal with it. And it's become very heartwarming, because the only way I thought it could be really kept in place was we gave a hay-bale suture. I was very hesitant in giving it, but now I realize that a hay-bale suture is an in thing. It's been done quite often nowadays and does quite well because it keeps it in place. Root tear is something that took a long time understanding. And a root tear, untreated root tear, is like a total meniscectomy. And like we know, a total meniscectomy on the ipsilateral compartment adds to about 2 to 3 times the total load in that compartment. Even if you take 1/3 of a meniscus off, it still adds about 60 to 65% of additional load in that compartment. So a root tear should always be repaired, especially in traumatic situation. We seem to be overdiagnosing root tears at times, and I think it's a clear thing, it has been mentioned today too, that root tears, and that happens more in the degenerative cases, medial meniscus, especially when you see some of the meniscus being extruding out. If you have an outer bridge 2+3 or thereabouts, it's not a great idea to try and do this, because we do not know what the outcome is, but you do know what the patient is going to come and tell you. 2 weeks, 3 weeks, 4 weeks, 3 months from now, they're coming to pester you. It's usually a lady. She'll come pester you. Doc, you've operated. I'm still the same. So that's another very important thing. You have to take care of your patients, and you also take care of your clinic. You don't want a very unhappy camper coming to see you every day. So about the biomechanics, we do know the consequences of taking the meniscus out. But just like we do know that there are some menisci which cannot be repaired, which should not be repaired, and there the meniscus should be balanced. When we embark on the meniscectomy, partial meniscectomy, we should only excise that much of the meniscus that is necessary and try and preserve as much of it as is possible. The present mantra is to preserve meniscus, repair them, which is perfectly all right. And I think a large number of them can be repaired. We should always try and repair as much of them as possible in whichever way we think is possible. Make sure that the patient realizes that the post-operative is not a walk in the park. You need a lot of compliance, you need a lot of discipline, and there's a lot of heartache associated with it, both for the patient and for the surgeon. because the complication rates in terms of reoperation is slightly higher than if you did not do it. And even though there's a new study that shows that overall expense is higher because these people who have a meniscectomy will get to a total knee, I think in our situation, that's a little too far-fetched to imagine about the cost here. Our cost here, the reoperation rate for those who come back to us, about 20-odd% still seem to need a reoperation rate in one time or the other. And we've already seen that the different ways we can repair the meniscus, an inside out or an outside in or an all inside. And they all have their pluses and minuses. They all have their uses. And it always depends on which one you're most comfortable with. Add to that the one that Himanshu and Sheetal showed us. And you have a huge plethora of cases to decide from. Now, in terms of meniscus repair, age, essentially not a bar. There's not a great deal of osteoarthritis present. Younger patients, even though they have re-tears, the overall outcome is good. Adolescents do quite well. Literature says that 40, 45 plus, if there's very little osteoarthritis, the repair rate is still, the healing rate is still good. The outcome overall is really, really good. And in root tears should always be repaired if the osteoarthritis is out of reach 2 or less. Chronicity is a big minus point. The longer the tear stays, the harder it is for it to come to a good union. But again, when we operate, when we are in there, we take a look at the meniscal tissue, we take a look at where it is, and if it's repairable, it doesn't hurt to try again, as is mentioned. It's one try is good enough, especially if you counsel the patient before that. Now, extent of the tear. We always thought that it was a red zone that has good chance of union, which is perfectly true. Red-white zone does well too. Avascular zones, and this is not anything new. This is not the industry-driven thing. Frank Noyes, Galasher, Frank Noyes in 1998 showed that radial tears can heal or at least do well symptomatically. Galasher in 2010 has shown 10 years survival rate of avascular zone meniscal repairs in radial tears. And then you have the root tear, which should always be done. And now, just a list of small literature studies that will help people to understand where we are going wrong, where we do not follow literature. A large number of meniscal surgeries is still being done on osteoarthritis. The reports say this difference between a partial meniscectomy in elderly and sham surgery. There's no difference. The same goes for PT or meniscectomy. No difference. And yet, we sometimes go ahead and do them. But things that should help us in deciding again. Now, this is Shelbourne, a 12-year follow-up of bucket handle meniscal tear. Meniscectomy is done at the end of 12 years. Radiological studies showed a very minimal change in the ipsilateral quadrant. We could always say this was old. This was described in 2006, but not too old that way, which means it has a place in certain situations. Now, this is another by Rockbourne, where he compared open repairs with meniscectomies. At the end of 12 years, the results of meniscectomized patient, partial meniscectomized patient, and the repair, there's not a great deal of difference, even for the ones that did not require a resurgery in meniscus repair. In adolescents, even though there's a high rate of early failure, the overall outcome suggests that you should try and repair them. And in an outcome, and this is interesting, we always believed that an isolated meniscal repair has about 50% chance of union, as opposed to about 83, 84% chance when associated with ACL. But systematic review by Nepal in 2022 showed the union rate is about the same whether you do an isolated meniscal repair or an ACL repair. So that makes it easier for us to decide on repairing each one of them. And in radial tears, regardless of the heterogeneity, different ways of treating radial tears, the results of healing are pretty good. To summarize, the elderly patients, most often you probably would not require surgery unless there's a serious mechanical symptoms. With small tears, have a chance, give them a conservative trial. Large tears should be addressed with urgency. Discoid meniscus, you should address them at the first symptom, and partial meniscectomy reserved only for a select few. Exercise as much as necessary and save as much as possible. Repair indications are on the rise, and you have to judge your cases properly regarding expectations, regarding the cost, regarding the outcome. Thank you very much. And do not forget the evidence. They are with you all the time.
Right. Great, Dr. Kanchan. This was very elaborate. We open all the talks which we had for discussions. All the speakers just be there at their place, and if any questions, most welcome to have a discussion on.
So my question to Dr. Sheetal, is there any space for conservative management of the ramp lesion? Is it the size or its chronicity or its tissue wise? Many a time you find that tissue is also very friable. So is there any space for conservative management?
Yes, so there is definitely role. In fact, we have classified the new classification, which we are going to publish soon, into simple two types, a stable and the unstable. So all ramp which are stable doesn't require a surgery. So what are the criteria for unstable? Like if you go into the posteromedial compartment, your tibial condyle is exposed, MTL is avulsed. On flexion extension, if it is displacement is more than 5, you're putting a probe and you're able to displace your ramp for more than 5 millimeter. So these are there is a pivot which is present. So definitely to go ahead and do a ramp repair. So these are 5-6 criteria. So I don't do repair in all my cases. So if there is a partial superior capsular tear is going to heal, I will leave it alone.
So message is it's the classification would decide that it
Absolutely.
It's not all ramps should be treated.
Particularly the size is more than 2 centimeter, and we get a lot of chronic cases. So you see a lot of ramp over there. So that's why.
Yeah. So Bhushan sir, so do you look all the ramp repair from the posteromedial portal at the same time after repair, or it's just a stitching from the posterior side, then it's fine? Even if the bigger tear, you put one stitch and it looks fine from that side, then it's okay. Or you do all the time explore whether its repair is fine or not.
So when I am dealing with a ramp tear, it's always a posteromedial portal. Sheetal's technique seems to be very promising, having 2 portals. I think we need to reskill ourselves in putting 2 portals. But I'm looking at my repairs from the posteromedial portal. Just to slightly digress, I still do inside-out repair for a ramp tear as well. So we put a grasper from behind, lift the capsule up, and passed inside-out needles from front to back, and then tie the knots on the outside. But I think you should check your repair from the posteromedial portal at the end, and more often than not, you'll realize that you haven't stitched it completely. There'll be some part left, especially on the medial aspect of the root.
So if the tear size is big, I think you need to go to 2 portal technique. Yeah. If tear size is small, you can just manage with a single posteromedial technique using a suture lasso. And I think it's quite cheap technique. If you see such a large 2 centimeter tear, if you go ahead and put a fast fix, you will end up putting 3 or 4. And a simple fiber wear is going to cost you 1,200 rupees. So it's a lot of cost difference which is there.
Sheetal, how difficult is it to put 2 portals in the posteromedials?
It's quite easy. I've been doing from last year for PCL. So it was quite easy for me to do for the ramp actually.
And do you do a posterolateral portal also?
It's not required for ramp, but for PCL, definitely 2 posteromedial and 1 posterolateral portal.
Without entering into the posteromedial, you routinely put posteromedial into 2 portals, is it? For all
only the size is the bigger. I can just understand with the simple needle test that the size is extending it's going to be more than 2 centimeter. I will use a 2 posteromedial technique. Otherwise, if it's a smaller tear, you're able to see that it's a smaller tear. I will just manage with a single posteromedial portal only. But I never use all inside device for my ramp.
I want to have a quick survey of how many of you routinely put posteromedial portal for ACLs?
For ACL? No, I'm talking about
routine ACL.
ACL, so ACL...
In ACL might have a hidden meniscus lesion.
So I will go in all cases into posteromedial compartment. I will not make a posteromedial portal. I will just put a needle, check it. If there is no ramp, I will not make a portal posteromedially.
One question. Without entering into the posteromedial compartment, are there any signs to say that this fellow might be having a ramp lesion.
Yeah, absolutely. So one thing is basically if you're having a preoperative pivot and you see that lateral meniscus root is not there.
Arthroscopically,
Yeah,
you're not
I'm
getting there.
yeah, talking about arthroscopy. So once you see that there is nothing, no lateral meniscus root tear and the pre-op pivot was there. So intraoperatively, once you do your assistant do the valgus and just rotation, you will see your knee will get locked. And once you enter into the posterior compartment, you will see there is a ramp lesion. The second sign is the meniscus lifting. If you see, meniscus is sometimes lifted, and when you probe from the inferior surface, you can see a lesion just at the inferior surface of the meniscus. So that indicates there is a ramp lesion.
Right. And that also it can be pulled a bit more.
Yeah.
The posterior.
So once you do the probing and just put the probe on the behind, you can just.
I think one good practice is if you hold your grasper and get hold of the posterior part of the meniscus and try a good traction on that. If it is not coming out at all, then it's almost very stable meniscus. Yeah. You don't need to go for posterior.
The more simpler is go into the posterior compartment, do a needle that is rather than doing all this. It's a very simple technique. So
Sheetal, there was lots of discussion that the ramp should be repaired to the bone, but not to the soft tissue.
Yeah.
Recently.
So that's why I've shown that slide. So on the meniscus, if you see the attachment, there is a meniscocapsular ligament and the meniscotibial is attached 1 centimeter below the tibia. So if the meniscotibial ligament is disrupted from the bone, you need to put a suture anchor like you do in Bankart and repair it. But many a times, almost in more than 85% of cases, you see the MTL is not ruptured from the bone, it is ruptured from the posterior aspect of meniscus. So then this technique works very well. So only in the cases when MTL is ruptured from bone, you need to put anchor. Yeah.
Okay, thank you.
So I would like to add, it is not as simple what Sheetal has shown. For me, it is the toughest part of my surgery to repair a ramp. And I have been asking Sheetal how to do it in such a perfect way. The most important thing I realize is the position of your limb. He is doing all his surgeries in 90-degree hanging down position. So any surgeon who is doing it by keeping the limb on the table, it is really difficult to get a proper access from posterior medial compartment. And it is very difficult to change your position once everything is draped. So I'm half of the time struggling doing my ramp repair. So I've been just doing with single cannula on the posterior medial side.
Tips here is put your big towel below the tunicate level. So there will be a space between thigh and the table, even if you are doing by the leg hanging position. I'm doing all the time in leg hanging position, and anything from the posterior medial side, very thick towel below the tunicate level. So you will have a space. Just a tips in that case. Yeah. Just on the behalf of beginners, Bhattacharya sir, you have seen the evolution of meniscus surgery from very beginning, and you must have the follow-up for very long time, maybe 20, 30 or even more than that. So any times if there is problem in the repair, so what you advise? It's a meniscectomy or should try it for the meniscus repair only?
Now that you bring it up, I've been very hesitant about going into the new generation of all inside sutures. Again, referring to Anand Joshi. So every time they come with a new interference screw, they say, this is the best, sir. And we all know he's been using surface fixation for TBI with excellent results. So we learned outside and inside out, we've been doing it for many years. And then about 20 years ago, the first all inside devices came, meniscus arrows and meniscus darts. So I procured them from the US with all the bells and whistles, and I put them in. And look, they looked so easy, so good. Fortunately, I did only about 8 or 10 of them. They all failed. Not in terms of union. They scored the articular cartilage so badly. And in those situations, I took them all out. And I was just mentioning, I had to do a total knee on one of them. Poor guy, he was still loyal. To answer your question, if a failed meniscus comes to me, do I do a meniscectomy or a repair again? It depends on what kind of a tear it is. More than half the time, I re-repair them. And if it's all in tatters, then I take them out. So for me, it's not whether it's a re-tear on a meniscus. If I'm going in again, I treat it as a virgin meniscal tear and decide according to the way I see it. And we do see it quite often in revision cases.
So one question for Dr. Bhattacharya. So Kanchan, what we did not discuss too much about presence of arthritis and meniscus tear. So if you're doing, even Sheetal or all of us actually, so you're doing arthroscopy, there's grade 3 changes in the cartilage and a meniscal tear. Would you repair it or would you not repair it? grade 3 changes. So it's not grade 4. Grade 4 there is no role, but grade 3 changes.
And I cannot imagine why I would be going in to do an arthroscopy in a patient with grade 3 arthro.
That's the right answer. That's the perfect answer. We should not be doing arthroscopy in presence of arthritis, but off chance you are in the knee for something else.
So I think for such patient, when MRI is showing a scanogram works very well, and if you see there is a varus malalignment, I will go ahead and do a offloading osteotomy along with the meniscus repair.
Next.
I think decision making also depends upon the personality of the patient. All the repair techniques are very good and the results are also getting better. But sometimes it's not what you see inside the knee which is important, it's the outside. Like we do get a lot of wrestlers and these are young patients. And you know that wrestling is they have a lot of pivoting and great forces. And these are young patients, hardly 20. And they come with just meniscus tear, not with ACL. And it's in a gray zone. So what will you do?
Of course, we'll give a trial of repair with some
So
augmentation technique.
these guys have a very short career.
Yeah. So only for elite athletes.
They can't even, they're not ready for even rehab. And of course, they can't afford failure.
Same thing with footballers, professional footballers who come, they can't lose one whole season.
Historically, professional athletes do very poorly with meniscal repairs.
I think we've done few cases in which we combine meniscus repair with LET without ACL. So in such cases, when you feel that the pivot injury is a mechanism, and if the repair is not zone 1, zone 0, zone 1, if you are repairing zone 2, and if you feel that is associated pivot is there, and ACL is normal because the pivot mechanism not necessarily be associated with the ACL. So a meniscus repair with LET, but I have done only 2 cases, the 2 in the sports person.
At least for the meniscal tear with ACL, you're kindly safe because this guy knows he's going to be off sports for some time. But in place of it's a isolated meniscal repair, and
it's a high chances of
Dr. Shekhar pointed out a very relevant point. I faced this dilemma once few years back, and again a wrestler. You very rightly said he was not ready at all to wait for 2 to 3 months. He was not ready at all. Despite I am telling him, if you go for a meniscectomy, you will end up with an arthritic knee. He simply didn't care. But he was not ready to wait. And if you look up in the literature, even the published literature, they say that in a young patient, meniscectomy sends them back to a field faster. Definitely, we all know that. And yes, it will lead to an arthritic knee. But yes, it does not matter to these patients because the only motivation for them is to play. Right? And rest, anything else doesn't matter to them. So yes, I think Dr. Shekhar very rightly pointed out, we need to understand the demand of our patient and made a custom-made solution to them after doing a due prognostication. So yes, meniscus repair is advisable, but if you impose something on him because something is meant to be good for them, and if he's not happy down the line, it doesn't matter.
We do meniscectomy.
For the root tear with the degenerate knee, I stopped repairing.
Sir,
grade 3 OA.
Dr. Subramaniam.
HTO with root tear, you always repair or just go away with the STO and leave the root?
So basically, if it's an acute tear and it's repairable, I will go ahead and repair it.
Thank you, Sheetal.
Sir,
There is a talk by Vinny Jens around that.
One thing that you were talking about degenerative knee with that meniscal root tear. Suppose you're taking, yesterday only I did a case, 70-year female. She had an anterior bony impingement. I had to take her. There was a root tear with a varus and obviously cartilage changes, but otherwise she was pretty happy with the knee. So in these cases, is there any?
So Siddharth, excuse me, there is a case discussion by Dr. Vinny Jens around that only. So we'll
Thank you, our
discuss that.
chairperson. So our next session is on ACL, and Dr. Rajanura, please come to moderate this session.
Hello. Good morning, delegates. Good morning, faculty. Hope we have full of academic session, meniscus session. Now we are moving to ACL session. I would like to invite Dr. Beneet Jain, Dr. Himanshu Gupta, Dr. N.K. Sinha sir, Dr. Alok Kumar, and Dr. Prabhat Prakash to session the chair. Chair the session, come please.
So this is the ACL session. I am inviting the first speaker, Dr. Ashwani Gaurav, ACL Spine Avulsion Fixation. Ashwani, please.
Hello, everyone. So I'll be starting the ACL session. This will be about ACL avulsion, which we all know is the avulsion of the tibial attachment of the ACL at the ACL's tibial spine. Can we proceed, right? So this is how I address this. First of all, we need to know the classification by Mears and McKeever's classification, where he classified it into the position of the ACL, the fragment, and whether it is comminuted or a large fragment. So I'll straight away come to my case. So a 24-year-old male, he had a history of knee injury while playing volleyball around 10 days back. So he had a painful limb and with a knee swelling. He had a knee immobilizer in situ with a painful range of motion. Knee fusion was severe and we could not much do the examination of the knee due to pain. So this is the X-ray that we got. So it showed a fracture of the tibial eminence and classified into type 4 of the ACL avulsion classification type. We got the MRIs done to see any other ligament injury or meniscal injury. So it was an isolated, comminuted ACL avulsion tear. For this type of tears, I use a suture passing device such as a First Pass Mini. One can also use, I also use fiber wires for the repair. Sometimes fiber tapes can also be used. One can also use a lasso suture passing devices. I'll just give a small graphic representation of how I repair this kind of ACL avulsions. So first step is to take a fiber wire using this First Pass Mini device. I pass the fiber wire through the mid substance of the ACL using this First Pass Mini. Then I reload the loop end over the device and then reinsert it over the ACL. So it creates a cinch knot kind of construct. One can make 2 cinch knot if you feel that the bite is not good enough. Now I cut the loop ends and then I have 2 double ends. I drilled 2 holes with the 2 mm beath pin at the anterolateral corner and the anteromedial corner just outside the ACL crater. Now using the spinal needles, I pull through both the suture. I cross either side one end of either side sutures to create a cruciate design over the anterior part of the crater. Now these sutures are then tied over the bone without, one can use also a suture button or a suture disc, but I usually tie it over the bone. The bone is cortical bone and gives good hold to the suture. I at least put 4 or more than 4 knots. So this is a case that I did. This is not the same case in the X-ray. This is a separate case. I recorded the video. This is the first bite that has already been taken, and I'm taking the second bite. Now I pull the suture out and it creates the first cinched knot. Now, after this, I felt that I need to take more substance of the ACL. So what I did, I took another bite. This time I tried to be more posterior and inferior to have more control and more bite of tissue of the ACL. This is the second bite. Now one can also slide fiber tapes over the wire if one wants. Now after taking 2 bites, I next check the tug and check the hold of the suture over the ACL. Next, I drilled 2 holes as I told at the anterolateral and the anteromedial corner of the crater using a 2 millimeter beath pin. I don't overdrill it. I just pass a spinal needle and pull down both the sutures. Now I cross one of the sutures from the medial end to the right lateral and one from the lateral end to the medial side to create a cross over the bone, and it provides a good hold and tries to when we pull down the suture through the bone, it creates a downward pressure over the crater. Now this is the final construct that I usually have. This is very strong. This was the case that I did. This was the POD1 X-ray, and after 8 weeks, the fracture has much united. My rehabilitation protocol is just like any other fracture. I immobilize it in full extension. I start with my static quadriceps, SLR in braces and ankle palms, and I start with partial weight bearing with crutches up till 3 weeks. After 3 to 6 weeks, I knee mobilizer during walking and ROM exercises started up to 90 degrees. These are close chain exercises, and progressive weight bearing to 100% of the body weight by 6 weeks. 6 to 8 weeks is ROM beyond 90 degree, gait training, and full weight bearing is allowed. And beyond 8 weeks, when the fracture seems to be invited, then I allow squatting. So this is the 2-month patient has been comfortably walking, and at 6 months, the patient is almost back into his normal gait and movement. This is the ACL tug, which I do in the follow-ups, and the fragment seems to be stable. One can also use a suture disc or a button in case of at the tibial end. So this is how I would do. Thank you for the attention. Thank you so much.
Thank you, Dr. Ashwini, for your talk on a very common problem. Now, may I call upon Dr. Ramakant to present his paper.
Good morning, everyone. So today I'm going to talk about one of the technique of ACL reconstruction. That's all inside ACL. So we'll start with the case. So this is a 23-year-old male sustained a twisting injury while playing cricket with complaint of instability symptoms. These are the MRI images, sagittal and coronal. There was complete ACL tear, PCL was intact, meniscus was intact. These are the anterior drawer, Latchman, and pivot shift. All were positive. So I decided to do all inside ACL reconstruction in the case. So if you believe in the philosophy of CR knees, then all inside ACL reconstruction follow the similar philosophy. So basic advantage of all inside is it's bone preserving. So it's one of the technique of ACL reconstruction where we don't drill any open channels, open tunnels. We drill 2 closed or blind sockets. So the fixation is basically suspensory or cortical fixation, both on the tibia and the femur. So it gives freedom to adjustment of the graft tension. Graft choices, the preferred graft choice is quadruple symmetric graft. It's gracilus preserving. You can leave your gracilus behind. You can also use quads or bone patellar tendon graft. Graft length. In all inside cases, graft length is very, very important. Ideal length of your graft should be approximately 6.5 to 6.8 centimeter. the femur socket length and the tibia socket length should be more than 10 millimeter of the graft length, because then only you can tension your graft. So femoral socket preparation you can do by your conventional technique like medial portal technique, or you can also use flip cutter. So here you have both the options. You can go by your conventional technique, or you can use a flip cutter device. So major difference is for the tibia preparation. So the femur preparation is similar like we do in conventional ACL, but tibia preparation is slightly different. Here we have to use a flip cutter device to create the closed socket. So this is a flip cutter device. You unflip the flip cutter of your desired diameter. Then you drill it retrogradely. Before drilling, you check for impingement. In every case of ACL reconstruction, that your graft won't impinge the femur. So this is the flipping of flip cutter. So you drill the tunnel in a retrograde fashion. So once you drill the tunnel, the graft passes in this, like all inside technique is different. You pass the graft from the medial port. So these are the differences from the conventional ACL, where you pass the graft through the tibial tunnel. Here you pass the graft through the medial portal, and then you loop the graft through the tibia. So this is the graft being passed through the medial portal. And it's being looped through the tibial tunnel. So and then for the fixation on the tibial side, normally we use ABS button and ABS loop, that is suspensory device, which is adjustable device. We can fix the graft on the tibial side using the ABS button. So if we compare all inside and conventional technique of ACL reconstruction, if we compare on the biomechanical testing, single graft can restore anterior tibial translation to 1.3 mm of native ACL. Clinical outcome between the two, there was no significant difference. Functional deficit was potentially less in all inside cases. Hamstring strength, no significant difference. Graft side morbidity, no significant difference. So biomedical studies, if we compare dual suspensory versus button plus screw construct, so they have found that the ultimate load to the failure was higher in the suspensory fixation group. Although there was slightly greater sacral displacement in suspensory fixation group, it was not found to be a statistically significant difference. If you compare adjustable loop versus fixed loop, the ultimate loads of all the devices were greater than any force than a patient knee should experience in early rehab. So there is some concern that the adjustable loop devices may elongate more than the fixed loop devices. However, this has not been supported in clinical outcome studies. Socket versus tunnel, there is less pain, VOS score is better. closed sockets are created that there will be less graft length available for the windshield wiper and the bungee cord phenomenon compared to the full tunnels. So closed socket for all inside technique, it may have a protective effect that results in decreased tunnel expansion and bone preservation. In a skeletally immature patients, it decreases the likelihood of physeal injuries. So there are multiple studies, meta-analysis and systemic review. They conclude that all inside ACL reconstruction is a good alternative method considering it preserves bone tissues and gracilis tendon with less postoperative pain along with more knee flexor strength and equal outcome compared to conventional ACL reconstruction surgery. So the take-home message is all inside technique is a bone preserving technique. It preserves your gracilis. It allows retensioning of your graft. There is less tunnel dilatation as interference screws are not used. The ease of revision, revising it becomes easier. Specifically useful in skeletally immature patients. There is less post-op pain, more flexor strength, and it has similar outcome as of standard ACL reconstruction. Thank you.
Rama, may I ask a question?
Yes.
So what are the ideal cases where you find this all inside is the bailout rather than making it generalized?
Particularly, I mean, in a skeletally immature cases.
Yeah.
I mean,
So
it's
that is one of
preferred technique.
Yeah, preferred technique.
Yeah.
And in revision cases on the femoral side.
Yes.
So it's become easier with
To
that.
revise the case.
And also when graft size is smaller.
Yeah, particularly in females. I mean, when the graft size is smaller, you can use your, quadruple your semi-T graft. Then it become,
Yes. One advantage you said the preservation of the bone tissue, but there is disadvantage of doing all inside. You have to remove all the ACL footprint for passing the graft because many a time if you left the remnant tissue, you're passing the this graft through the tunnel get stuck. So this is
normally I don't remove the ACL footprint. I mean, if you have to be very careful while looping the sutures. It has to through the same tunnel. I mean, otherwise it doesn't stuck.
Dr.
inside the
Sheetal,
tissue.
you preserve the remnant or you remove the remnant when you are doing this?
So I do all inside in very selected cases. So whenever this is selected cases, I will always preserve the tibial side remnant, but not much of remnant because it may lead to orthofibrosis or a cyclops or a lot of impingement. So all inside my indication is only in open physis. So Ramakant, you're talking about the bone preservation. You're drilling 30 millimeter of tibia. In any way, our length comes around 32 to 35. So actual bone preservation is around 5 millimeter. So does it matter 5 millimeter?
So like I said, if you believe in CR knees, the philosophy is same here.
The 5 millimeter is...
It's CR is not about PCL. It's mainly about bone preservation now. So the same philosophy applies here. It's little amount of bone, but it's bone preserving.
So I agree with Sheetal. In my practice also, it has got limited indications. The biggest drawback that I felt is that you have to remove a lot of remnant. Plus, if there is a slightest mismatch between your graft and the tunnel diameter, then you are stuck. I have revised my case on the table. Because the graft, when you are pulling the graft from the tibial side, often it gets mothered at that position. It's
true.
It is all like flowered.
So you have to be very meticulous about like length of the tibial and femoral tunnels and the graft length.
And even Ramakant, if you're talking about the gracilis preservation, sometime in female, if you do quadruple semi-T, the size is 7. So that is the biggest disadvantage in fact using all inside. If you add a gracilis, then in our routine cases, we get around 8 to 8.5. So quadruple semi-T in females is relatively, thin. So what's your take on that?
See, in Indian females, South heights, sometimes, even semi-T or gracilis, if you combine together, it doesn't cross 7 or 7.5.
For all inside also, you will combine semi-T and gracilis.
Yes.
So we can take further questions at the
regarding remnant preservation, I do in all my cases remnant preservation as far as practicable in all inside ACL also, because when you are keeping your particularly AM bundle intact, there is not much of difficulty, because on the tibial side you can with your all inside jig you can deflect your remnant and then you do your surgeries.
Remnant preservation does not interfere with passage of the graft. You have to be careful.
Yeah.
Your suture loops should go through the same line. I mean, you have to check it before passing the graft. That is not entangling inside the ACL bundle.
Yeah,
So it's
because
not a big
your
problem.
mouth should be clear. Even
Yes.
if your suture also not entangling, if your mouth is not clear, it will stuck at the mouth. So you have to clean your mouth by deflecting your remnant. Similarly, on the femoral side also, if you're creating this remnant preserving ACL, all inside ACL, you have to go with the PCL, PL bundle footprint, keeping your AM bundle footprint intact and clean the mouth. If you're not cleaning the mouth properly, the graft will not go. So that is the tip while preserving the remnant.
Okay, thank you, Ramakant, for this wonderful presentation. Next speaker is Dr. Ravi Kumar. He'll speak on ideal tunnels for ACL reconstruction.
That's not mine. It's not mine. Good morning. A very good morning. Thank you, Arvind sir, John sir, for the opportunity. I'll speak about ideal tunnel for the ACL reconstruction. Coming to introduction, arthroscopic ACL reconstruction surgeries are one of the most commonly performed knee surgeries with an average success rate of close to 90%. So the prime objective of ACL reconstruction is to restore the joint biomechanics so as to obtain a stable joint with full range of motion and prevention of secondary cartilage and meniscal lesions. Still, literature has reported re-rupture rate of close to 5.8% at a minimum follow-up of 5 years. So amongst various causes responsible for the graft failure, tunnel malposition is assumed to be one of the most intraoperative variable and is directly influenced by the operating surgeon. An audit of the tunnel position after ACL reconstruction, they found that close to 60% of femoral and tibial tunnels were malpositioned in the sagittal plane. So the studies have confirmed that there is a significant variation in tunnel placement, even in the hands of experts, to the tune of 10 to 40%. So young arthroscopic surgeons, they always have a dilemma regarding best method to determine appropriate intraoperative graft position. Of late, much importance is being put on placing the ACL graft in a more anatomical location on the tibia and femur, so thereby having graft in a more horizontal orientation, which is believed to provide better rotational and translation stability. So coming to anatomical ACL reconstruction, so we have two questions. So where is the anatomical point and how do we recognize the anatomical point? So there are various landmarks, intraoperative landmarks, intraoperative arthroscopic and fluoroscopic landmarks. So coming to arthroscopic ACL femoral footprint, the best landmark is the native ACL remnant, the native ACL remnant. Then comes the resident ridge. The resident ridge is basically a bony ridge which extends from posterior superior portion to the anterior-inferior portion of the femoral condyle. This is a resident ridge. It basically is a boundary for the anterior margin of the ACL. Next is a apex of the deep cartilage. This was basically a cadaveric study which was done 5 years ago. And they found that the center of the femoral tunnels, femoral footprint center, is approximately 3 millimeter higher from this. If this is the ADC, apex of the deep articular cartilage, so the median position is 3 mm higher, and 12 mm shallow to the ADC. Coming to the radiological ACL femoral footprint, there are numerous publications about use of fluoroscopy in identifying the femoral or tibial footprints. Majority of them have used Bernard and Huttle grid for evaluating the tunnel position. There was a paper published by Bird et al. Where they have used, they went through 5 or more previous studies, and they calculate that the median of the studies as 27% in the proximal and distal. So this is the proximal, this is the distal. From here, it's 27%, and from anterior to posterior, it's 34%. This was a landmark paper, which was a research paper published by the Department of Orthopaedics at AIIMS Patna, evaluated tunnel position using intrafluoroscopy and validated the findings post-operatively with a 3D CT scan. So coming to the ACL femoral footprint, this is an intra-op image. Normally what I do is, Sorry. Yes. I clean the posterior margin so as I can see the posterior border of the femoral condyle. You can appreciate the resident ridge over here. This is the remnant of the femoral. Sir, what's your opinion? What's your take about, do you preserve the femoral footprint or you just shave it off completely? Sheetal sir.
So I usually clean off everything, look at the footprint properly, and then make my tunnels.
Same here.
Sir,
Femoral footprint doesn't have a proprioceptive fibers, mainly on the tibial side, so it doesn't make much difference.
So by the end of the day, you know, the important thing is that you should be sure where you are entering.
Okay.
So your vision is important. So just in, in your, just to preserve the footprint, if your vision gets compromised, it doesn't serve a purpose anyway. So you should clean as much as required for having a good vision. You should know where you are entering the tunnel.
Okay.
So that should be the purpose, not the other way around.
So, do you use a resident ridge or your experience about using the apex of the deep cartilage for evaluating the tunnel position?
So as a tip to the beginners, it's always start from back.
Okay.
Clean from the back side and then come on the anterior side. The most common mistake that people do is they don't go on the back side.
Okay.
They try to make up the tunnel more interiorly. So once you start cleaning off from the posterior part where the cartilage ends, you will end up at the right place.
Yep, thank you. That's what I had done. I routinely shave till I visualize the posterior border of the femoral condyle.
You see, as you will take the knee into deep flexion, you are able to see that area pretty well.
Yes, sir.
If you have, sufficiently cleaned that area, and as you keep on flexing the knee, you will be able to see it.
Even if the resident ridge is not visible, you can draw a imaginary line, because there is a line in the continuation of the posterior cortex of the femur. So go posteriorly, draw a line using
Imaginary
a probe, and then you know that probably this would be the level of the resident ridge.
Well, frankly speaking, something which is covered with synovium, that is not where ACL was.
Right.
Where ACL is behind that. So resident ridge is a good, it's something which looks good on saying and speaking. But if somebody asks you, sir, show me the resident ridge, you might struggle with that.
Yeah.
You might just say, this area which is covered with synovium just shows that ACL was never here.
Never, yeah, okay.
So behind this, the ACL was there.
So you have to just stay behind the residence ridge. That's all.
Yes.
Binit sir, do you people ever do figure of 4 position to exactly look the femoral footprint of ACL?
Well, we do not do figure of 4. We only do figure of 4 when you have doubt whether there is actually a ACL tear or not. So in sometimes you come across a patient, we are not sure that the ACL is partially torn or not. To confirm that, you take it in figure of 4 and you see where it is attached, where the posterior part is attached. Only then you take it into figure of 4. Otherwise, you don't take into figure of 4.
The second option is like what he's doing. Just make a pilot hole, go to the intermedial portal, check where exactly your point is right or wrong. If point is right, then go ahead and start drilling with 4.5 and 8 mm. So this is the point where you should just put a small mark there and confirm from the intermedial portal.
What Sheetal has said, this becomes more pertinent when you are dealing with small knees, especially in Indian females. You sometimes feel you're too interior. So in those cases, you put in a mark, go in, change your portal, see where actually you are. And most of the time you're at the right place. But sometimes in very small knees, which you get sometimes in females, it seems that you're pretty interior.
So for female in a small knee, I just mark with this portal. Then I look from in the figure of 4 position. And many a time I find difference between exactly where should I have and where I have placed that jig. So this makes a little bit of difference. That's why I asked the question. So any small knee or any doubt, my tunnel is shorter and not bigger. So I used to look from this in the figure of 4 position exact location.
It just depends upon how you are accustomed doing your scoping. How well you can look at your landmarks in which position.
So for the bead spin, your experience about using femoral offset, you prefer using offset or directly?
Well, you can use your offsets, especially when your assistant is drilling. Okay. And you sometimes can't control where he will going to land up and drill. So, but the main point remains you have to drill at the center of the footprint. Right. So your offset is just for guiding or controlling the hand of your assistant.
All right. Arvind sir, your take about how much is exit point of the breath pin matters to a surgeon, unless and until it's too posterior.
So you will have little bit of idea whether you are exactly at the same place or not. If breath pin is too anterior, so this give you idea that your tunnel may be little bit anterior. If it is too posterior, it means maybe your tunnel will be toward the articular cartilage if it is too posterior. So this give you the rough idea, but most of the time, if it is within the range, it's hardly matter.
all right.
It's a
Level of-
starting point is the thing.
Yeah, level of the lateral intermuscular septum is one good criteria. So if you're above it, probably you're anterior, and you're too below that lateral intermuscular septum, then probably you're too posterior.
Anterior, yeah. All right. Coming to ACL tibial footprint, the best is in native ACL remnant, then posterior edge of the anterior horn of the lateral meniscus, then PCL. Again, there are radiological landmarks also. There was an article published almost 5 years ago. It was basically MRI-based study where they recommended that center of the tibial footprint is located at an average of 5 mm lateral to the middle tibial spine, and the center of the tibial footprint was located at average of 5 mm posterior to the posterior border of the anterior horn of the lateral meniscus. So this is how is the tunnel preparation done. Routinely, I just put the footprint jig. I use a footprint jig, put it over the medial ridge, let it slide down the place where it is kept, and then consider the posterior border of the anterior horn of the lateral meniscus. And this is how the end result is. So to conclude, there are numerous soft tissue and osseous landmarks available to aid surgeons achieving proper tunnel placement. The resident ridge and the posteromedial articular margin, also called as apex of the deep articular cartilage, are consistent femoral landmarks. Then anterior root of the lateral meniscus and the middle tibial spine are reliable intra-op landmarks for the tibial footprint. Thank you.
So just a request to the moderators, please allow the presenter to complete his talk in the 8 minutes before you go on to discussions amongst yourselves.
Take care of that.
Thank you, sir.
Well, thank you, Dr. Ravi. Next, we have Dr. Arvind Prasad Gupta, our organizer, and he will be talking about biological augmentation of ACL reconstruction.
So, so this is a case, 30-year male, and this is the 4-week-old injury we have. And this is the ACL tissue here. So, Dr. Sheetal, what you do with this tissue for ACL reconstruction at the time of ACL reconstruction?
So this is a good remnant. If this
submit
remnant
type
is,
2.
if this remnant is extending up to the femoral place, what I do is a combined repair and reconstruction. So we've done around 30 cases and probably going to publish soon. So I will put an anchor just above my tunnel and I will fix the.
Binit sir?
We usually do not repair ACL as of now, but yes, I will try to preserve the stump in my own way and take the graft through the center of the stump. And sometimes with such good stump, you know, the stump almost extends from the tibia till up to the femur.
Okay. Preservation of a stump is because it is rich in the blood vessels. At the same time, this neural tissue, that is the proprious fiber also. And this synovium of the ACL is having lot of this fibroblast also. So all these are the advantage of preserving this. So initially, people used to remove it completely. Then concept of the remnant preservation came. And then concept of repairing this tissue with the reconstructed ACL recently came. As Sheetal has said, they have he has 30 cases. We have around 17, 18 cases of similar things. So this was the MRI. This was the fresh 4 or 6 week old injury only. And this was the sagittal section. And this was the tissue that started with. So this was the femoral side. We did the extender, the tunnel making for the ACL reconstruction. And after the making the tunnel, so this was the 4 mm reamer, and then the graft size reaming was done. And after this reaming part, once this hole was made for tunnel was made for the femur, and this is the 2.6 mm of this fiber tag was used that you use for the Bankart tissue, and this is the sleeve for that. This is thus just anterior superior to that tunnel. What is your position, Sheetal, for making this same? That is the only space which is available to us. And also this femoral tunnel is in hyperflexion, and this is in 90-degree position. Do you do in hyperflexion only or 90-degree of knee flexion? 90. So in this way, your this is anywhere not going into the tunnel, and this is how this is made. And after passing the this fiber tag, this is passes through the remnant of the ACL with the help of this first pass mini or knee scorpion only. Then pass the femoral part and then the tibial part. Then graft is passes through the tunnel. And once graft has passed, then this remaining ACL tissue get stitched over that ACL graft. So initially we do preserve only this part. Now we have started stitching whenever there is type 1 and type 2 type of lesion of the ACL.
So Arvind, do you ever check the reducibility of your remnant first? If it's like type 1, you check that the entire stump is intact. You check the reducibility. It often doesn't come up to the footprint. There's always a gap between. So do you change your position according to that for fixation, or it's like fixed on the...
Most of the time type 1 and type 2, it came to the wall of the femur most of the time. And even if the type 1 is there, but tissue is not very good, it's very friable, then we used to take it out in chronic cases particularly. But most of the time type 1 and type 2 reaches to the wall most of the time. So like in this case, after the repair with this fiber tag, and this is after the sutured on this remnant part. So this is just covering over the reconstructed ACL, and also it's give the support to that. And this is thank you.
So Arvind, just a question, when you're doing this, this would work fine if you're not actually trying to pass through the middle of your stump. Like if you're trying to pass a graft in the middle of stump, it definitely takes quite some effort sometimes. It's not easy. You need to do a sequential reaming through the stump. It's a soft tissue. It takes quite some effort. So do you think, if you try to pass from the center of the stump, you will not have much of the tissue from which you can take the bite and then tie it down? So what would you prefer? Trying to go to the center of the stump, or adding this to your repair and trying to pass slightly behind the stump?
Yeah, very good question. So most of the time I keep, if there is, this is the situation where I'm going to repair the remnant. So usually my diameter is anything between 8 to 9 only. It is not more than that. And also at the time of reaming of the tibia tunnel, one probe keep retracting the complete ACL, and my starting point is little bit lateral rather than complete central. So if it is complete central, then you are going to damaging the complete footprint, and also little bit just posterior. It's not never anterior. In that way, you don't have left anything. So that is with the help of probe, I keep retracting it, and then I do this part.
While you're drilling the femoral tunnel, what I do basically, you can use a cover of a spinal drill for that 4 mm drill, and you can use a 2 cc syringe so that it protects the graft. Once you're drilling, your the native ACL will not get
Remain
damaged.
protected. Yeah.
Dr. Arvind, so what are the technique to at the time of drilling to preserve the stump?
So same thing we discuss. First, you with the help of probe, you keep retracting the remnant ACL all the time, and your jig should be little bit posterior and little bit lateral. It's never interior or medial. Then in that case, you will be damaging complete your footprint.
What is your clinical follow-up in cases where you are going to preserve all the remnant while doing the ACL reconstruction?
One thing that we have seen clearly radiologically, the dilatation of the tunnel that is usually happen with the soft tissue is less. We are doing this for last, I think, 1.5 year or 2 year only. The dilatation of tunnel, we find lesser with that, and rest, it is almost equal to your ACL.
Does the rehabilitation program differ while preserving the remnant or not preserving?
Anyway, a patient is going to take full bed wearing after the 2 weeks. So hardly in 2 weeks, hardly any difference with that, whether it's the non-bed wearing or wet wearing. So after 2 weeks, he is doing complete wet wearing, full range of motion. So that is my protocol.
Thank you.
Next, I would like to invite Dr. Manish Kumar to speak on ACL with HTO.
By keeping the remnant, what is your motto? You prioritize your biology, compromising anatomy, or you will stress on your anatomy and do whatever biology is possible?
So I think anatomy is not going to change because diameter is 8 millimeter. Your complete footprint is almost 16-20 millimeter. So your anatomy is not going to change. But I think the biology and proprioception, that is the two important thing. That is because of that ACL is failing over the time. Even failure rate is up to 25 to 30%, particularly for the young people. So if this can aid in a longer term, so this is what I am expecting. So little bit of proprioception and definitely biology.
So on the tibial side, the entire, what you have shown, entire ACL is attached to the tibial side. So now you are taking out some of your this tibial footprint and then you are creating the tunnel, or the entire ACL is remaining intact and then you are compromising your...
So little bit of the tissue from the lateral side only.
So you're taking it out?
Just little bit.
Okay.
Well, Ranajit, I think you had a very valid point. It's somewhere between what I was saying, that you try to come from within the stump only and try to preserve a sleeve throughout all around your ACL.
Exactly.
And in this way, you are trying to preserve only from the front part which you're looking. Behind you have the ACL which you've reconstructed. So I think, you need to have somewhere in between. You try to come between the stump so that you have a stump all around. So your purpose of preserving the biology and proprioception remains. But even by, your best of intentions, that doesn't happen sometimes. So if it doesn't happen, then you should try to preserve with what Dr. Arvind has said. Now, I personally believe in that. You should try to have a stump all around your ACL rather than trying to keep the stump on one side, come from the back side, and now trying to do it. Because what you're actually doing by this way is you're just creating a good picture in front of you, but not all around your graft, which may not be serving the purpose which you intended to.
Yeah.
So here idea is you are repairing the ACL that you have, because nowadays there is concept of ACL repair also. At the same time, you are augmenting with your reconstructed graft. The only thing, graft diameter should be lesser. It should not be a bigger one. 8 or anything, 8 or 9, something like that. Yeah, sir.
For preserving the tibial stump, you have almost fair amount there. Sequential drilling leaves everything.
Yeah, that is.
You really don't have to
worried about the destructing the
you have
ACL
sequential
footprint.
drilling just like you do in revision cases. Then you can keep almost all the stump in there.
Yes.
Go around that.
Yeah. Same we do in this case. First the bead pin, then the 4 mm, then 6 mm, then 8, 7 or 8 mm. So in that way, you can change little bit direction of your bead pin so that your foot remaining stump is not going to disturb with the remaining. Thank you.
Surface of the reamer. When you're reaming it, actually the reamer should not be seen at all. You just see that into the fibers. And then use a shaver from the tibial end. The shaver is only 4 mm diameter. So you can put the shaver and just peel off some of the fibers over there, and you can pull the graft after that. By that, you can preserve most of the fibers.
Thank you. Okay. So I will be presenting a case. I think it will be an interesting case to all of us. Now here's a young man, 40 years, young, height 177 centimeters, weight 88 kgs, BMI 28.08. Now this fellow has got instability of his right knee for last 22 years. Okay. And that's discussion. ACL complete rupture, instability. When the patient was 18 years old, he sustained a twist injury and he ruptured his ACL. Now from this point, 22 years instability, 40 years at this time, what should we do? Should we go for a reconstruction or plan something else? So,
well, Manish, I think you need to see what is bothering the patient more.
Right.
Is it the knee pain which is bothering the patient more? Is it the instability which is bothering him, or is it both?
okay, sir. So what happened to him? He underwent an ACL reconstruction about 14 years after the injury. But unluckily, the patient sustained a re-injury and he got his graft completely ruptured. And there was a recurrence of instability. The fellow did not want to undergo a revision surgery at present. He presented to us about 7 years after the previous ACL reconstruction, which had ruptured 1 month later. Now from here. Now this is the X-ray of the patient at the age of 32 years when he underwent an ACL reconstruction. That was 14 years after the injury. This was the X-ray picture when the patient presented to us when he was 40 years old. Now, sir, what to do? You can see the joint, how it is.
I think we need to get a MRI and scanogram to see particularly I would be more worried about the lateral compartment now because ACL, you got a lot of lateral meniscus injury and because it's a convex structure, so lateral condyle may damage a lot. So MRI will guide us what next to do.
Right, sir. So this is the MRI picture, sir. Okay. This is the alignment of the patient. He has got a mechanical axis deviation with LDFA of 90 degrees, the MPT 83 degrees, and he has got a posterior tibial slope of 12 degrees. Now we gave him an option. Now he is 40 years old. You can go for a revision ACL reconstruction at the same time with an HTO. The patient was absolutely reluctant that I do not want to undergo a ACL reconstruction now. So what can be done, sir? With this X-ray picture and the patient's instability?
Only option is to correct the slope at the same time you're doing a high tibial osteotomy.
Okay, sir. So we went for a HTO. The patient did not want a ACL reconstruction. So we tried to remove the non-absorbent materials. They were removed. And we did a restoration of the alignment. And that was done in 19th of August 21. The patient started feeling better. I tried to correct the slope, which was 12 degrees. I tried to correct as much as possible, but I could not achieve more than 10 degrees. Right, sir. Right, sir. So once the patient started feeling better, okay, now I'm fine. He had a good alignment. And then he said, okay, sir, I'm ready for the ACL reconstruction. So we went for it. So this was the intra picture. He had a pivot shift grade 2-3. So that was the examination anesthesia of the patient. And this was the intra picture. The graft was passed. And we did an LET as well as the ACL reconstruction. And that was the stability of the knee, intra-op. And the patient had a good outcome. Though he had an osteoarthritic changes of his knee, this is the POD5. And this is the 9 months after HTO. The alignment appears good. And this was the follow-up of the patient. He was able to squat nicely without any support. And the picture is distorted. And I think the gait appears good. The alignment is good. What I want to say is, this is the follow-up of the patient at 2 years. Now he was being tested on an uneven surface on the ground. A good walk. The patient is able to walk nicely. Able to have against gravity. And this is the test of the patient to run on an uneven surface on the ground. So my message is, though it is a neglected case, one should not leave it as such. Try to do something. You may have a good result. Thank you. Not good. Not good. You can see the OA changes. Lateral compartment was better than the medial compartment. There was changes. I would go slightly on the lat. I would not be in the center. The alignment, I would not like to keep it absolutely in center. I would go slightly lateral. Near the tibial spine, laterally.
Somewhere around 54-55%.
Right, sir.
Sir,
So
one
Manish,
question from my side, sir. Here. Sir, why LET was done?
So we were planning a revision ACL. So we thought if an LET could be added, there might be an additional stability.
Hello. You have made it valgus with osteoarthritic changes in both the compartment. Now adding LAT to already
I got your point.
osteoarthritic
I got
lateral
your point. You are
will-
saying that the misalignment would be misaxis would be distributed more laterally.
Yeah, it will lead to
More
early
constraint on the
degeneration
lateral
of the
side. More
lateral side
constraint on the lateral
also.
side. You want to say that?
Yeah, STO's life will be reduced.
I got a
So
point.
That question.
So anything
Well, I
to-
think you can argue both ways. Your concern is very right in stating that there are already some changes in the lateral side. By adding an LET, you're making the lateral compartment more tight.
more constraint.
But his concern is right that he wanted, since a revision ACL, he was more concerned of providing more stability. So I think, you can argue it both ways. There's no something clearly black and white in this. And one more thing, he did an HTO first and then went for an ACL. So I think Manish should be wise that if you can tell us, if you have done an HTO and you're going for an ACL second sitting, you might encounter problem making a tibial tunnel.
Right, sir.
How
Right,
did you
sir.
encounter that first thing? And one more thing, sometimes after doing an HTO, these patients may be absolutely stable and they may not want an ACL reconstruction. So I have two such patients in which we had planned a sequential ACL and they said, doc, we don't want it. Our knee is stable, we are feeling better, the pain is gone, and I do not want an ACL reconstruction. So they were happy with an HTO. So we now do an HTO with an ACL reconstruction in the same sitting, doing it sequentially, your patient may not want it.
Right, sir.
Dr. Manish, you made a new femoral tunnel?
Yeah.
The previous one was, I think, pretty interior.
Yes, I made a new one.
New one.
And While trying to negotiate or making a new tunnel, I landed up slightly, my button landed up on the posterior cortex of the femur. That's fine.
And you left the screw in situ.
I was not able to remove it. I didn't know what kind of implant it. I would like to ask Dr. Amit Joshi. So for what kind of implant was that? Because the patient was operated in Nepal. Long back.
And the tibia tunnel, you utilize the same tunnel.
No, sir. A new one.
Tibia also you made a new one.
Yeah, I made a new tunnel because that I was while I removed one of the screws from the raft, the horizontal segment of the HTO plate, and then I tried to make a tunnel so I could create a new tunnel.
Okay.
Remove the HTO plate or you?
No, I removed only the third screw, sir, the posterior screw.
And so how many days after the HTO did you did an ACL?
9 months.
9 months. I think that would have good enough. You must have.
I could have removed the plate also.
Union of the osteotomy.
Yes, I could have removed the plate
yeah,
also.
And people say that if 1 year down the line, you need to remove the HTO plate.
Right, sir.
So you could have removed
because
the
he
plate
was happy
also.
with the plate. He didn't want to get it removed. So he was I was feeling better.
So who said you need to remove the HTO plates at 1 year? Because we don't remove our plates.
Yes, sir.
at all.
We usually do not do, but people say that if you remove that, it might make a subsequent totally down the line,
True, but-
maybe easy for the patient. So most of the patients do not get it, but yes, there is a school of thought which says that you should remove it once your osteotomy united because now it has served the purpose.
Just means an additional surgery.
Thank you, sir.
Thank you. So coming to the next topic, the failure of ACL reconstruction by Dr. Ankit Goyal.
Good morning, everyone. I first like to thank Dr. Arvind, Dr. Mukhopadhyay sir, Dr. Vikas sir, who has invited me for the conference. And actually, it's a privilege for me to come here because Arvind and Himanshu both were my senior residents along with me when the new SIC started in 2010. And it's really, looks good कि ये कहाँ से कहाँ पहुँच गए हैं. और I was looking forward to coming to Patna and to attend this conference and the amount of work Arvind is doing, and it's really feels good for them. Now, coming to today's topic, there are two topics. Dr. Subramaniam also going to speak on the same topic, the next one. So let's make it short and crisp. So we are doing around 300 ACLs in our sports injury center in a month. And we do around 15 to 20 revisions a month. Worldwide, around more than 400,000 ACL reconstructions are done. And the failure rate is around 3 to 15%. The most common reason of failure is femoral tunnel malposition, which causes 80% of the graft failures after ACL reconstruction. And the revision ACL reconstruction, there is obviously 3 to 4 greater graft failure rate compared to the primary ACL. And after first revision, the second revision, there is a 26-fold increased failure rate as compared to the first revision rate. So this is various causes of failures of ACL reconstruction. The most common reason is the fixation, screw divergence, graft tunnel mismatch, slippage of the soft tissue grafts, ingrowth, autografts, harvest morbidity, strength loosening, impingement, non-anatomical tunnels, unrestricted rehabilitation protocols, infection, excessive graft stress due to malalignment, and our surgical limitations. The most common the causes are femoral tunnel and tibial tunnel malposition. If you put it to anteriorly, the tension changes in flexion. If you put it vertically, it causes rotational instability. Tibial tunnel malposition anteriorly causes excessive graft length changes in flexion, and posterior causes graft tension changes in extension. Inadequate nosplasty leads to graft impingement and inadequate graft tensioning, unrecognized collateral ligament injury, unrecognized control of meniscal injury, or poor fixation may all cause the failure of the surgery. So what are the challenges we are looking when a patient comes to us with a failed ACL reconstruction? Graft selection. Most of we are doing hamstring graft. So what graft are we left with? Either we can take out the contralateral hamstring graft. Should we take out the peroneus graft? Should we do a BPTB graft? Depends on surgeon to surgeon. At our center in sports injury, we generally do a soft tissue graft procedure because the patients who are coming to us are mostly wrestlers or they are from paramilitary. So they are not very eager to get the BPTB because they may or may not have anterior knee pain. Secondly, what we try to correct the posterior tibial slope, whether it's the first revision or second failure, we always check for the posterior tibial slope. The normal posterior tibial slope is around 7 degree. Any posterior tibial slope which is 12 degree or more, we need to correct it. Modified Lamar procedure or ITB, do we need to do it in every revision case? Yes, we do it in most of the cases. Most of the patient is a hyperlax patient or patient has a high demand athlete. We mostly we add a LET. Obviously, cost constraint at our center is an issue. If the patient agrees, then only we can do it. Then there is internal bracing. Do we use a fiber tape in a revision case to add a strength by doing a differential tensioning to add strength to the graft? Timing of the surgery, when should we operate? Do we a one-stage surgery or two-stage surgery? So it depends. There is no clear-cut guidelines, frankly, on it. It depends surgeon to surgeon, and literature is divided on a particular strict protocol which needs to be followed. But some things we need to see in every patient: gait and limb alignment, look for signs for infection and previous skin incisions, range of motion, look for any loss of extension, assess patellar mobility, quadricep strength, thigh circumference, do proper examination, anterior draw, attachment, pivot, posterior draw, look for collaterals and mostly posterolateral corner injuries. A standard AP radiograph should be done to see the presence and location of the hardware. Assessment of the tunnel malposition and widening should be done. And if limb alignment is in doubt, we should definitely do a scanogram. CT scan provides the most precise evaluation of the bone tunnel enlargement, calculation of the entry points and position of the tibial and the femoral tunnels. It provides a template for planning a new tunnel and calculation of the posterior tibial slope, MRI, integrity of the graft, status of meniscus and cartilage, and with PCL and collaterals. So decisions. What decision do we do? Tunnels are not dilated. If tunnels are not dilated, they're anatomical tunnels. We can do a single stage procedure by removing the hardware. And the tunnels are non-anatomical, then single stage, bypass the hardware and do the surgery. Two-stage surgery can be done. First stage, bone grafting with the removal of the hardware, and second stage, after 6 months, we can proceed for the ACL reconstruction. What are the advantages of single stage surgery? Single surgeries avoids the need of a second surgery. Adequate bone quality must to allow the placement of tunnels with acceptable size and location. The primary thing is when you pass a graft, there should be healthy bone all around. It requires advanced surgical skill. A surgeon must have ability to bypass the existing tunnels and fill the bone defects with adequate density and strength. Staged procedures ensure adequate healing of the bone tunnels, which will then provide a good bed for fixation of ACL graft. Indications are widening of the tunnels, excessive amount of bone removed during the hardware extraction process, tunnel confluence or large defect. So I'll be presenting a couple of cases. This is a single stage revision ACL which we did. We calculated a posterior tibial slope which was 7 degree with a tibial tunnel dilatation of 9.2 millimeters with the screw in situ, so it was not very accurate, and femoral tunnel dilatation of 10.1 millimeter. So this was the case. We removed the hardware from the tibial side. We freshened the margins, removed any ethibond from there, went inside the arthroscopy. So as you can see, this area here, this was a femoral tunnel. It's very vertical and an interior. So we did an extensive notchplasty, which is a must for every revision case to remove any anterior or lateral notch impingement. Then we put after doing an extensive notch impingement with the help of an offset, we did a femoral tunnel draining. We used a suspensory fixation. We checked for the bone tunnel. There is a healthy bone all around in the tunnels. Then we did tibial tunnel and then put the graft. This was the final picture after doing a single stage revision ACL. We didn't remove the femoral screw as it was not coming in our way. This is a case of a revision of a two-stage surgery. This is the first stage surgery which we did of a patient with a posterior tibial slope of 7 degree with tibial tunnel dilatation of 10.3 and femoral tunnel dilatation of 11.5. We thoroughly debrided the tibial tunnel. We took out the graft from the iliac crest. freshened the tibial tunnel completely, and then packed it with the cancellous grafts, used an impactor. I'll just take a couple of minutes more. I'm sorry. We packed the tibial tunnel with the cortilocancellous grafts, impacted it, then went inside, checked if there is no graft is coming inside the tibial tunnel. So there is no graft which is communicating inside the tunnel. Then we did an extensive notchplasty. Again, after passing of a drill pin kit, after recognizing the tunnel, we did a drilling with 10mm graft, a 10mm reamer. This is the graft we prepared, and we had 2 threads passing out from the graft. We passed it through the femoral tunnel. And this was a picture. I normally put an endo button along with the graft on the femoral side. So this was the second stage. Another patient, I'm sorry, I didn't had the second stage, but then as yet for that patient. This patient was operated again 2 times at sports injury center. This failed. We did a first stage by putting a graft on both the tibial and the femoral tunnel. And this was his second stage 6 months after the first surgery of bone grafting. So as you can see, the femoral tunnel is completely filled with the bone graft. Again, we did an extensive notchplasty. Just 1 minute. I just want to show you that how beautifully the bone tunnel heals. We have a tibial offset. We did the drilling. So as you can see, there's a healthy bone all around. And this was a bone plug initially which was put, which has healed beautifully. And this was the graft. So this was the X-ray. We removed the hardware from the femoral side. So take-home message: revision ACL reconstruction results do not match those of primary ACL reconstruction. There's a meticulous preoperative planning and analysis of the cause for failure is necessary. Depending on the type and location of the fixation, the location and size of existing tunnels, and the quality of the bone, the surgeon must be prepared to use a number of different techniques. The goal must be able to choose an appropriate graft and fix it in anatomic position in good quality bone, similar to the primary procedure. Thank you.
Thank you, Dr. Goel. Next speaker is Dr. K. N. Subramanian. He is talking about revision ACL planning makes precision.
Morning all. Thank you, Chairperson. And thank you, Arvind and team Patna for inviting me. I think almost is going to be a repetition of what just Ankit has told about revision ACL reconstruction. I'll try to show 1 or 2 cases which might be helpful to understand how we plan it. I think we all know that revision is increasing. You can at least about 4 to 5% of cases which are being done primary will come for revision at the minimum I'm talking about. They are even more than 10% are being revised. At least is a minimum of 4 to 5% are there. And I'm not going to talk about the infection scenario because that's entirely a different ballgame. We are going to talk about only the non-infection scenario. The main reasons for ACL failure, I think at this time we all know that it's a malposition of the tunnel, which is a very important reason for the ACL failure. And out of which femoral tunnel is malposition about 83% and tibial tunnel is around 45%. And re-trauma, miss-associated ligament injury, inappropriate graft sizing. And many times you will see there are combination of 2 or 3 factors together. It's not the one reason, there are 2 or 3 reasons why it failed. First thing very important in making planning is clinical exam is very, very important. And of which, for example, this particular case, we see there is they put a different type of scar there. Scar is also very important because normally we do a vertical scar or a oblique scar. Here you have a very abnormal scar. That is also very important. You go think about revising. And another patient has got a missed ligament injury. So he has got a MCL injury also, which has been missed during the first ACL surgery, which that's the reason it failed. So it's important to assess what the full clinical findings of that particular patient in order to make a proper planning of the revision. So this particular patient has had a root repair and ACL reconstruction done with a varus knee. So in fact, it failed in a short duration of time, and what he needed is a high tibial osteotomy and revision ACL reconstruction. So it's important to make a full clinical assessment to see whether we are addressing with a proper case of instability along with other ligament instability, or how is the alignment. All should be taken into account when you are doing these cases. Point number 2 is very important to know what happened during the previous surgery. What is the graft type used, graft size, type of fixation they have used, and the screw button. If you have the previous OT notes, that will be really useful for when you're planning for the revision. Next is point number 3 is investigations. Investigations, I do all patients coming for do blood test to rule out we are not missing infection. So CRP is a must for all of them. If the CRP is high or any reason it is having borderline, be always ready to deal with the patient who has got a hidden infection there. If there is a hidden infection, we will not incorporate it, will fail. The next is X-ray, MRI, and CT scan, and look for CT scanogram if we think there is an alignment issue also. I think you all agree that we do MRI scan. What do you look for in MRI? In MRI scan, what do you look for in MRI? Acid ligament injuries, yes. So, yes. So, X-ray is the first thing. In this particular patient, there is actually a very small malposition in the femoral side. In the tibial side, you can see the red line is showing the original tunnel. Where the tunnel should be is the orange line. So there's a slight malposition in the X-ray itself. And the next important thing is MRI. In MRI, what I see is slightly apart from the graft, which is not integrity is not there, or graft rupture is there, other associated ligament injury. You can, in fact, if you go and see properly, you can assess the precise position of the tunnel. There are good papers published in this, and we actually look for this in almost all the patients who are coming for revision ACL. From the anterior position of the tibia to the anterior graft position, we make a line and make a full horizontal tibial line. You can divide between A by A, and you can see normally it's around 40 to 48% is a normal ratio. For this particular patient, about 58%. We can very well see it's anatomically malpositioned tibial tunnel. As well as even the femoral tunnel also, you can measure in the same way. You can almost precisely tell that, yes, this tunnel is malplaced, or is correctly placed, or partially malplaced also. We can very well say this from the MRI itself. Next important thing for him is a CT scan. CT scan is a must for all the patients who are coming for revision ACL. The not reason just to assess the tunnel, to assess the width of the tunnel. Because the width of the tunnel, if it is more than 12 mm, then it means that you may not be able to address it in one single stage. You need to have a bone graft and also do it a second stage. And next thing is important to see the tibial slope also. If the tibial slope is very bad, or if it is having a altered posterior tibial slope, then you need to correct that slope also. Otherwise, your ACL is going to fail. So, for example, if you look into this particular patient, you can see the ACL is very vertically placed. The ideal tunnel should have been in the very low, but this tunnel has been placed very high. So that is one of the reasons it's failed. And when I went in, I found out the original tunnel was the place where my trocar is showing. Where we have put is a new tunnel is far lower than the anatomical area. So if it is a non-anatomically placed tunnel, it is much easier to revise it. If it's anatomically placed tunnel, then you have to, the graft diameter and the width of the tunnel is very important. In a place where there is partial, then that is a big trouble, where when you are putting your tunnel reamer in, you might suddenly make it a very big hole. So you have to make sure the plan is done very precisely in order to make sure that we don't miss that partially anatomically placed tunnel. So in tibial side, this patient had a slightly posteriorly placed tunnel. So we are doing anteriorly by serial reaming. So slowly trying to bring the position of the tunnel slightly anterior by doing 6 mm and then 8 mm, then 9 mm. And you can see that after doing that, you can see there are two tunnels, which is the original tunnel was placed little medially. We have placed the tunnel slightly anteriorly. And there is a small bony bridge only. One simple trick of avoiding the bony bridge to break is what I do is keep a reamer onto that original tunnel. Like keep a 7 mm reamer or a 6 mm reamer, so that when you are reaming the new tunnel, the tunnel wall will not break. If it breaks and you are ending up with a very big tunnel width, then you are having the use to think about putting a 12 mm, 13 mm screw. So this is a simple trick that you can use to not to break the previous wall. So that's previous vertically placed graft. The graft should look horizontal like this. Normal ACL is actually a very horizontal structure. It's not a vertical structure. So at the end, it should look very horizontal like this. And that not only gives a vertical stability, it gives a rotational stability. That is a more important function of the ACL than giving the vertical stability. So BTV is a preferred graft. But in cases where I think if you have a choice of doing same soft tissue graft in anatomically placed channel, then use LET also at the same time. Because I prefer to do both at the same thing. ACL plus LET, hamstring graft means put LET also at the same time. That gives a lesser chance of refailure. So next important is 3 months after doing a revision ACL after and lateral extra-articular tenodesis, giving good stability. Another important point to mention is, I think Ankit has already mentioned about bone grafting. Anyone having a bone tunnel diameter of more than 12 mm or 13 mm, then think about doing a two-stage. Do a first bone grafting of femoral side or whichever side the tunnel width is bigger, and then do the second stage in about 4 to 6 months time. Next important thing is think about malalignment. For example, this particular patient has got a 12-degree posterior tibial slope along with the ACL degree which has failed. So here what we have done is done ACL reconstruction with osteotomy, where you are not only correcting the varus and also correcting the tibial slope. So when you are doing ACL and HTO together, try to keep the tibial aimer and make a marking of the place where your beat pin is going to be, and then you can do the HTO. So that your HTO osteotomy side will not go and hit on the place where your future tunnel is going to be. It's a simple trick to avoid the tunnel and the osteotomy side together. So it's simple dictum is if you correct 1 mm on the slope, then you can actually achieve 2 degree of correction. So here this patient we have done about 9 mm anterior and 12 mm posteriorly, so it gives approximately 6 degree correction. You can see the before correction the ACL was very lax. Once after correction the ACL becomes suddenly tight. The slope correction actually makes a big difference in patients who are having coming for revision ACL with slope problem. So to summarize, clinical assessment is very, very important. Blood parameters is very important to rule out infection. And X-ray is important to do alignment, degeneration, tunnel position, and implants. MRI to assess the precise position of the previous graft. And CT scan is to assess the tunnel width and decide on single stage or two stage depending on the tunnel width. And graft selection is important. Revision is go for BTB. If you're doing hamstring, do hamstring plus another extra-articular procedure also LET like that. Always aim for getting tunnels in the correct position to start with, and you don't have to go for revision at all. Thus, I conclude my talk. Thank you very much. If you're not member of Indian Ortho Society, please do make it soon. Thank you very much.
Thank you, Dr. Subramaniam. Since we had discussions in between while during presentations, we'll skip the discussion. Now, may I call upon Dr. Shekhar Srivastava to present his. Correcting the flow and the same time correcting the curve. Because with the median opening bend, inherent tendency is there and increase the flow. So what is your tips to your flow? You are going to go to
are correcting the varus with a medial open wedge, what are the trips and tips to correct the posterior slope also at the same time? Because with the medial open wedge, your slope will increase. That is the inherent tendency for medial opening wedge.
So when you are having planning for slope correction also, you are trying to put your plate either anteriorly or posteriorly. So for example, if you are doing 9 mm gap anteriorly and 11 mm gap posteriorly, then you keep it, there is a wedge sizer, osteotomy wedge sizer, that you can measure it 9 mm, 12 mm in that, or whatever size you want, you can measure in that. And try to keep it in the place where your plate is not going. For usually I put the plate slightly posteriorly and keep that wedge sizer anteriorly, the desired width. So that is a simple way of doing differential slope correction. So
It's about the correction.
I think part of it is the medial collateral ligament, and you need to release that to be able to distract it adequately posteriorly. So very often you actually, in fact, if you look at the recommendations of the open wedge osteotomy group, they actually say to divide the superficial medial collateral ligament completely to get that slope corrected. So if you want the posterior wedge to open more, you need to release the medial collateral ligament.
So my question
That is
is
a very
to,
good point, because in a TKR, we always do medial release when you are having varus knee. That similar step has to be carried out in all the patients who are having varus correction for HTO, because you need to do the medial release. And at the end of the procedure, when you have done the correction, we feel that MCL has become very tight also. The release ligament has become very tight also.
I think we'll discuss further after this lecture, then we'll have a lot of time for discussion.
Okay.
So, Dr. Shekhar, please.
Thank you. First of all, I congratulate Dr. John Mukhopadhyay, Dr. Arvind, and Team Patna for organizing this news meeting. The audience has been very knowledgeable and very receptive, and the discussions have been great. I thank Dr. Subramaniam and Dr. Ankit to build up my talk, because they have discussed about LET, using LET in their revision procedures. So what is the rationale of using LET procedure, or what is extra-articular tenodesis and why it should be done? It's not moving. Basically. Okay. Okay. So you can see these videos of ACL injury. And in almost all of these videos, you will see that it is the rotational force which is causing the injury. So as we think that ACL gives anteroposterior stability, but during all these discussions, we have seen that it also provides a lot of rotational stability, and it is the rotational force which is basically causing the ACL injury. Now, when we do ACL reconstruction, the purpose of the ACL reconstruction is to provide anteroposterior stability as well as rotational stability. The problems of, so earlier when the tibial ACL reconstruction was done, where the ACL was quite vertical, so it provided anteroposterior stability, but the rotational stability was not there. So then came your double bundle ACL reconstruction as well as anatomical ACL reconstruction. So increased graft obliquity. So nowadays, as we see that the graft is much more horizontal, much more oblique, to not only provide the anteroposterior stability, but as well as rotational stability. But still, many studies have shown that the anatomical ACL reconstruction as well as double bundle ACL reconstruction fail to provide adequate rotational stability in few selected patients. Pivot shift remains positive in almost 22% of patients who have undergone ACL with hamstring and almost 16% of the patient with patellar tendon. And many studies have shown that the rate of grade 2 pivot shift is close to 20%. So Ellison provided this concept. So he told that ACL is the hub of the wheel, and it is easier to control the rotation of the wheel at its rim than at its hub. So we also see that in our vehicle, the brake pad is not in the hub, it is at the periphery, because it is much more easier to control the rotation at the periphery than at the rim. So that's why the longer lever arm exerted by peripherally based extra-articular reconstructions theoretically provides more resistance to the torque. So that gave the concept of providing a support to ACL peripherally. Now, historically also, we know that the previously Macintosh procedures were done. So these were also providing stability laterally. Then if you see the anatomy, that also shows that the ACL is supported by lateral structures. We all know about ALL. We know about the Segon fracture, which is nothing but avulsion of the middle third of the lateral capsular ligament. And it is proposed that if there is a big fragment, then it needs to be it needs to be repaired again. So lateral extra-articular tenodesis, it's not one procedure, there are many procedures, but the purpose of all this procedure is to provide stability, rotational stability laterally, which protects your ACL also. And it has been shown that it decreases the stresses on ACL graft by close to 40 to 45%. So do all cases need LET? No. There are few criteria where you may think of LET. So it has been shown that there are few criteria, and if you have one of the main criteria or two secondary criteria, then you should seriously think of adding LET procedures to your primary ACL procedures. So what are those? If you are doing revision ACL, if your pivot shift grade is 2 to 3, Segon factor is there, patient is into pivoting sports, patient is into high-level sports and is having hyperlaxity. If he's having contralateral ACL rupture, the Latchman test is more than 7 millimeter, age is less than 20. So if all these factors are there, then you must consider adding LET to your ACL reconstruction. So if I think of a primary ACL reconstruction where I will consider LET, that will be perhaps a person who is less than 20, who is hyperlax, who is into pivoting sports. If you do Latchman, the Latchman is more than 6 to 7 millimeters. Pivot shift is more than is grade 3. So these are the patients where I would seriously think of doing LET along with ACL reconstruction. And of course, in revision scenario, it is almost always added. Now, how do you do it? Well, if we talk of a modified Lemire technique, which I do, will explain it in this talk, or else you have other techniques like Ellison technique. So we'll consider both of them. So this is a case, a 20-year-old gentleman, failed ACLR, my own case, no associate ligament injury, a football player, no infection, Latchman is positive, pivoting grade 3, and genu recurvatum 10 degree. So this patient came back to us a year after surgery, and he was having instability. He gave a history that 2 months back I was playing and I fell down. So you can pass it on as re-injury, but deep inside we know that perhaps the primary ACL was not working so well. So these are the MRI pictures, and you see that there is you can't see ACL and there is comma sign of the PCL. The tunnels, it seemed there was no tunnel dilatation. The tunnels seemed to be in proper position. This is the clinical examination. You can see that the Latchman is almost close to 10 millimeter. And pivot shift was grade 3. So we discussed with the patient. There was no sign of infection. There was no tunnel widening. So the plan was to do a single stage revision ACL and added with modified Lemire procedure. We decided to take the peroneus longus graft for this patient. So that's the intra-articular picture. You can see that this is just a remnant of the previous ACL. Instead of tear, I think it has stretched out. The tissues were debrided so that we could prepare a tunnel. That's debriding the tissue on the medial wall of the femoral condyle. And when we considered the position of the femoral tunnel, it seemed to be in good position. There was not much of tunnel dilatation, so we decided to use the same tunnel. The graft was augmented with a tape. It was a revision scenario, so you want to use everything. You don't want another failure in your hand. But the quality of graft was quite good. So that's the intra-articular part after the ACL reconstruction was done. The position of the graft and the orientation seemed quite okay. Then we proceeded for the extra-articular tenodesis procedure. So this is the Gurdjieff tubercle. This is the lateral epicondyle of the femur. An incision was made from Gurdjieff tubercle, approximately 2 to 3 centimeter proximal to the femoral condyle. This is a iliotibial band which was cleared, and a central 1 centimeter band of iliotibial band was harvested. Now, whip stitch were done on the proximal aspect. The length of this iliotibial band is approximately 8 centimeter. Then you have to identify the LCL. Sometimes it becomes difficult to identify the LCL, so you can put the limb in figure of 4 position and then it becomes taut. So then you can mark the anterior and posterior border of LCL. So this is the LCL. You pass the graft beneath the LCL or medial to the LCL, and then you fix it slightly proximal and posterior to the attachment of the LCL. So here you have to be careful that you don't converge with the tunnel of the ACL. So one tip is that you guide your tunnel more anteriorly, because your ACL tunnel is coming from the posterior aspect. If you guide your tunnel anteriorly, then you will avoid the femoral tunnel of the ACL. And then you fix the graft in almost 30 degree of flexion. The limb should be in neutral rotation. Again, one thing which you have to take care is that you should not over constrain the joint. This ligament just acts as a check ring, so you don't have to pull it too hard. Now, instead of screw, one can also use anchors. If you're using an anchor, then after fixing, you can again bring it back and you can fold it back and then stitch it upon itself. So this is the button of the previous ACL, and that's the new ACL. The technical concerns are convergence with the ACL femoral tunnel or over constraining the lateral joint. So that must be avoided. And these are the clinical pictures of the patient. So currently ACLR technique failed to adequately control rotation in few selected cases. Laterally placed graft may provide better rotational control due to enhanced biomechanical advantages. But you must remember that LET works only in conjunction with ACL and not alone. So these are the few indications for doing LET. Thank you.
Thank you, Dr. Shekhar. May I invite both the speakers, Dr. Subra and Ankit? We can have a discussion if there are any questions. Subra, please come forward. Kanchanda, from the era of transtibial to anatomical, what Subra was pointing that 80% of cases, the failure is because of the malpositioning of the femur tunnel. But the incidence of re-tear, what was there at the time of transtibial and at the time of anatomical, has not much changed. So do you think there is something else which we are not able to understand still?
Very interesting point. when we started to go trans-tibial for the first time around 2006-7, not having read literature, not knowing history, we ran into a lot of trouble. For the first time, I started to have a lot of early failures. Then I looked back at the Scandinavian registry. And in 2007 Scandinavian registry, they showed there was 2.5 times more re-tear with the then anatomical repair. They found out that they were reconstructing more of the PL bundle and less of the AM bundle. The other study by from Britain, I forget the name, a long-term study, and he found that the survival rate of slightly more vertical ACL, which is more inherent with transtibial, is more than that of the transtibial or more horizontal one. So they found the survival rate of Haddad, this is by Faraz Haddad, again, a systematic review. Survival rate of transtibial in the long term, they found to be slightly more when you don't mix apples with oranges, when you don't mix BTB with hamstrings or allografts. And there have been other findings about why we still have anything from 5 to 20% failures. I think there are lots of hidden things we don't know. And one, I think, is we miss a lot of additional injuries.
So our center used to do one of the largest number of double bundle ACL reconstruction sports injury center, and exclusively for 7-8 years we did a lot of double bundles. And after that, a lot of papers also started to come on double bundle. So PL bundle MRI was done after 6 months, and up to 65 to 80% tear rate was noted in the PL bundle. So PL bundle, what we were doing was more of a rudimentary thing. And again, we have gone back from double bundle to single bundle. So we went from transtibial to anatomical to double bundle. So now we are more into anatomical double bundle. So we have to preserve the remnant from the tibia and femur and make a more anatomical.
Dr. Sekhar, can you recommending do the Lachman test and pivot shift test in primary ACL reconstruction for sake of LET?
Post reconstruction?
Post primary ACL reconstruction, you are recommending Lachman test and pivot shift test?
No.
To check for
that is your pre-operative consideration.
Pre-operative.
Yes.
Consideration.
So
yes.
These are few red flag signs. If you get a young patient who is less than 20, who also had, suppose, a contralateral ACL tear, who is hyperlax, who is into pivoting sports, and in these patients, if your Lachman is more than, say, 6 to 7 millimeter and pivot shift is grade 3, explosive pivot shift. So these are the cases where you should be ready for LET. So these are the pre-operative considerations.
So all your
even
cases,
they say that if there is a family history of ACL injury, that is also one of the factors.
So all your revision cases, you are using internal bracing?
No, not necessarily. See, when you are in a clinical practice, you don't want another failure. So maybe in that case, I will add it if I have any doubts. But it's not that we use internal bracing, and that is not. Here we are not using it as an internal brace. It is just to augment the graft.
Augment the graft.
Yes.
Okay.
Sekhar sir, what's your take when you're doing a revision if it's a bone patellar tendon graft? Why are you not doing the LET? Because the principle remains the same. The knee is pivoting. You are doing a revision. It's just that because you are thinking that the bone is going to incorporate well. Is that the thing that you keep in mind? And if that is the thought, you don't believe in your hamstrings or peroneals?
So I don't do bone patellar tendon graft. If required, I take quadriceps graft. And if the indication is there for LET, then I do LET along with quadriceps graft also.
So Ankit, considering your study like posterolateral graft failed more as compared to intermediate, would you like to cheat while you are doing your surgery, anatomical ACL reconstruction more toward AM rather than PL? So again, more vertical rather than truly horizontal?
So we constructed an AM bundle. That's as simple as that. We are not complicating the things too much. We make an AM bundle. PL bundle obviously prevents rotational stability. So as Dr. Shekhar said, in patients with pivot grade 3, So instead of making up femoral tunnel AM or PL, we add a ACL along with the LLT for the rotational stability. And coming to Himanshu's question, that why do we not do LET along with the BPTB? It's a difference of soft tissue graft and a bone with a BPTB graft is not as, can be stretched as compared to a obviously bone healing with in a revision scenario in a BPTB graft is much better. The flexibility, the tensile stretch होने के जो chances है ज़्यादा BPTB के कम है as compared to hamstring. तो LET के शायद हम लोग better avoid कर सकते हैं BPTB के.
Sekha sir. So nowadays incidence of doing LET with primary ACL is very high. So what is your teaching part when it's get failed?
When
suppose primary ACL with LET get failed and patient came to you, what you do in that case?
Well, I think then one has to look into bony factors like your tibial slope.
No, it's about the revision case. You are going to do the surgery of that case. The patient who has primary ACL reconstruction at the same time LET was done and that failed. Now what you will do in that case?
So no, you have to look into the cause of failure.
Yes.
So if there was a technical problem.
So maybe my question make it simple. In failed LET, what is your second thing?
Your question is in an anatomically placed.
Everything is fine.
Tunnel,
Your ACL failed, LET failed. So what is your next? Patient came to you for revision. Doctor साहब सब कुछ ठीक है? No. ACL initially approach is in failed primary ACL. You do ACL along with LET.
Okay,
if there is any.
So a primary ACL with LET fails.
Yeah.
And slope and everything is fine.
Other thing is fine.
Okay, then you again go for the same thing. Perhaps I would use a more robust graft like quadriceps. Now you have already done LET, so you can go for ALL in this case.
Yes. So I think Arvind, in these kind of cases, often you have missed something. And the commonest is ramp because the knee pivots when you have a ramp behind. And often we don't go back and look after the ramp. We do an ACL and an LET and leave the ramp like that. So that's one of the cases where we have
recently revised a case, young patient, 18-year male, operated for ACL with LET 1 year back. So I just do the ALL. That you have option along with the, if LET fail, you can do ALL along with revision ACL at the same time. So don't forget ALL. Message is that don't forget the ALL if you are looking for LET modified lemma. So LL is still alive. You have option for that.
Also, don't forget that the second injury may have been a definitely big injury.
Absolutely.
Because everything was all right.
Absolutely.
He tore his native ACL because of a significant injury. A very large number of our revision ACLs are now because of significant injury as opposed to technical difficulties that had happened earlier.
Absolutely. So I think if it's an injury after 2 years, probably it's due to trauma and you have to consider it as a normal.
Arvind, मैं उस केस के अंदर
But I think
मैं BPTB करूंगा.
If a person
graft choices जो हैं हमारे पास कम है. हाँ, मतलब because soft tissue grafts तो fail होने के chances हैं.
And Ankit, revision में I use almost all my revisions at BTB, and I do LET all the time. And there's nothing that says you should not do it. And to answer to question you another way, आप कह रहे हो कि BTB graft is so much stronger, तो primary क्यों नहीं करते हो सब BTB?
I think
wonderful results.
Yeah, that's.
मेरे सारे फुटबॉलर का वही करते हैं.
So given a choice, I would do BTB in all my patients. I do a lot of BTB in sports person. But I think for low demand individual, I think hamstring or peroneus is a good option. Yeah.
So the only reason BTB is that anterior knee pain, all these are there. Rehab is little slower than hamstring.
I think anterior knee pain is equally common in hamstring as well.
Otherwise, BTB actually very good graft.
Yeah, Dr. Ankit, you shown the revision first stage you have grafted, and after how many days you did the
6 months.
6 months. So during this time period of 6 months, from stage 1 to stage 2, how you mobilize the patient so that you will avoid meniscal and chondral injuries, and how you
6 weeks I do non-weight bearing, no knee bending for 6 weeks, and then I mobilize the patient properly, just 0 to 45, 45 to 90 in 120. Another
So
6 weeks.
6 months non-weight bearing?
No, 6 weeks. 6
6
weeks
weeks.
तक मैं no knee bending, non-weight bearing करता हूँ. 6 हफ्ते के बाद 0 to 45, 45 to 90, 120 every 2 weeks. और 6 हफ्ते के बाद surgery के बाद full weight bearing.
So why non-knee bending? How does graft?
कुछ नहीं सर, बस ऐसे
What's
ही.
the problem with bending the
कोई
knee?
रीजन नहीं है, बताना है बस आपको. कोई रीजन नहीं होता.
Even non-weight bearing, you can understand.
ग्राफ अपनी जगह से हिलना नहीं चाहिए. ग्राफ अपनी जगह से हिले ना बस.
No, even weight bearing can be done because it is just
Yeah.
putting in the tunnel.
Yes, right. ये तो अपने जान बचाने के लिए बस.
Yeah.
I think
There's two questions quickly. Yeah.
So
और अच्छी फाइब्रोसिस हो जाएगी.
I have a question with Shekhar sir. Sir, what's the role for any role for superficial lemurs, especially if a patient is having grade 1 or grade 2 LCL sprain? Passing the LET superficial to the lateral collateral ligament, provided patient is having grade 1 or 2 sprain.
Okay.
It's kind of ALL. I mean,
Okay,
you
but
don't pass.
there's
with the
nothing
ALL.
grade 1, grade 2 sprain, that's just a radiological thing that they report. You need to see whether the latchman is positive patient has instability or not. And for as Dr. Shekhar said, there are different ways of doing LET. You do a Lemass, people pass it above the LCL also, people pass it below. It's just a technical thing.
So that's what if the LCL is passed superficial to the LCL, so is it similar to the outcome? Is similar
It is
to
still, you are still tenodising it.
Okay.
So it still works.
Dr. Amit.
I think I'll go again back to the pivot shift as Dr. Shekhar said that pivot shift, high grade explosive pivot shift is the main thing. But suppose you go inside grade 3 pivot, you go inside along with the ACL, there is a ramp tear. There is a big ramp tear. Now you repair the ramp tear, you'll still continue with the LET or you'll now do not do the LET?
I'll still do it.
I just want to know from the faculties as well.
I will not do. It's a grade 2 pivot. I would just because the ramp is the reason for that pivot. So pivot is
gross pivot. But Sheetal,
it's explosive pivot.
explosive pivot is not
Explosive pivot. I would go ahead with LET only if patient is a high demand. Otherwise, the ramp repair is sufficient.
What I want to bring a point that it's not only the explosive pivots that will decide either you do a LET or not. There are so many other things that will also should be taken into consideration. So if you say that if there is a explosive pivot, grade 4 pivot, and then you do LET on everything, then it doesn't match with what recommendation literature has to recommend.
So Dr. Amit, still the problem is we are not able to quantify the pivot like we are being able to do for a valgus and varus stress views. For the X-ray, we know that it's a superficial MCL, this is POL. Same thing we are not able to quantify. So once we are able to quantify that pivot, we'll be able to judge better that this much is the pivot. So do this much is the pivot. So I think still we need to work on the quantification of pivot.
But there are studies which say that if the patient has a ramp tear, they'll have an explosive pivot as well.
Absolutely. So I will go ahead and do a ramp repair in the sleeve low demand patient.
As you were saying, pivot is a very subjective, isn't it?
No,
Subjective.
yeah.
Obviously, it's a
It's a
grade 3
subjective.
means we all accept it's grade 3. More than grade 3. We don't know how to assess it so far.
Yeah, still we need to quantify it.
Dr. Subramanian sir. So infection is one of the cause for the revision of the ACL. So how we take the infection and in one stage or two stage you are going for the ACL revision? ACL
Once we suspect infection, if we identify it in very early stage, for example, within 2 weeks or 3 weeks, then you go for a one washout and try to retain the graft and see how the things goes. But if they are not getting better even after one washout, then you take the graft fully out, including all the foreign materials, under button, screw everything out, do the reaming inside, and then give IV antibiotic for until the CRP totally comes down, wait for 6 weeks. Many times the patient will not come for revision at all, second stage. I hardly done only 2 cases so far who had infection in the past and come for second stage revision. I'm talking about throughout 10 years. I have hardly done cases. A lot of patients don't come for second stage revision.
Thank you, Dr. Subramanian. I think we'll just conclude the session here and we can continue the discussion.
So one question, sir. For the benefit of the house, so can you differentiate between the modified lemma and the lemma? What is the basic difference between them?
Can anyone? I do modified Lamar.
So Lamar was originally described.
So what Lamar had done?
Lamar had actually Yeah. Lamar used to suture the femoral fixation point was different. He used to drill a bone tunnel and then suture pass the tunnel like a hook around in the femoral tunnel and suture it back on on itself.
Lamar, he passed it beneath the LCL, then flipped it back and then sutured it
I
back.
think that Dr. Ankit is right. He used to make a tunnel through the femur, a curved tunnel, and then bring it back and then suture it.
Yeah.
Okay.
That was a Lamar and then modification.
And the modified Lamar, I think it's just through the under the LCL, then suture it back or on the femur.
Yeah.
Good afternoon, everyone. Now we are moving on to the next session on PCL session. And to chair the session, I would like to call upon Kanchan Bhattacharya, sir. For the next session, sir, we have Dr. Kanchan Bhattacharya, sir, on the stage, sir. Please, sir. Dr. Rakesh Agrawal, sir. Dr. Ankit Goyal, sir. Dr. S.P. Gupta, sir. Dr. S.P. Gupta, sir. And Dr. Manoj Chaudhary, sir. For the PCL session, we have the first one in a case discussion of PCL spine avulsion by Dr. Siddharth Agrawal, sir. Siddharth, sir.
Good afternoon, everybody. I would like to thank Arvind and the team to invite me for this conference. I'll try to keep it a simple case-based talk. We all encounter PCL avulsions in our practice, so I'll just briefly touch what it is. The classification, it has 3 types depending upon how much it is displaced. Quite similar to ACL avulsions. The evaluation of PCL avulsion is the most important part. The clinical part, we have a posterior sag and posterior drawer, which is positive. Calf pain and bruising is something which really is a giveaway in clinical examination. The patient says, "Ki calf mein pain hai, piche dard hai." So that can alert us about a possible PCL injury or a avulsion injury. X-rays, be stressful that you want an exact lateral view. For all spine avulsions, be it anterior or posterior tibial spine avulsions, have a dead lateral view. Stress on a radiographer that you want exact lateral. Don't compromise on the lateral view. MRI is required to see the integrity of PCL and the other associated injuries. And in case you feel there is a combination, do get a CT scan because that can have a bearing on your surgical technique. Decision making for undisplaced, you can think about conservative. I conserve them. Type 2 and 3, my preference fixation, because having residual laxity is always bothering to the patient in the long run. With associated injuries, results of better fixation is done within 2 weeks. Open fixation, the workhorse, the standard that we're learning. Posterior approach, Burke and Schaffer approach. We make an inverted L-shaped incision. Develop the interval between gastro and semimembranosus. Vertical capsule incision and reduction fixation with screws. Even with this, we can make errors. And a hilarious one, I did one in my postgraduate time, and I actually ended up putting a screw in the femur instead of the tibia. The fixation was fixed to femur in my postgraduation days. So next day we went again to the OT and revised it. So we have to be careful while doing an open approach also and not really get overconfident about it. These are few of the exercises that we can do depending on the fracture anatomy. So pearls it's cost effective and relatively easier to master. And the disadvantage of large incision in the popliteal fossa. So the topic that we want to focus is the arthroscopic fixation. One is suture pull-out fixation over a post or a bony bridge that most of us practice. The other method is double button technique that I have learned from my mentor. That's what I am been practicing most of the times. Now, technique that I've learned from my mentor, Dr. Sheetal, is that we do a double suture disc technique. The fragment is exposed posterior medially. Tunnel is drilled through the bony fragment. We reduce it through the jig and drill a tunnel through the bony fragment. Put a suture disc over it and compress it with a suture disc which is tied at the anterior cortex. This is a technique we are following. I'll show step-by-step video demonstration for this. This is my case, a 25-year young man had a motorcycle accident and presented to me around 10-12 days of injury. Had a big PCL avulsion, a single piece, not much combination in this. This was his MRI picture. So I'll go step by step. The first step being creation of space between the ACL and the PCL. Through the shaver, we create the space between ACL and PCL so that we can go posteriorly to the posterior medial compartment. We need to go and see the posterior medial compartment so that we can make our portals. So on my side is the PCL and on the panel side is the ACL. So I'm creating the space towards the PCL and the shaver has to be pointing on one side towards the medial compartment and should be just adjacent to the PCL so that you don't go very deep creating this portal, the space between the two ligaments in the intercruciate space. So once you have created the space, your scope goes into the posterior medial compartment. Okay, I cannot fast forward it. So once we are in the posterior medial compartment, we create two portals, high and the low posterior medial portals. I normally use a spinal needle, make multiple passes in the capsule. That gives me a reasonable rent rather than using a knife. I create multiple passes and from them I pass the finger rod on which I prefer to pass my portals. These are the two posterior medial portals from a different patient. I didn't have a very good picture of that. We have two cannulas in both the portals. In PCL avulsion, the upper cannula can be a smaller one in which we can pass the arthroscope. It has to be a visualization portal. And the lower one I normally use is around 6.5 or 8 mm cannula, which is my working portal. The visualization is from the high posterior medial portal now. So this is the PCL coming from front. This is the avulsed fragment. So I'm visualizing from the high posterior medial portal, looking at the PCL and the avulsed base. In this case, this bunching of a PCL is also seen around that area. Sorry, I cannot forward the video a bit. So this is the shaver I'm using from the lower posterior medial portal. I'm clearing the soft tissues around the avulsed fragment and creating a space between the posterior capsule and the PCL. So this is my working space, which I'm creating. So all this is being done while visualizing from the high posterior medial portal and working from the lower posterior medial portal. And I work normally on the leg is kept on the table, not hanging. But I somehow feel I get enough space to make two posterior medial portals in that position also. So once we have created the space and we have identified the fragment reasonably well, there's an extension of the clearance of the space only. I'm just clearing and making adequate space. One tip while after doing all this is we can pass a Visinger rod from the inferior portal and push our capsule posteriorly so that we can develop a space between the two, the PCL and the posterior capsule. So this is basically adequate clearance of the space so that our vision is good. Next is you reduce the PCL avulsed fragment with the PCL jig. You pass the jig between the ACL and the PCL. Give an anterior drawer force to the leg, your assistant gives it, and you press the fragment with the tip of the jig. Your fragment sits back on its bed. The tip is that you don't try to take the jig like 15-20 mm down that you normally do in cases of PCL reconstruction, because these fragments are right at the edge of the posterior border of tibia and not that down. So you have to like 5 or 10 mm down lower from the border, and that is the area you place this PCL jig and apply pressure with the PCL jig to reduce the fragment. So I manipulate a bit that whether I want to push the fragment down anterior side to side with the jig, and then I apply the pressure and reduce the fragment with this jig. Once the fragment is reduced to my satisfaction, I fix the jig in that position and do a standard drilling of the tunnel as we do all in PCL reconstruction. So drilling is being done. Slightly, you have to bear with me because it's an important step and the video is not getting forwarded. So once we drill the fragment, the tip stops just at the jig. So right now it is at the jig, and I can feel it on by tactile sensation that the metal is hitting the metal. Now, once I'm sure, I move my jig away from the drilling point a bit, 2 to 3 mm on the lateral side. You can see that there is a slight movement in the jig. Yep. Now, if you see it's around 5 to 10 mm is the mark that the part I'm going inferior to the tibial rim and not too inferior as we prefer to go in case of PCL reconstruction. This way it becomes easier that you don't have to expose that much of the proximal tibia part. So now when the drillers come out, the tip is there. Now you move the jig a bit lateral, keeping the fragment compressed and hammering the guide wire so that you have a controlled penetration of guide wire through the fragment in the soft tissue and doesn't run back. And you keep the pressure on with the jig so that the fragment does not move around. At the same time, you drill it with the 4.7 drill bit while keeping the pressure on with the jig so that fragment does not move. This is a most common point where you have loss of reduction. So you have drilled it with a 4.7 drill bit. After that, you pass the suture shuttle. You just through a bead pin, just pass a ethibond, and you retrieve this ethibond through the lower posterior medial portal. That is your working portal. You get a grasper suture retriever from the lower posterior medial portal and retrieve the suture. So now you have a fragment is reduced with your jig. The tunnel is drilled through the tibia and the bony fragment, and the suture is retrieved in the lower posterior middle portal. This is suture disc construct that we use. We take a suture disc in an inverted fashion, pass a suture tape and a suture this fiber wire through it, so that we have a double security in case something of the other two breaks. I normally use double of it. The suture disc construct, this is the way we use it. This is I'm viewing from the anterior portal now. The superior one is the Wissinger rod in the higher posterior middle portal, and the inferior one is the threads of the suture disc construct coming. And now we are just pulling the construct inside. The suture disc has a tendency to get stuck in the capsular end. But once you are through it, you can have the suture disc inside the joint. This green thread is just for the leading part. I put it additionally so that I have a better control of the disc. So once I'm inside the joint, I've got the disc inside. Then I again go back to my posterior middle portal, I1, and pull the disc from anterior cortex. I can visualize the PCL and the fragment tightening as I exert pressure on the disc from the anterior cortex. So just two more. So you can appreciate the movement of the fragment reducing with the movement of the suture disc. And now you can tighten it from the anterior cortex over a post or a bony or a button. And this is the final picture when I'm seeing from anteriorly. So I have one suture disc inside. This is just another patient just for the appreciation. The first image shows that the fragment is not yet sitting. The second one is after pulling, the fragment has gone back into the crater. The suture disc has pushed it back. It's a big, good 9-10 mm force putting it back. So this is a post-op X-ray. There was slight mediolateral malalignment, but the fragment is superior inferiorly well seated with the disc. Limitation is comminuted bony fragments are difficult to manage with this technique. And we have a hardware which is intra-articular, though it's not bothering, but it sometimes can be concerning to us. Tip is that tunnels exit just at the posterior cortex or 5 mm beneath it. And reduction, you have to maintain with a tibial jig while doing all the manipulations. Thank you. And with this, I would like to invite you all to Chandigarh in the coming month, 1st and 2nd June, for the second Chandigarh Arthroscopy course. Thank you, everyone. I would like to thank my mentor, Dr. Sheetal, for teaching me this technique, which I have been practicing for last 8-9 years. Thank you, sir. Any questions?
I guess one thing, Dr. Siddharth, very well shown video and very well described as well. लेकिन मुझे लगता है कि shaver, most of the people posterior compartment में with expertise and experience, obviously you are able to use it.
RF is better
RF
in initial stages, and more so if you want to go a bit lateral.
Yes.
In this technique, most of our things are on the medial part of the.
But मुझे लगता है कि for
RF
delegates and beginners, one should not be using shaver. So
RF is something I should have showed actually.
yeah,
I should have
मुझे
taken
थोड़ा सा
from
लगता है वो
PCL.
take home message की shaver नहीं डालना चाहिए posterior compartment initially, but it's learning curve के उसके बाद जब experience हो जाए तो obviously you can use whatever you want to do.
I use RF in PCL reconstructions always.
So nice talk. My question from the house. So everyone shifted from open reduction, internal fixation with a screw to the gradual nowadays with the arthroscopic method of fixation of the PCL avulsion. We do the same method, but anybody have any complication post-operative later on, like pseudo aneurysm of the popliteal artery?
Yes, in sports injury center we had
I had it.
We had a couple of cases.
One I had it pseudoaneurysm, but it settled by itself. Luckily, we didn't require to intervene in that. That was after PCL reconstruction I had. And, and for me, that case went uneventful. I was surprised to have that. It was surprise to me that in post-op.
So while doing a posterior tibial spine avulsion, what we do, we make a transseptal portal.
No.
So we make a posterolateral portal as a viewing portal and posteromedial portal as a working portal. So in one case, recently only one of my colleagues was doing a posterior tibial spine avulsion while using a cautery. We was trying to reduce the fragment, take out the fragment from the bed and take it down. So meanwhile doing that, it took a lot of time. So maybe during that or during the dreaming, no, we were not able to make out, but there wasn't a popliteal artery injury after that.
Sir,
so,
we routinely, approximately in a month, we are doing 4 to 5 cases of PCL avulsion arthroscopic method of fixation. And we have all the data, intraoperative, we have full record of the operative procedure. And I have one complication of popliteal artery pseudoaneurysm in a case done around 6 months back. And I went back and rechecked the operative procedure. There is no any mishap during the procedure. Again, the patient developed the pseudoaneurysm after the surgery.
How was it diagnosed?
Sir, the patient came to the OPD and said, "Sir, we have I have some swelling in the calf, posterior aspect of the knee." Then I said, "Arey kuch nahi hai, theek ho jayega." Then gradually it is increasing day by day. And after 6 months, it's a little bit huge swelling in the popliteal fossa. So I went for the CT angiogram, and there is very, very thin one, just like a thread of pedicle connecting from the parent artery to the pseudoaneurysm. And luckily the patient operated in a week back and now he's fine.
I think the very fact that there are 3 people here who've had this complication, at least 3 people here who've just told, okay, more, is something that is really worrying to me. Because with open surgery, you will not get this complication if you're careful. So I think you need, obviously there are some things which you have to do arthroscopically, there's no choice. And if they come late, you probably have no choice but to do a PCL reconstruction. But if you have a large fragment which presents to you early, I still think that open surgery is the best way to do it because it just needs a couple of screws which you can fix. If it's a large fragment of bone, because you get much better fixation with screw fixation in those. And very often there's a part of the condyle involved with these injuries. So you have to assess them very carefully, whether it's just a PCL avulsion or it actually has a chunk of the condyle with it.
Gurudev, your case may be the aneurysm could have happened due to original injury itself, not due to surgery.
That might
I've had cases where the patient presented like this after 8 months, they're having pseudoaneurysm, not due to PCL at all, due to something else. But had due to trauma.
But went to the literature and read the article. There is a paper at the time of drilling. Most of the time, the guide wire hits the popliteal artery. But we are not aware.
Do it in vision, full vision of what the guide wire is going in, where the reamer is going in, less likely to have a vascular injury, as long as the capsule is not broken. The synovial membrane is broken, then there is a high risk of injury. But I think if you did not have any mishap during procedure, if the procedure went smoothly, if you have pseudoaneurysm after 3 or 4 months or something like that, then it may be due to original injury itself, not due to your surgery.
But simply PCL avulsion may leads to the intimal injury or the injury of the artery. No idea.
Knee dislocation can
Sir,
cause
we are dealing with
pseudoaneurysm.
PCL artery is close by. We can have things which are beyond our control. And we
So
should be
main
prepared.
thing, you have to do everything under vision only. You should not be doing anything that is not visible. Just about the technical things, how many of you doing the drilling through the fragment part? Starting from Bhattacharya, sir.
No.
Ankit boss?
No, I do.
Bhushan, sir? Through the fragment only. So is there any measurement that you decide preoperatively that this is the size, so I'll be doing through the fragment only? Because most of the time it's very small fragment or many a time it's comminuted one also.
If it is a comminuted one, this technique is difficult to execute. Then we can use a suture pull-out technique by 2 tunnels and making a loop around the PCL, having the tunnels threads come through the 2 loops, and that is what
So what is your indication for making drilling through the fragment? Are you measuring preoperatively the size of that fragment?
No, I'm not measuring the size. It is a combination I look at. In case it is comminuted or very small, looking like very small, I go ahead with the suture pull-out. Or if it looks to be a reasonable chunk, I've not made any objective measurement, but yes, that looks to be a good point. And goes by the feeling if I drill a 4.5 mm drill in the fragment.
That's the point.
So 10 mm should be a 10 mm 1 centimeter should be a cutoff value. I have not worked on this, but yes, this point needs further
Yeah,
consideration.
so that's the point. Anything less than 1 centimeter, we should not be drilling through the PCL fragment. Thank you, Siddharth.
Thank you.
Makes my life easy. Most of the chunks are big enough. Get a CT scan done. So 20-30 minutes procedure. Very.
So
I
in the
will just
same,
say one thing, sir.
So in the same hospital, John sir is doing by most of the time open method with very good result. And I'm doing orthoscopic.
Siddharth, mine is 50-50, open and arthroscopic. There is a technique by Gavaskar et al. In which the incision is very less.
Yes.
And the literature we have seen that arthrofibrosis after an arthroscopic procedure is more than what we seen in open procedure. So
this may vary from hand to hand.
I'm telling literature.
Neeraj, I had one complication which I've told you in open procedure. I think no one of us would have seen that. See,
that is during PG. See, once you are PG, you have to do.
And for the last 10 years, I've come to practice. I have not done an open procedure for PCL fixation. You can say by habit or just by the fear of it. So whatever works in our hands best can be done. Both of them have proven to be.
I've been doing 50-50. I would say economics again works here.
Yeah,
Many
economics.
patient,
But
many
I don't
patient
think
cannot
this
afford.
procedure also is very costly. We don't spend much. Economics, I think in all PCL avulsions or ACL avulsions, implant usage is not much. The quantity of implant is not significant.
Yeah, but if you have a very comminuted fragment or very small fragment,
Yes,
then
sir.
the screw technique is not going to work. So
Yes,
there
sir.
you have no
Then
choice.
suture
but to-
pull-out is
yeah.
the best technique to have, sir.
I have one question. You do four, an average of 4 PCL avulsions a month.
5 cases of PCL avulsion in a month.
तो you should publish a series. मतलब ये तो
We
स्पोर्ट्स इंजरी सेंटर में जब मैं बता रहा था हाई वॉल्यूम सेंटर है
approximately we are
वहाँ पे
getting 4 to
महीने
5 cases. Yes, sir.
महीने में एक भी नहीं होता होगा शायद 2 महीने में 2 या 3
No, no.
मैक्सिमम
We have data of all the patient.
नहीं मैं आप ये नहीं कह रहा कि आप गलत हाँ आप ये नहीं कह रहा कि आप गलत कह रहे हैं लेकिन मैं कह रहा
Yeah,
हूँ publish
Siddharth,
करिए
are
उसको।
you able to pass your suture wheel through the cannula?
Sutures?
Suture wheel.
Disc, no. Just
You have to take it out.
if you realize at that very point, the cannula was not there. When the suture disc was being pulled, that time the cannula was removed.
Cannula you have to
Normally, I
take
use a 6.5 mm striker cannula for that part because it allows passage of almost every instrument. And I don't use a knife to make that. I showed that multiple punctures so that the cannula fits snugly there.
So you need to take out the cannula and free
And
hand
then I
to
put
pass.
an artery, dilate the capsule a bit because suture disc is 12 mm.
12.
So I have to dilate it from 6.5 to 12 mm that portal. And then I pull the disc because it's a big issue. The disc gets stuck in that capsule. That is why I attach that green thread to pull the disc back so that in case it does not pass further.
Or you can pass in between the portal that we have created between the ACL and PCL from anterior side directly. I used to pass through anterior side.
And that is another option. Yeah, you're right.
How many of you take off the septum? How many of you take off the septum between?
Yeah,
you do
all the time.
all the time.
All the time.
So you do two posterior
medial
you
portals, sir.
still take off the septum. I think you have to take it up to get a better
Yes, sir.
view.
To expose the posterior medial compartment. Yes.
So some of us do a posteromedial and posterolateral.
That also we do at times in posterior. In PCL reconstruction, I make posterior lateral.
Your safe way of taking away the septum. Very important word of use the 4 cases already. Many who have not recognized it also.
Once with experience there is no tip and trick actually, but we have to be remaining on the fragment, the shaver and the cannula shaver or the cautery, whichever we want to use. It doesn't have to face towards the capsule. It always have to be above the bone fragment. And once you remove the bone cannula, you just pass a Rissinger rod to make a posterolateral portal, and I think there is no difficulty in making that.
Yeah, I think you're very good at it. You do it, but it's easier if you follow one of those tricks. One is you pass the Rissinger rod, pass a cannula over it. That makes its own way. And the other thing is all the working instruments should face the bone. Nothing should face away from the bone and stay a little on the lower side. Higher side, you have the vessels coming in. You stay on slightly on the lower side, you're safe. But you gradually make it. And you'll find at the moment the septum goes up, you get a lot of space in there. And it makes a lot easier. I mean, when you do with 2 posteromedial portals, till the time you have not got the septum off, you are still struggling. The moment you get the septum off, you see everything very well. What portals do you use?
All the time it should be done. The leg is hanging on the side of the table so that the vessel is going already posteriorly, and the blade is facing towards the bony fragment, not posterior to the capsule. That may prevent the injury of the visa of the vessel.
What posterior portals do you use? Posteromedial, posterolateral?
Sometimes I use the posteromedial and posterolateral portal both. Sometimes in obese patient, I use both the portal.
Dr. Siddharth, I would like to invite our next speaker, Dr. Bhushan Sabnish. He's going to talk on the master talk on tips and tricks of ideal PCL reconstruction.
Okay, good afternoon. So that was a good discussion about PCL avulsion fixation. This talk is about how to make PCL reconstruction easy, reproducible, and without raising your heart rate, your blood pressure, and your whatever other hormones are related to your stress, and not have a heart attack during surgery or post-surgery. So before doing a PCL reconstruction, make sure this is the cardinal rule of a PCL reconstruction. If there's a fixed posterior contracture, you're going to be in a soup and going to be in major trouble. So make sure there is no fixed posterior contracture. That's the only prerequisite before you start doing a PCL reconstruction. Apart from that, of course, you need to know the anatomy, possess the right skills, be familiar with the portals that we are discussing for so long, have the required instrumentation, and a stepwise approach always helps in making any surgery that you're doing reproducible. So always follow the specific steps that you are comfortable with. This is how I do it, but everybody has a different way of doing it. So the key for doing a PCL reconstruction is developing this window. The window between your ACL and the PCL is the most important step in a PCL reconstruction, going to the back of the knee joint. So once you develop this window, you are able to reach the back of the knee joint very comfortably, pass your shaver, clean the septum, so that you can visualize the medial part or the posterior part of the joint through this gap. You need this specific equipment, as you know. You need a good jig for the tibia, which is reproducible and which is comfortable. So always use jigs which are really good, where the guide wire that you pass through, the bullet hits the right spot and doesn't go medial or lateral. I think all of us have stopped using a C-arm during PCL reconstruction now. We always do it under vision now, because C-arm is not perfect when you're seeing it from the inner lateral view. Even a 10 degrees rotation can cause about a centimeter difference in the position of the tip of the guide wire. So always have proper equipment ready, have the proper position, make your proper portals. The posteromedial portal, I think, is a must, unless some of the old-fashioned surgeons or the ones who are really brave, who use a 70-degree scope from the front and do the whole PCL reconstruction through that, which is quite commendable in my opinion. I'm not that brave. I think I still do a good posteromedial portal, visualize everything that I'm doing, and do a nice 1.5 to 2 centimeters deep PCL tibial tunnel position, rather than accepting a shallow position as such. When you're doing a femoral tunnel, you need to have a proper tunnel which will allow you proper inside out femoral tunnel, unless you're doing a specific jig and doing an outside in tunnel. So be prepared to cite accessory portals if you need to when you're doing a PCL reconstruction. Okay. The most important thing in PCL reconstruction is to have a slightly higher portal. You want to go to the back of the knee joint, so your portals are naturally going to be slightly higher. Before you start the procedure, before you take the graft, confirm the diagnosis by doing an arthroscopy, clear the fat pad in the front of the knee joint, clear the synovium on top of the PCL to identify the femoral insertion, and then start creating that space between your ACL and the PCL. Then you can harvest the graft. You can take a semi-T plus gracilis. You can take the peroneus graft. You can take a quads tendon. I think patellar tendon is slightly difficult in PCL reconstruction unless you have a nice patella alta with a long BTB graft. But I would generally go for a soft tissue graft such as semi-T gracilis or a quads or peroneus longus. Next, you're going to site your posteromedial portal. Pass your shaver, always having the mouth of the shaver towards you. That means you're always looking at the mouth of the shaver. I have had one episode of popliteal artery injury in my career, and that's when the shaver was facing the wrong direction. So always make sure that your shaver is looking at you when you're shaving in the back of the knee joint. Next step is passing your elevator through the intermedial portal and clearing the capsule from the PCL insertion all the way to a point which is about 2 centimeters from the joint line. You should start seeing the popliteus muscle. That's the end point. That's when you stop seeing the white and start seeing the red part, not the bloody red, the muscle red. Then you are sure that you have reached the back of the knee joint properly. Now, the most important part where everyone is slightly apprehensive is tibial tunnel. So have your scope through your posteromedial portal and see that you're drilling exactly where you want to drill, and make sure that your jig is stopping the guide wire from inadvertently going beyond where it needs to go. And that's the easiest recipe to cause damage to the neurovascular structures and have complications such as a pseudo aneurysm or a proper aneurysm. Then you pass the suture. So this is the right way a jig is passed over the PCL. The septum is taken off, and even this is slightly shallow in my opinion. I would go slightly deeper. PCL reconstruction. It's very easy to accept a shallow position, but what needs to be done is a proper reproduction of anatomy when you're drilling. Another good trick is either you drill yourself and ask someone else to hold the drill, or you should have a very trusted person to drill it for you. And the moment he or she reaches the subchondral bone or the posterior cortex, start using a hand movement to drill the last part of it. The worst thing that you can see is someone drilling and going like that inside when you're drilling. So always be very slow in the last 4 or 5 turns and avoid the wire from migrating. If you use a shallow angle in the jig, such as the first picture, such as the picture I'm showing just now, you're going to get a very small or a very short tunnel. So have a nice long tunnel on the PCL side. So keep your angle slightly more than 50 or 60 degrees. That helps in getting a long tunnel, which allows you to make a properly placed tunnel, which allows you to have a suture passage. Now, the suture is then retrieved from the anteromedial portal as seen here. And then it's just a simple thing to site your femoral tunnel and do the surgery yourself. You can use the clock face, but generally speaking, the position that you would want to go is as high on the roof and about 1 o'clock position here. So if you can see my arrow, that's the right position for it. We are reproducing the AL bundle. We are not trying to do a double bundle PCL. Those of you who want to, you can do a 2 bundle technique. Then it's 1 o'clock position and 3:30 position, which is for the 2 bundles that you want to. So that's the normal position that you would want to go. I would even go slightly more anterior to that. Your tunnel should be kissing the articular margin to get a normal anatomy of your tunnel. Now here you can do an inside out or outside in. If you want to use a jig, you can do outside in, but it's very easy to do an inside out technique by passing a guide wire exactly where you want to go. The problem when you do that is your exit point is not under your control. So a lot of times the exit point on the femur is quite posterior. And if you are fixing the screw, it becomes slightly tricky when you're in your final fixation. So a good compromise is to drill with this and then finish the drilling from inside out after you pass the guide wire in. Next is a fairly straightforward thing. You pass the suture from the tibia to the femoral side and navigate the good old acute turn or the killer turn as we call it by passing a periosteum elevator or a Steinmann pin on the back and pushing the graft forward. An easier way to avoid that is to pass the graft from the joint down onto the tibia, pull it out on the tibia and then pull it up on the femur. That works really good, and that's the easiest way to get the PCL reconstruction done. You can fix it both sides with a screw or on the femoral side with a button, whatever you're comfortable with. So that was a theory part. So let's quickly have a look at the practical part of the surgery. So your quick diagnostic round will show exactly that your PCL is deficient completely. It's a chronic case, so you can't see anything, of course. So once you have confirmed the diagnosis, take out the soft tissue which is blocking. Here there is no PCL remnant left, so you are lucky you don't have to create that gap that I talked about. So go to the back of the knee between the what is left of PCL and the medial femoral condyle, and you create your posteromedial portal there. The shaver is always facing you and you are clearing the back of the knee slowly. There's a septum falling away now. And this is where the high portal helps you, because then you are able to look down to the back of the knee much more easily. As you can see here, you are easily able to pass now the tibial jig till about 18 to 20 millimeters. And this is the view from the posteromedial portal. See how nicely and clearly you are able to see the whole of the PCL remnant and exactly where you want to come. Then drilling is done. You pass the guide wire exactly where it should be, and it should stop in the jig. It will not go beyond that. Followed this by using the jig as a retractor. So push the jig backwards while you're drilling. So even though if your drill comes through, it will not hit anything soft tissue wise. It will be protected by the jig itself. Then you pass your sutures, pull them screw anteriorly. Then your femoral tunnel is sighted. So you can see this is a chronic case. So there are a few osteophytes there. You decide where you want to go. Pass your guide wire through. Withdraw it from the medial side on the femoral side and drill. Now, in this case, I have put a screw both on the tibial side as well as the femoral side. I still use titanium screws with really good effect, and I love titanium screws. I don't go for bio screws for my ACLs or PCL yet. And this is that killer turn which has been sorted. So you can see that shadow of the periosteum elevator, which is physically pulling the graft backwards while it's pulled inside. So you can see the graft being pulled in slowly. This is a patient time-consuming thing that needs to be given its due time. You can't hurry into pulling the graft fast. The killer turn is really a killer turn. It can damage the graft on the sharp edge of the bone. And once the graft is through, you can pull it inside the femur, the femoral tunnel, I mean, and fix it with a screw both on the tibial side and the femoral side. That stitch that you see is the marker on the graft to know that 2.5 centimeters has gone inside. That's fixation with a screw. The screw is fixed from outside in rather from inside out. Remember, you are very close to the articular cartilage, so you don't want the screw to damage. In this case, it's inside out, as you can see. But I've moved from this technique now. I go from the outside in technique fixation for the screw, because that screw tip can be very close to the articular cartilage and can cause damage to the articular cartilage. You can see a nice looking PCL graft there in its right trajectory now. So that's how I would normally do a PCL fixation. I would do a single bundle PCL fixation normally, but you can always do a double bundle PCL reconstruction on the femoral side. More important than anything else is not to miss the associated injuries with the PCL reconstruction. Many times it's associated with the PLC injury, so don't neglect that and fix that as well. So to conclude, PCL is a very important structure that needs to be reconstructed. We all know that. And it's a slightly stressful surgery if you're not accustomed to it. If you follow the same step that we discuss day in and day out, there's very less chance of errors or mistakes happening and causing any inadvertent damage as such. Thank you.
Thank you, Bhushan. I think we'll take questions later. Let's ask Dr. Amit Joshi to come and tell us about small lesion, big surgery, surprise after arthroscopic cyst excision. Nice to know that even Amit gets surprised.
So when Arvind called me and asked, I asked what to present, he said that present something interesting. And the interesting thing that happened to me very recently was nothing to do with ACL, PCL, or any of the menisci. So this was just over the last 10 years, we have done 112 excision of intra-articular lesions. Most of them, practically all of them, were benign until we got this 113th case, and probably giving us a long-lasting memory because of the kind of surgery this very young guy received. So this was a 19-year-old boy, knee pain, inability to fully extend the knee, mild pain in the right knee for 4 months, and there was a small history of, small trivial trauma 4 months back. Since then, he was having swelling on and off. Otherwise, there was no significant history. If you look at this figure, picture and video, this is under anesthesia. Also, he was having some degree of extension lag. So there was something blocking. There was a little bit of effusion, and there were no other findings. The ligaments and the menisci were normal. This was the X-ray of the patient that he came with us, which was perfectly all right. But the attention was, taken by the MRI, although it's little poor quality MRI, which is done in the periphery of the Kathmandu. But you could see that there was a lesion on the both in the coronal and the sagittal section. And this lesion was intra-articular, just anterior to the ACL, above the anterior horn of the lateral meniscus. So this was in the T2 sagittal image. Again, you can see those lesions were visible in that one. So since we have done a lot of these things and then the arthroscopy surgeon's value came in, we thought that this is yet another PVNS because the reports were also for, benign lesion. We thought that with the provisional diagnosis of pigmented velonodular synovitis of the right knee joint, we'll go ahead and do an arthroscopic excision of the lesion. So when we went inside, you could see that the grayish brownish color of these small cysts, which is pedunculated, small pedicle into the anterior horn, or probably coming from the fat, which was very much mobile, and it was not much of adherence to the Hoffa's fat pad as well. So we could just push it anteriorly and started excising it. It didn't took a very long time, and then we were able to excise this, giving on the pedicle side we give small cut. Maybe we used a vapor, and then it could be displaced into the notch, and then we remove that. I'll show you that it was not that difficult. So here we are pushing and cutting the pedicle. So once the pedicle is cut, this brownish color tissue was removed. And then we debrided and then this surgery was done within 10-15 minutes. And we were very happy that we got this tissue, probably in toto excision. Then the patient was followed up after 2.5 weeks, 3 weeks. His stitch were removed, everything was healed. He regained his hyperextension of the knee joint, which he was looking for. The pain subsided, there was no effusion, and the patient was very happy. Then I said that just, if any problem, just come with me, because I forgot that we have sent this specimen for the biopsy. And then I didn't inquire for the biopsy itself, because I thought that this will be yet another velonodular synovitis. But this patient calls me on 3 weeks' time and say that, doctor, my pathologist called me and he said that you should immediately meet your surgeon, because the pathology report was suggestive of synovial sarcoma biphasic, which is more, aggressive and the more malignant than the uniphasic. So we were not believing on this report. We thought that how can this be in a 19-year-old guy? How can this be such a malignant lesion? So we decided to take opinion of a second musculoskeletal, histopathologist, and he also reported the same thing. And based upon their suggestion, we did immunohistochemistry also. And if you see this immunohistochemistry parameter, these are the parameter of very aggressive, synovial cell sarcoma. So then it pushed all our colleague and team to sit together and discuss on a 19-year-old guy who came with just a simple, pain and the effusion for 4 months, now has a diagnosis of synovial cell sarcoma. So the main thing was it was a very rare condition that we have found. And then even if it is rare, we understood that rare cases, they still do occur. Any space occupying lesion should not be taken very casually, because we missed, counseling this patient. So it should not be taken very casually. That was the lesson initially in first stage we learned. So if you see these pictures on your left side is our MRI, on the right side is the one of the case reported into the literature. And they suggested that if do a contrast enhanced MRI, then we will be able to see massive edema around that lesion, which is indicative of, malignant lesion. In this case, since the radiologist didn't report anything, we just took it casually. And probably if we would have done an contrast enhanced MRI in this particular patient, we would have diagnosed the case very early, and then probably the treatment would have gone a little differently, Was arthroscopic biopsy a better decision than an open biopsy? If you consider from an arthroscopic point of view, I said that I give a 2 small incision and then I remove the big mass. Even if it is malignant, it came out to be malignant. But my the oncology colleague, they said that you have a incision, you have a portal on either side of the patellar tendon. So when they do an aggressive surgery, probably these portals have to be removed from both the sides. That's why the incision is going to be a little extensive. So then most important is we just took it casually, and we did not counsel the patient, this 19-year boy, about the possibility of severe malignancy, which may require a future, aggressive treatment. Then we sat with our MSK oncologist with the diagnosis, and they say that this patient require extra articular knee resection and distal femur endoprosthesis. So this again put us on a shock, and the patient was in shock because this is a massive undertaking. If you look at this, diagrammatic representation, what is extra articular resection of the distal femur for synovial sarcoma? This is the 12 millimeter of the proximal tibia, the 5 millimeter of the patellar, the articular side of the patella, and about 15 centimeter of the distal femur has to be excised. So for such a small lesion, this bigger surgery is recommended for him, and probably that is what literature also say, that this surgery is required. And this picture I received from my MSK oncology colleague. Look at that small lesion, and now look at this incision. One of the biggest surgery I have seen were done in some of the patient who has such a small lesion. And then this is what he was showing to me, that you see at the center, since they had to excise both the portal, they have to put a graft to cover that region, to cover that. So they say that if they would have done an open lateral incision, probably this grafting wouldn't have required. These are the X-rays of the megaprosthesis. One good thing that happened was the margins were clear. There were no other surrounding metastasis that was identified. So surprise can appear anytime. It's always wise to follow the standard protocol, and we know that we have missed certain standard protocol to address this patient from the very beginning. So what are the lessons we learned? That never underestimate a space occupying lesion. Always consider malignant until proven otherwise, and counsel your patient accordingly that this could just turn into a malignant lesion, which may require future treatment as well. Contrast enhanced MRI is a mandatory if we locate a mass. We should not ignore, it's a very small size, this looks very benign. So probably contrast in enhanced MRI puts more information into the mass that we find out. And the patient counseling is necessary about the possible malignancy of all the lesion that we excise and send for the biopsy. Thank you very much. Thank you.
Thanks, Amit. I'll ask you one question. What would your treatment have been if we had diagnosed it preoperatively?
I wouldn't have treated. I would have sent straight forward for the MSK oncologist.
What would their treatment have been?
Sorry?
What would their treatment have been?
Their treatment would have been the same one. The only thing, if they would have identified that lesion, probably extra skin grafting and extra flap they raised from the gastrocsoleus may not have required.
So I'm not sure about that, because I think we've had a few cases of synovial sarcoma in the past. One of the problems is when you excise it, you actually accelerate the growth of it. That's the interesting thing. When you excise a synovial sarcoma from the knee, the chances of it growing faster increases. So they often give radiotherapy and chemotherapy rather than do surgery for these, if I'm not mistaken. It's been a while since.
Absolutely. Synovial sarcoma, intra-articular are very rarely reported. Extra-articular synovial sarcoma is not that rare. They are very common. And the treatment for them, and then on understanding of these type of extra-articular synovial sarcoma are very well mentioned in the literature. But intra-articular synovial sarcoma are extremely rare.
It's you more often in the posterior part of the knee that they get.
Superior pole of the patella, posterior part of the knee, these are the common locations. But intra-articular, very rare, extremely rare. There is only one case reported earlier in the literature.
Looks like very big surgery for a lesion like that.
That is what we understood. As an arthroscopy surgeon, I just couldn't understand why this patient required that bigger surgery for just a small excision. But that is what literature suggests, that intra-articular synovial sarcoma will require a bigger excision of these things.
It's really a revelation. As is when the first time when you come across an extra-articular synovial sarcoma, that is also quite often missed. And then, it comes to the finding some days later, you take out a small tissue somewhere in the proximal tibia, and later comes out. But fortunately, that is a slow-growing tumor. This one is very aggressive.
This is
more aggressive after excision. That's the interesting part of it.
Biphasic itself is aggressive, and if you touch it, it becomes more aggressive. That is the reason why this bigger surgery is probably required. Thank you, everyone. Thank you.
Thank you, Amit. Go ahead with
Now we invite Dr. Ranajit Panagri for doing a relief surgery on a PCL reconstruction. After that, we'll take questions from Dr. Bhushan and Dr. Ranajit for PCL.
Yeah. Good afternoon, everyone, respected chairperson and delegates, and thanks John sir and Arvind and team Patna for inviting me to this meeting. It's a very good meeting. And I was supposed to do this live surgery because of some real unavoidable situations. All those live surgeries got cancelled. So I'm presenting a small video of the technique. So it's a all inside reconstruction of PCL with remnant preservation technique. And this technique was published last year by us. So here we keep the knee continuously at 90 degrees throughout the surgery. And only semi-T is required for harvesting because we are preserving the remnant. So 8 mm graft is enough. If you are not preserving the remnant, then you have to take at least 10 mm of the graft. So less morbid procedure. And posteromedial and standard anteromedial and anterolateral puttal, all that was required for this kind of surgeries. And this is the instrument set we require for all inside PCL reconstruction. And most important tool is the PCL elevator, where we go in and just release the cleavage point between the PCL remnant and the capsule so as to decrease the neurovascular injuries. This is a PCL tibial jig, which is anatomically contoured jig, and you can directly put it over the distal part of the remnant. And there is a stepped sleeve inside this jig, where the stepped part enters into the bone so that inadvertently you will not create a tunnel instead of socket. So that is why the stepped part is there inside the sleeve. Similarly, this is the PCL femoral jig, which is also anatomically contoured according to the femoral condyle to accommodate it so that you can directly keep this jig on the footprint. And the most important tool is the flip cutter or retro rimmer, which creates the retro socket. We are not creating the tunnel through and through tunnel, unlike traditional PCL reconstruction. So we are creating the sockets. And offlet to it, the flip cutter 3 is added, where you can adjust your cutting width so that it is from 6 mm to 12 mm. You can adjust your width in a single flip cutter so that the number of flip cutter will reduce for a single surgery and the cost will also reduce. So coming to the case detail directly, this is a 30-year male presented with posterior knee pain with instability of the knee with history of injury 7 months back. On examination, there was a small healed abrasion on the posterior anterior aspect of the knee. Loss of tibial step-off was there. Posterior sag sign was positive. Posterior drawer was positive. Quadriceps active was positive. There was no mediolateral or rotatory instability. On imaging, X-ray showed no bony injury or avulsion injury. Posterior stress X-ray showed 11 mm of the translation. Scanogram, no alignment issue. And MRI, isolated PCL injury without any meniscal, collateral or chondral injury. So in this case, we planned for all inside PCL reconstruction with preservation of the remnants. So coming to the surgical video directly under anesthesia, again, we checked the instability. It was grade 3 instability. Clearly, the tibial step-off is vanishing beyond the femur. So it's almost a grade 2 to 3 instability, and you can quantify it by the slopy ACL sign, how much it is subluxating posteriorly. And only semi-T graft is taken. And most important step is to create a graft link here in this case. So this graft link is usually 8 centimeter. We intend to make it 8 centimeter length. For inside the femur 15, inside the tibia 25, and intra-articular 4 mm. And we are giving the marking on either side. Then intra-articularly, the most important step is to create 2 windows on either side of the remnant PCL, one between ACL and PCL and one between PCL and medial femoral condyle. So always you keep your shaver towards the PCL side, because even if you damage the PCL, it's not an issue. Don't harm the ACL. So now the second window is between the this PCL remnant and the medial femoral condyle. You should take out some of the soft tissue with the RF and shaver. And sometimes we do reverse notchplasty to create a nice window so that easily you can go into the posteromedial compartment. So once you enter the posteromedial compartment, Then you create the posteromedial portal and create this above the synovial fluid, synovial fold of the this posteromedial compartment. So above the capsular fold, if you are coming, then your vision will not be obstructed. Then give a stab incision and put a 8 mm cannula with the cannula introducer through this posteromedial compartment. Now all of your surgery will be through these three portals. Then you switch over your scope to the posteromedial compartment and bring your shaver and RF system to clean the soft tissue and the scar tissue behind the PCL remnant. Never point it towards the posterior side so as not to injure any vascular structure. So this creation of the cleavage is very important if you are keeping the remnant intact. Then you come through the lateral window, again do the clearing, necessary clearing, because you will have to bring your jig through the lateral window. So you can take the help of this PCL elevator and just go down as much as possible so that you can nicely see the popliteus muscle. So once you see this popliteus muscle, now you are sure that your capsule is far behind and there is no risk of vascular injury on the posterior aspect. So you have to create this much of cleavage plane. Then you mark your tibial footprint. In PCL remnant preservation, you mark it at the distal most part of the PCL remnant, never in the center, because it will damage your remnant at the attachment of the tibia. Then bring your PCL tibial jig through the lateral window so that it will be kept directly over the footprint. And then take your appropriate size flip cutter through the outside sleeve and bring it through the tibial footprint, and it will be protected by the sleeve and the typically designed this jig where it will protect your flip cutter from going behind. Then you deflect the soft tissue and the capsule behind, and then flip the flip cutter to appropriate size and bring it up to the bone. Always bring it up to the bone, or else you will end up in creating a smaller socket. So once you bring it up to the bone, then you start creating retro socket and mark this black color grommet outside. This is the black color mark, and measure the length of the tibia socket. Usually we do 30 millimeter of the socket on the tibial side. Then you take the flip cutter inside and bring it outside, and then you pass a bead pin with a suture, or you can pass a tiger stick or fiber stick through this sleeve and bring a hemostat. I bring usually right angle hemostat through the lateral window and just retrieve the suture through the lateral window and park it anteriorly through the intermedial portal. Once you do that, then you go ahead with the creation of your this femoral footprint. Always in the remnant preserving, we are doing the AL portal reconstruction. So we keep it over that femoral footprint 8 millimeter behind the articular surface, and bring your flip cutter likewise from outside the sleeve. And then once it goes inside up to the required depth, then you flip your flip cutter inside to the required diameter. Here it is 8 millimeter diameter. And then you bring this flip cutter up to the bone. And once you reach the bone, then you start creating your retro socket and measure the retro socket. Usually on the femoral side, we create 15 to 20 millimeter of the retro socket. So here you can mark the black color grommet again, and you mark 4 marks there. So it will be 20 millimeter of the retro socket. Once you do that, then you take this flip cutter back again inside the knee joint, and then you unflip the flip cutter and clear all these debris from inside the joint and pass a bead pin with a suture into the joint. Now you put a passport cannula so as not to create any soft tissue bridge in between these sutures. So retrieve all these sutures through the passport cannula. First, the tibial leading suture,
And once you pull the tibial leading suture and park it, then you pull the femoral leading suture. And over this femoral leading suture, you load the femoral side, this tightrope construct, and then pull the tibial leading suture first into the tibia and take out all the sutures of the tightrope outside the tunnel, and then gradually pull your button into the tunnel and then outside. And once the button is outside, then do a gentle cinching movement. Take a probe to deflect the ACL and gradually cinch this graft link into the tibial tunnel. It will slide along the remnant very nicely and will enter into the tibial tunnel, tibial socket. Then your femoral side suture, you just pull gently and take out all the sutures outside, and then gradually holding all the sutures of this tightrope, then you pull inside the femoral tunnel. Once the button is goes inside the femoral tunnel, you can directly visualize through the scope also. It is going through the femoral tunnel. And once it is outside, then you do the cinching movement on the femoral side so that your graft link will go inside the femoral tunnel up to the required depth. And then you give an anterior drawer force to recreate your tibial step off like the normal side, and then you do the cinching movement on the tibial side. And this is the final reconstructed ACL, reconstructed PCL with remnant preservation. And you can fine tune your tension even after fixation. This is the beauty of the all inside technique. If you fixed it and not satisfied with your step off, then again you can fine tune by cinching on both sides simultaneously, giving the anterior drawer force. Post-op rehab is pretty similar to that of traditional PCL reconstruction. The only thing we allow the sporting movement little bit earlier in this case. So what are the advantages of all inside technique? It is a bone conserving surgery, allows graft retensioning even after the graft fixation. The socket reduces the tunnel widening because the synovial fluid doesn't enter inside the tunnel because of the 360-degree healing. So there is less chance of tunnel widening, and there is decreased pain and morbidity because of the bone, muscle and tendon preserving surgery. So what is the advantage of remnant preservation? The graft reinforcement prevents stretching and laxity during the healing phase. It heals together with the newly reconstructed PCL, so better mechanical support. It prevents new graft from the killer turn at tibia because of smooth sliding of the graft link, and aids in better proprioception because of the mechanoreceptors in the residual remnant. So this is all about all inside PCL reconstruction with remnant preservation technique. Thank you.
Question for Ranjan and Fraser. So there will be many.
What was your indication for doing all inside?
In all cases of isolated PCL reconstruction, I go with all inside. Number two, when I am planning for a multi-ligament knee reconstruction to avoid the tunnel coalition, I go with the all inside. Whenever I am going for a revision knee reconstruction, I go with the all inside technique. So it's basically a bone preserving procedure with less morbid procedure. And whenever we are doing a standard PCL reconstruction, we usually don't recreate the tibial step off. There is some amount of posterior sag even after the fixation. But in this case, after fixation also, if you are not satisfied with your step off, you can just retension your graft and recreate that step off. And many cases, I am also augment it with fiber tape to give extra support for the PCL.
Bhushan, like a rising trend was there for double bundle ACL. Similar things are coming up for double bundle PCL as well. And that's more of a biomechanical rather than truly clinical outcomes as compared to single bundle. So is there any indication in your cases for double bundle PCL, or you don't do it?
In big athletes, where there's a big footprint of PCL on the femoral side, a double bundle is quite a attractive offering for most patients and surgeons also. So if I'm treating an athlete who's well built, has a good good big footprint, it will be a good idea to do a 2 tunnels on the femur, but a single tunnel on the tibia. I think so we have a technique of doing the same in all inside way as well. That is called a striling technique, which works really well. But I think 2 tunnels on femur, 1 on tibia with a graft which is Y-shaped works really well. So
In that case, you will use a central cords.
yeah, you can use central cord. That's a very good way. Central cords, you can split it in half, take a stitch in between, and make 2 femoral bundles.
That too with the bone plug.
Yeah, that with the bone plug. Yeah. Hey, Ranjit, one question. When you're doing your fiber tape extra fixation, would you fix the fiber tape and the sutures from your tightrope separately as a secondary fixation on the tibia with a swivel lock?
Yeah, always says a secondary fixation with a swivel lock on the tibial side. I don't augment the graft. I fix it separately, both for ACL and PCL.
And what's your angle of fixation? And you tie first your native graft or first your fiber tape? Like in ACL.
First I do the fiber tape fixation.
And at what angle?
For ACL or for PCL?
PCL I'm talking about.
For PCL, 90 degrees of the flexion. First I'll just tie since the this button so that it will go up to the bone. Then I leave it. Then I fix the fiber tape with a swivel lock, giving the adequate amount of tension. Then I go in and do the extra amount of cinching to create the step off again. 90 degree. Yeah, but in ACL it is separate. In PCL, yeah.
Okay.
Bhushan, when you're doing your PCL, Dr. Ranajit has shown this remnant preservation on the tibial side. So you also try to preserve it on the tibial side, or you take it off and go along with the bone?
So if there is a good remnant, you will try and save the remnant. So you go behind the remnant now. So you have to release the septum, which is holding the PCL to the capsule. So you place your jig on top of the remnant. That makes your life really easy.
And I think the tip for this is that if you're trying to preserve the remnant, you have to go make the window between the ACL and the PCL and go down. Otherwise, you won't be able to. Otherwise, you won't be able to do that.
Yeah.
Questions? Anytime you make posterolateral portal for PCL along with posteromedial.
So I don't do a PL portal usually unless I'm struggling with posterior visualization. But generally, I don't think it's required for standard PCL reconstruction. You can have 2 posteromedial portals if you're struggling to view. That makes visualizing the from the north portal and operating through the south portal really easy.
Yes. Yeah, same here. I don't do posterolateral portal unless it is a bony avulsion, because in case of bony avulsion like ACL bony avulsion, I have to see my PCL or bony avulsion from both sides, so that it will be easier to fix the bony avulsion. But for the standard PCL reconstruction, only posteromedial portal or at best 2 posteromedial portal is enough.
And if you are making a femoral tunnel for PCL,
sorry,
femoral tunnel for a PCL, inside out, not outside in.
Inside out.
Yeah, through the anterolateral portal.
Yeah.
So how to ensure it is anterior, the exit point is not posterior?
How
to ensure that the exit point is not posteriorly, it is anteriorly in the femur side?
Yeah, because when you are putting your jig, you have to put your sleeve in between your medial epicondyle and the articular cartilage. Just in between these 2 bony landmarks, if you keep the sleeve, it will not go posteriorly. Because when you are reconstructing the MCL along with PCL, it is an issue. So always keep your jig between the medial epicondyle and the femoral articular cartilage, so that it will not go posteriorly.
I wanted to ask about the inside out, the accessory portals which we make to make it more anteriorly.
When you're doing it from inside out, unless you superflex the knee, it's very difficult to come more anteriorly, and it's very difficult. So the exit point control is very poor when you're doing inside out drilling. So if you're doing a PCL with a MCL, you should be doing outside in drilling, because then you can control both the exit and entry point for the tunnel. So I think
I'll answer your question. Do it inside out. Use a bar lateral portal. Flex your knee. Put in your work. If you're going to go use maybe a 9mm graft, put in your 9mm tunnel. As the articular surface, then put in your guide wire through it. You'll end up in a. Thank you. Thank you very much.
Thank you, sir.
Close it.
Thank you, chairpersons. Lunch is ready, so please join the lunch. Meanwhile, time for the felicitation. Dr. John, sir, please kindly come on the dais. And we'll start with the Dr. Bhushan Sabnis, sir. Please come on the dais. Dr. K.N. Subramaniam, sir, kindly come on the dais.
Am I supposed to give it to them?
Yeah, yeah. राकेश चौधरी सर नहीं है, नहीं राकेश चौधरी सर नहीं है। डॉक्टर राजीव रंजन, चल जल्दी आ, जल्दी कर। डॉक्टर राजीव रंजन, इसके बाद डॉक्टर परवीन टिट्टल। चल चल चल, इधर से इधर से इधर से इधर से चलो। एंड डॉक्टर राजीव रंजन, डॉक्टर परवीन टिट्टल। थैंक यू। आइए आइए। डॉक्टर हिमांशु गुप्ता। हाँ हाँ, डॉक्टर शीतल गुप्ता। डॉक्टर कंचन भट्टाचार्य सर। डॉक्टर शीतल गुप्ता। हाँ। हाँ, इसके बाद एंड डॉक्टर मनीष कुमार, यूएसए। डॉक्टर विनीत जैन सर, प्लीज। विनीत जैन सर। मीन वाली डॉक्टर एन के सिंह सर, प्लीज कम ऑन द डैश। डॉक्टर एन के सिंह ये सर, मैं आपको नाम कोई बात एन के सिंह। डॉक्टर प्रभात प्रकाश बॉस। डॉक्टर अश्विनी गौरव। विनीत सर, कैन यू कम ऑन द डाइस? नहीं, आपको देना है। थैंक यू, थैंक यू। आइए। डॉक्टर रमाकांत, डॉक्टर रमाकांत, रमा भाई आ जाओ। डॉक्टर रवि कुमार। चलो चलो डॉक्टर अंकित गोयल. Dr. Shekhar sir, please. शेखर तो मैं नहीं दे सकता नहीं सर. Now Shekhar sir, you stay please. Dr. Rakesh Agrawal. Dr. Rakesh boss. Okay. Dr. Manoj Chaudhary sir. Dr. SP Gupta sir. ये पहले SP Gupta sir. ये ये पकड़िए इसके बाद Dr. Siddharth Agrawal, please. Dr. Amit Joshi, sir, please. Dr. Amit Joshi. Dr. Rakesh Agrawal, sir. Right. Dr. Neeraj Kanipal. Dr. Neeraj Srivastav. Neeraj, chalo. Dr. Abhishek Das. Dr. Gurudev. Dr. Gurudev. Dr. Gurudev. Dr. Ikram. Dr. Ikram. Dr. Abhishek Das का ये है ना ये चलिए चलिए आइए डॉक्टर इकराम डॉक्टर जानकी सरन बदानी
Dr. Arvind Gupta.
कुछ लोग करा क्या है
सर एक मेरा दे दीजिए। डॉक्टर विकास कुमार।
अभी बाद में
Every time like that.
Those who have completed their lunch, kindly come in the front row. And those who are still taking can sit on the table with their plate. So we are moving to the next session, that is the multi-leg knee injury session.
So our next session is about multiligamentous and knee collateral injuries. And may I call upon the dais, our chairperson, Dr. Sekhar Srivastava, sir. So, sir, please. Dr. Neeraj Srivastava, sir. Dr. Ramakant, sir. Dr. Vivek Jain, sir. Sorry, Dr. Vinit Jain, sir. And Dr. Ikram, sir. Yes, sir. Please, sir. Ramakant, sir, please. Yes.
Hello. Good afternoon, everyone. So we are going to start the next session, post-lunch session, and we will start with multi-ligament injuries around the of the knees. So the first talk in the series is by Dr. Abhishek Das. He will talk about multi-ligament knee injury 2 stage.
Good afternoon, everybody. First of all, I'd like to thank Dr. Arvind, John sir, Dr. Vikas, and the Paras team for organizing such a fabulous conference and inviting me as well to speak on a topic. I hope not to put everybody on a post-lunch snooze. I'll keep it short. I have a case on multi-ligament knee injury 2 stage, which is slightly going out of vogue. So my case is a 25-year-old male who had a fall, road traffic accident, fall from a bike. He presented with this wound. He had a few injuries, which includes PCL avulsion fracture, complete ACL tear, MCL injury, and also a patellar dislocation. So the X-ray is not very clear, but this is what we found out. So these are his CT scans. We did get a CT scan as part of a CT angiogram because in these cases, what I wanted to rule out was any vascular injury as well. Anything else you would like to have before proceeding from the panel? Anything else any information other than this you want? Maybe let's get an MRI scan just to have a look. See that there is a PCL avulsion here. ACL is gone. MCL, probably there is an injury. Can't really make out it. Everything is lighting up on the MRI. So because of this massive wound on top of the knee where I would actually put my incision for drilling the tunnels, I was quite apprehensive. So I thought I would do the lesser the best for this case, because what I was worrying about is this: when you do a reconstruction, open wound, you can have infection, which can cause disaster. This is another patient, not this one. So yeah. So normally we got a CT angiogram in this case, but obviously we can do ankle brachial index, or, first thing is a high index of suspicion in these cases. So I think it is a good practice to go for a CT angiogram, which is available in most of the hospitals. You'd obviously get all the scans done. And then would any of you prefer to do a single stage for this?
This is an open wound.
This is an open wound.
No. Initially, you have to take care of the wound. Yeah.
Okay. So what would be your sequence of repair or reconstruction in this case? Or what would you address in this setting?
So in this setting, with the open wound, one can go for debridement and one can even apply a fixator.
Okay. So when we took the patient to theater, it was not completely dislocating. I was in two minds whether to put a fixator or do, a little bit of, avulsion if I can fix. So what I did was, sorry. Fine. I had another photo which probably I haven't put here. So what I did was the PCL avulsion bit, I fixed it with a couple of Herbert screws. I went in through the same medial wound, could palpate it, put him in slightly floppy position so that I could access it, and then fix it with two screws. At the same time, repaired the, or at best cobbled the medial retinaculum, MPFL, and the MCL part, and then debrided the wound, put him on a vac.
One question. You didn't take the extra incision. It's the same incision you fix the PCL.
Whole wound is like this. Slightly, the distal part of the wound, I have slightly extended it. That's all. I haven't made any separate incisions on this. This is the whole of the wound.
For the PCL.
No, for the PCL, actually the whole of the medial side was kind of ripped open. Okay. So I just did blunt finger dissection, went posteriorly, and then used the ACL jig sort of to kind of put that fragment back. So sort of as a, hook to put it back in place. And then the guide wire, so reflected the whole of the skin, which was quite floppy, reflected it back, and then put the two guide wires for the Herbert screws.
So the percutaneous
Through a small stab incision.
And popliteal artery damage is a risk if you not open it for.
I think popliteal artery is slightly more medial. Slightly more posterior. It is medial, but with my finger and the retractors pulling the skin as far back as possible, I say, the incision for the two stab incisions was slightly posterior, but I can't say with 100% certainty that it won't damage the vessels. But with my finger, I was trying to protect that structures. My finger was going deep in the wound, protecting it, and I could feel the wires skiving on my finger.
So why there was hesitation to use the posterior incision?
Well, so for that, I would have to make another separate incision on this. Given this wound, there was a good chance of having skin necrosis, scarring, and problems. So this was my first go. If I could feel the fragment, reduce it, and get my guide wires in. If not, then I would have totally leave the PCL at this stage. My plan was just to reduce the patella, fix the retinaculum, MCL, and then leave ACL and PCL maybe for a later stage. Because it was a bony avulsion, I thought maybe I would get away by fixing it at this stage, which I managed to do it. So this is the patella after cobbling everything together. And that is actually the hole on the medial side through which I got my finger in, tried to put back the avulsed fragment. And then how much time would you give for the next stage?
So I would have just treated it like a trauma. It's
Okay.
an open wound. I would have done the debridement. I would have put the fixator. I feel that probably it's difficult to open it, to close it primarily.
Okay.
So I would have first waited for the wound to heal, maybe a flap or whatever was required. And once everything healed, then I would have assessed the ligamentous part and dealt with it.
So good thing was that he didn't require any flap. We managed to put a vac in at a second stage. We managed to close most of the wound, and then he required just a small skin graft on the medial side.
The wound is clean and contaminated. Can you go ahead with like open ACL and PCL reconstruction?
So such wounds, I think better to go for 2-stage.
Yeah. So
to go for.
Going to the literature where multiligamentous cases previously done as a 2-stage, you can safely leave the ACL for a second stage. So after his wound healed, I called him back at 3 months. He didn't come back. After 5 months, he came back to the hospital, and he said that he still has slight laxity when he tries to run. And I gave him an option that, well, his knee may become stiff, which is a case when you do 2 stages. So he had a choice, but since he was young, we went ahead and did a standard ACL reconstruction. This is almost now 3.5 weeks. So you can see he is walking, but he is able to sit on the ground. His knee flexion is good. He still has got a lot of rehab to be done. It is only 3.5 weeks. He has got about 100 degrees of flexion at this stage and full extension of his knee. There are some good papers from Rob Laprade, which we can go ahead and read it. But nowadays, most of these cases, unless they are an open wound or there's a big posterior lateral corner and PCL to be fixed, which has taken a lot of the surgical time, the trend is to do all the multiligamentous injuries as a single stage. So this was an interesting case, which I thought might be worth a bit of discussion. I'd like to take this opportunity to invite you all, knee enthusiasts, to a shoulder course, which we are planning in a big Apollo hospital on 30th of June. It would be nice discussion on shoulder arthroplasty and arthroscopy.
So this was really bold by your side, and it went out well. So congratulations. I think most of us would have just debrided it and left it to heal, and after a month, go again and do ACL or PCL, whatever you want.
Yeah, my planning was to just see how it goes. If I am able to fix that fragment, because it looks a bit juicy to leave that chunk of the
That's
PCL.
what I said. It's a very bold decision, and once the results are good, we all must congratulate you for this. Yeah, actually, it was really bold.
Thank you, everybody.
Thank you, Dr. Abhishek. So the next talk in the series is by Dr. Gurudev. He will talk about multi-ligament reconstruction in single stage.
Pointer नहीं है. So good afternoon, everybody. Actually, This is not the single stage surgery because there is some conflict between me and Dr. Abhishek. That's why I choose this case to be present here. Is a two-stage surgery. Although many times I prefer to do multi-ligament reconstruction in a single stage surgery. So this is a 17-year-old male. He's from Dehradun, study in the Dehradun, and in the Holi he came to the Patna, and in midnight, little bit not high velocity trauma, it's a low velocity trauma, and he had pain and swelling like this. And this patient presented to the some other hospital, and the initial treating doctor advised the X-ray, and this is the first X-ray in that hospital, and try to reduce this fracture, but he could not succeed and send the patient to higher center. And this is the X-ray. In this is the clinical picture we have seen here. So how many of us try to reduce this fracture under anesthesia after seeing this picture? Puckering sign or the dimple sign.
The femur and the tibia. So many times it's become very difficult to reduce. Even if it gets reduced, it's very difficult to keep this in position.
So definitely the primary surgeon try to reduce this fracture under sedation, and this is the last one on the right side. This is the X-ray. Although it looks there is the fracture is, the dislocation is reduced, but it is not the X-ray confirm it is still subluxated. It is not properly reduced. So this is a on examination, the ecchymosis and dimple sign or the puckering of the skin on the medial aspect of the knee. So it indicates this is a posterolateral knee dislocation or rotatory knee dislocation of the knee. And there is buttonholing of the medial femoral condyle through the medial soft tissue structure. So never try to reduce such kind of injury. It may lead to the skin necrosis. So in every cases, we go for a CT angiogram. It's normal. There is no any distal neurovascular deficit. And in all cases, we go for 3D CT. And in the CT scan, we can see here there is a bony chunk lying in the posteromedial aspect of the knee joint, or you can say it lie in the intercondylar notch. That is the bony avulsion of the medial collateral ligament from the femoral side. This is the MRI. Although the literature does not support in this kind of injury to go for MRI, it may it takes time, and it may lead to the skin necrosis. So the MRI advice later on once you reduce the fracture, but in our scenario the MRI is advisable feasible in the same hospital. So we go for MRI before the surgical procedure, and it indicates there is a complete tear of the anterior cruciate and posterior cruciate ligament along with femoral bony avulsion of the MCL, and it lies in the intercondylar notch. So my plan is the again examination under the anesthesia. There is a valgus opening of the medial side and laxity anteroposteriorly. So our plan is to reduce this dislocation in emergency, make a direct skin incision over the puckered sign on the knee.
So Gurudev, once patient is in the OT, you haven't tried this one-side arthroscopically and taking out this
No, I just
instead of making such a bigger incision.
No.
No, you need to fix the avulsion part with the screw. So that can be done with this single screw with the Vasa. But you should have tried one orthoscopic method also.
Yes, yes, you are right. It is written in the literature. Some arthroscopic surgeon across the world try to reduce such kind of fracture by arthroscopic method, but it is not feasible in all the time, and it is best possible through the open approach. Directly make the skin incision over the puckered sign, cut down all the incarcerated structure through the medial buttonholing through the medial femoral condyle, then reduce reduce it. You can see here, this is the avulse piece of the MCL from the femoral condyle, and here in the last picture, there is a tear of the vastus medialis obliquus muscle also. So we fix the avulse piece of the MCL with a spike washer and a screw, and use the couple of anchor also to repair the medial structure like capsule, and medial retinaculum, vastus medialis obliquus, and the torn part of the MPFL also. And simultaneously, we applied the external fixator because the knee is not stable. It is highly unstable, subluxating. That's why I put the X-fix. And after 15 days, I removed the X-fix, put on CPM, gain range of movement. And after 6 weeks, again, plan for ACL and PCL reconstruction. And this is the picture, ACL and PCL reconstruction, and the just intraoperative CR picture, knee is well reduced. This is the CPM, and the patient allowed to walk with the walker, with just toe touch with the help, with the wearing the long knee brace. This is the post-op picture after 1.5 years, I think. He sent, and meanwhile, he selected as a IIT, and right now he's studying in IIT Delhi. And he sent this picture from his institute, and he is happy with his range of movement. This why.
So I think the open procedure was rightly chosen because Dr. Arvind, with so much capsular injury, because the capsule is button hold. So doing an arthroscopy with such extensive injury can actually risk the patient for compartment syndrome, and
Because patient is outside already in the OT. Just you have to try it once. It's not the repetitive attempt or not for the longer time. You just do the valgus with the Wissinger rod or with the help of probe. You take out this avulse fragment outside the capsule. And many times it looks very easy if you are doing from inside out. That's why I said this. But always you need to fix the medial epicondyle. For that, you have to give incision. Yes. That's very obvious.
It is written in the literature also.
Medial epicondyle, you have to again open it up. So
incision in that case will be very small. What was the status of meniscus in this case, Gurudev?
Meniscus is okay, fine. It is written in the literature, sir. I went there and read the article. Somehow across the world try to reduce such kind of buttonholing with the help of arthroscope, but it is very difficult. And ultimately, they have opened and then reduce it and fix it.
Yeah, that's why I said give only one chance, not repetitive one.
No, if it is associated with MCL avulsion, which has to be fixed, then I think anyhow you have to open it.
In that case, you have to make very big incision.
Sometimes there can be just
absolutely right, sir.
Capsular rent. So in that case, you can go arthroscopically and do it. But anyway, you did the right thing. Great results.
This is not an ACL avulsion.
So if this would have been apart from the avulsion, the MCL, the medial side injury, would you like to augment your MCL at the same stage? Because I have done a couple of cases. There is residual valgus instability, which is there once 3 months down the line we see. And sometimes we have to augment that healed MCL later on when we are doing an ACL PCL reconstruction.
Sir, mostly prefer to do all these cases in acute setting. My timing of surgery between 7 to 10 days. So in bony avulsion, I just fix it. In soft tissue injury, I do the reconstruction, not the repair. I always prefer to do a reconstruction. That means the augmented reconstruction. Yes.
Himanshu, what I see that in these kind of cases, usually it's not the MCL rupture, the whole sleeve gets avulsed. So you have to fix all that with multiple
All the medial
anchors.
side structures. Well,
Yes.
yes.
Okay, thank you.
Thank you, Gurudev. So the next talk in the series is acute ACL, MCL, and lateral collateral reconstruction repair by Dr. Sheetal Gupta.
So he's a 30-year-old male sports officer and a table tennis player injured in the field 10 days back with a moderate effusion. His range of motion is painful with no flexion deformity. He's got a varus stress test, which is positive at 30-degree flexion and 0-degree. Valgus stress, which is again positive in 30 and 0-degree. Dial test is negative and pivot shift is negative, which is although difficult to judge when there is acute tear. So very gentle examination of Lechman because drawer is not visible in acute injury. A very gentle valgus stress and a varus stress test indicating that all the three ligament, that is ACL, MCL, and you can see there is some contusion on the lateral side as well. And this was the valgus stress view, which suggests MCL injury as well. So MRI was suggesting that ACL was torn. There was an injury to the lateral collateral ligament and even the MCL was torn. So the controversy that we get in the multi-ligament is acute versus delayed, stage versus non-staged, repair versus reconstruction, graft choice, and a tunnel placement. So what we are doing is basically ACL, MCL, and POL and lateral collateral ligament injury. It's a 10 days post-injury. So these are the various choices which are available to us. So what we have started doing off late, particularly in the patient who are having a combined ACL and the MCL injury, like we plan in the 2 stage, we do MCL in stage 1, do a repair, and plan ACL reconstruction in stage 2, maybe after 8 weeks or 10 weeks when there is a patient has got a full range of motion. So in all such cases, what we started doing the scopy and just put a single anchor onto the for ACL repair and explain to the patient that he may require ACL reconstruction in the future. And fortunately, in last 20 cases and from last 2 years, none of the patient has undergone an ACL reconstruction. So we started repairing both MCL and ACL as acute repair, but this was a case in which ACL, MCL, and LCL, all three were gone. So this was again the intraoperative picture, which again confirms the injury to both MCL, LCL, and ACL. And this was the intraoperative finding. So good ACL stem was preserved. You can see a large, huge opening indicating of MCL and POL both. And the dial sign or dialysis sign was positive. So we have decided, because the LCL was from the bony femoral side, so we decided to repair the LCL. We have done the MCL repair. And whenever there is an MCL rupture, which is from the tibial side, I will always augment with the Danish technique. If it is on the femoral side, I will just go ahead and do a repair because the result of repair on the tibial side is not good. So we used the anchor and done the LCL repair. And for the ACL, that what we have done in last 20 cases is the same. We tried to repair the ACL while we are doing the MCL repairs, arthroscopic pictures. We use this cannula of the spinal needle so we don't damage the ACL structure. We use all suture anchor because if you want to make a future tunnel, a patient needs to go undergo ACL reconstruction, the things are easy. We use a central portal to park our all the 3 sutures. And the 1 suture, then we start taking a bite through the enteromedial bundle as well as through the posterolateral bundle. We just take a suture, 1 suture only. And once you pull the 2nd suture, because the suture anchor, automatically the ACL will go back to its original position. This is the thing after the ACL repair. So we've done the LCL repair, ACL repair, and MCL was repaired as well. So this was the picture. You can see ACL healed very well. The MCL has healed and LCL has also healed very well. So acute surgical intervention may result in superior clinical and functional outcome in compared with the delayed intervention. So if patient is presenting within 3 weeks, we can always give a chance if the patient is having a ACL and MCL. But for lateral, I would say the result of LCL repair are not very good. You have to go for a reconstruction. But there are exceptions whenever there is a bony avulsion, either on the lateral side or on the medial side, you can safely go ahead and do a repair. So acute repair of collateral will have a good outcome for avulsion from bone or bony avulsion. Patient should be counseled that it's associated with high complication and low functional outcome. Thank you.
You didn't augment anything, like you didn't augment your MCL repair.
Yeah,
ACL.
MCL I augmented using this Danish technique. I always augment my MCL because MCL is particularly from the tibial side.
Like ACL, could you have used an internal brace in this just to support it?
That was not required. Actually, I'm always thinking that if patient require ACL reconstruction in the future, I don't want anything in the joint actually. So that was the reason I have not used it. And primarily what I explained to the patient that I'm going to do MCL repair. If ACL is repairable, I will just put one anchor. Maybe after 8 weeks, we will reassess you. If patient is quite fine on examination at 3 months, 6 months, he doesn't require ACL reconstruction there.
Siddharth, can we have the discussion after this talk? Both the talks, we can have a discussion together. Dr. Subramaniam.
Good afternoon. I'm actually going to show a full video of how we do PLC reconstruction. So I think we all know that once it has been seen as a dark side of the knee joint, posterolateral corneris, but it's not dark side anymore because we all know the anatomy quite clearly. And if you look into the books, you will see layer 1, layer 2, layer 3. And a lot of structures have been mentioned. But I think for importance in relation to surgical aspects, we need to know about only these 3 structures, LCL, PFL, and popliteus. The reason behind it, they are the primary stabilizers for the posterolateral side. LCL, PFL, and popliteus tendon. This is the one which we are going to do in PLC reconstruction surgery. First and foremost thing important is how to assess clinically. So if you look at this patient, the first thing is most of the time when you have a LCL, PLC injury, they will be associated with ACL or PCL also. So make sure you're not missing those. So this one has got a Lachman positive and Varus test is positive. And then if a dial test is done at about 30-degree flexion, and it's a dial test is also positive. And some of them will have anterior dial rotation also. That is also another significant finding of patients who are having a PLC injury. This is a very first and foremost important point. Next is where to make tunnels for doing a PLC reconstruction and LCL reconstruction. These are the 4 points that you have to make tunnel. One tunnel is for in the tibia, another tunnel is the fibula, and 2 tunnels are in the femoral side. These are the perfect landmarks that we normally make. This is a standard Laprade technique which has been described for stabilizing the posterolateral structures. So fibula tunnel is the first tunnel that I make. And then I make the tibia tunnel. After that, we make 2 femoral tunnel. So now let's go to the surgery in a minute. And the fixation of graft is done. LCL is done in 30-degree flexion with valgus stress. And posterolateral structures are done in 60-degree flexion with neutral rotation. This is the final point of fixation. So let's go to the surgical procedure as such. So the patient is in a supine position with around 90-degree flexion. The incision is done from the lateral epicondyle to about Gerdy's tubercle. Raise a posterior flap. And first thing is to make sure you release the common peroneal nerve. Because once you release that nerve, then we are very safe that we are not going to damage it. It's isolated very well. Always, if you don't do that, then it always lingers in the mind whether are you going to damage the nerve or not. So identify it, release it, go right up to the peroneal fascia and release the peroneal fascia also so that the nerve is fully released from the proximal to distal end, make it completely isolated. And that is a first and foremost step that you do in whether it is a LCL repair, LCL reconstruction or a PLC reconstruction, do both at the same time. So now what I am doing, releasing the peroneal fascia. After that, dissect space between the biceps and gastroscolius to reach the posterior aspect of the head of the fibula and posterior aspect of the proximal tibia to identify the popliteal sulcus over there. So next step is to make a fibular tunnel. To make fibular tunnel, make a small incision over the peroneal fascia on the neck of the fibula region, dissect right down to the bone, and place a small Hohmann's retractor on the anterior aspect and another Hohmann's retractor on the posterior aspect, so that you have an exposure of the neck of the fibula region, which is about 1.5 to 2 centimeter from the head of the fibula region. That's where your entry point, that has been classically described as champion glass appearance. That's where you normally put your tunnel for the fibula. The direction for the tunnel is from anterolateral to posteromedial. What you are trying to do is to make an oblique tunnel, which is as per the description of the fibular insertion of the LCL, and make a pilot hole with the help of the owl. So it makes easier for your bead pin to go through that. And pass the bead pin. While you're passing the bead pin, make sure you are protecting on the posterior aspect with some curette or some kind of soft tissue protection in order to not to damage any soft tissues over there. So once you are done with the bead pin, then use a endoreamer. And then my usual tunnel diameter for the fibula side is 6 mm. The 6 mm reamer is passed through because the graft diameter is around 5 to 6 mm only for the LCL. So again, do with the protection around with the curette and pass a suture material through that and keep it ready. Next is making the tibial tunnel. Tibial tunnel is made about 1 centimeter distal to the girdis tubercle and slightly lateral to the girdis tubercle. That's where the entry point for the tibial side. Use a jig, tibial jig, use about 50-degree angle for that, and make sure you keep watching on the posterior aspect so that you don't damage any soft tissue over there by keeping a curette over there, and make one bead pin and then 6 mm reamer, 4 mm reamer, and then the 7 mm reamer. Standard sizing for me for a posterolateral is about 7 mm for the tibia side. You don't get anything more than 7 mm. So once you have done that, use a suture material to keep it around with the tibial tunnel. So now we are done with the fibula tunnel and the tibia tunnel. Then you have both tibia and fibula is first addressed, and the next step is to go for the femoral side. The femoral side is you have to incise the IT band and expose the lateral epicondyle, and also about 2 centimeter distal to the lateral epicondyle also have to be exposed. So feel it, lateral epicondyle is a very prominent structure. You cannot miss it. Very nicely you can feel it. And just proximal and slightly posterior, about 2 to 3 millimeter proximal posterior to that, you can use insertion of the lateral collateral ligament is there. Pass a pilot hole with the help of the owl, and then pass a bead pin and try to aim it slightly anteromedially, so that you can avoid the ACL. This patient had a ACL reconstruction, so we are avoiding that. So make it right to anteromedially and pass a bead pin. And then after that, similarly pass the endoreamer. The endoreamer has to go from the near cortex to the fore cortex also. But when you do the 7 mm reamer, it goes only through the near cortex, doesn't go through the fore cortex. So that is a standard technique for the LCL ligament. And then for the PLC, the insertion point of the PLC is about 1.8 centimeter distal to the lateral epicondyle, slightly anterior and slightly distal to that, and measure it with the help of your measuring scale, and then identify the right origin point of the PLC, which is the popliteal tendon, and then make an diathermy marking over there, and then use an owl and make a pilot hole. After that, use a bead pin and use your bead pin and then endoreamer and then 7 mm reamer for the popliteus also. So you try to do it exactly parallel to the LCL tunnel also. So you have 2 tunnels on the femoral side, one tunnel on the fibula and 1 tunnel on the tibia. These are the main tunnels that we have to make for doing a complete PLC reconstruction as per the Laprat technique. This is. So once you are done with that, then it's a stage of passing the grafts. The first graft I pass through is through the PLC for the femoral side, and the graft is usually the hamstring graft. And semitendinous is for the PLC, and LCL will have the gracilis graft. And pass through that, and then pass the gracilis graft through for the LCL through the lateral epicondyle. So once you have done those two, then pass underneath the IT band and bring those 2 grafts underneath the IT band So that graft is about 7 mm. The gracilis graft is around 6 mm. So once you have done that, you pass the fibula graft from anterior to posterior, LCL graft. And you can put a screw on the fibula. If you're putting a screw, you can put a 6 mm screw for the fibula, because a 7 mm screw or 8 mm screw can be quite big and you can sometimes break the fibula neck. So use a 6 mm screw and then pass those two graft, both ST and gracilis, towards tibia from the posterior to anterior, which will actually cover the PFL ligament as well as the PLC ligament. Next is application of screws at about 60-degree flexion and a neutral rotation for the PLC. The first is putting the screw for the femoral side of the PLC, and for the lateral epicondyle is the next one. But it'll take another 2 minutes. And once this putting metal screw just for the, you can use a bias screw also, it's not an issue. And for the tibial side, then you have to put your proximal screw from the tibia from the anterior to posterior. That is kept at 60-degree rotation. 60-degree flexion and neutral rotation. So that's the almost end of the technique of the PLC reconstruction. If you have chronic PLC insufficiency, that is different ball game. This is I'm talking about chronic PLC with alignment problems. Here, what you have is 3 problems: varus problem, posterior translation of tibia, and they might have slope problem also, where they have reduced posterior tibial slope. You have to address all the 3 together. You have to do that. By doing that, what you are doing is trying to stretch the PCL and posterolateral capsule out by altering the posterior tibial slope. Here, this is the second patient with the PLC insufficiency with valgus and altered posterior tibial slope. Has got a very low posterior tibial slope. Here, the treatment is doing the correction osteotomy, slope correction osteotomy, and also the varus correction osteotomy. Correction which differential correction with anteriorly keeping slightly wider than the posteriorly. By doing that, you can actually adjust the slope to 3 degree to 11 degree, can correct the posterior translation, can correct the varus deformity also. As 6 months post-op. So take-home message is acute tears, grade 1 and 2, you can treat non-operatively. A grade 3 tear will need repair and reconstruct together. Only place where you can do just repair is if you have a avulsion fracture, where you can just fix with anchors. You don't need to reconstruct those kind of tears. Chronic tears with no deformity, you can go for PLC reconstruction. If they have a chronic tear with deformity, consider for tibial alignment correction also by doing osteotomy. Thank you.
Can we have a talk by Dr. Kanchan Bhattacharya on the medial side injury, and then we can have the discussion.
So I'll speak about MCL injuries and just find out what the literature tells us and how we have changed over the years in the treatment of MCL injuries. We know that the function of the MCL is primarily a stabilizer of the valgus force, but it works in tandem with the anterior cruciate ligament. It resists external rotation. And MCL and ACL, they have a codependent behavior. History is usually have a valgus injury. On examination, we can find valgus opening, tenderness of the medial side, and we have to test valgus at 0 degrees and 30 degrees to find out which part of the MCL is torn, if at all. It's a very common injury in sports. The vast majority are a sprain, where only some fibers are torn, which could be a type 1 or a type 2 or a type 3 when it's a complete tear. Now, when it's a complete tear, and today we know that it can be avulsed from the femur, it can be avulsed from the tibia, or it can be a mid-substance tear. And they all behave differently. The one that's avulses from the femur has the best prognosis, regardless of what you do. The one that avulses from the tibia does not heal on its own and does not heal too well if it's just repaired. And an intrasubstance tear, though it's not as common, when it's repaired, it only heals by scarring and probably not too well. So that also would probably need an augmentation. We need an X-ray to exclude any bone injuries like an avulsion, but it's an MRI that tells us the most, and it also tells us which part of the MCL is gone. And then we come across how we treat it. Isolated MCL injuries, grade 1 and grade 2, is a no-brainer. You always treat them conservatively. You do not immobilize them for too long, because that impedes the coaptation of the collagens, and you have more stiffness, and the scarred ligament do not behave as well as the normal one would do. So movement actually helps in growth of the ligaments in the way it should be. It normally has a fairly speedy recovery, but in athletes, especially footballers, should be kept away for at least 4 to 6 weeks. Messi was kept away for 6 weeks. Grade 3 injury, and this is where we are kind of changing a little bit, as literature will show. Again, the vast majority of an isolated MCL will probably heal quite well on its own, but a fair number of them would need either a repair or a reconstruction. And it depends on the patient profile, on what is to be needed, and whether to start with it was a valgus knee or not. When you look at the literature, we find that the earlier literatures for a chronic MCL injury, if it presents late and presents with pain, that it's actually something to do with a deep MCL, and a single shot of steroids seem to do very well. And this is pretty well followed by a lot of sports persons in all around the world. In the newer literature, you find that the primary MCL reconstruction has gained in popularity, both arthroscopically and open, but especially for the tibial avulsion. People do not stay around and wait for it to heal on its own, because it will not. The vast majority are in favor of repair as some kind of augmentation, and some would carry on with repair alone. The results are, well, still does not tell us on acute stage whether you should reconstruct them or repair them, and you are probably both would be right. In a chronic MCL injury, the chronic results of MCL complex, should it be left to linger for too long, might present to you with pretty ugly deformities in valgus. And if you have a deformity as bad as this is what would need probably an osteotomy, probably a reconstruction, and in addition to capsular plication, advancement POL, and going the whole 9 yards. So in today's context, when in doubt, you do not wait for it to heal conservatively. You go ahead earlier and do something so that you do not land up with this kind of issues. The next is ACL and MCL, again, which is very common. Literature says the vast majority of ACL injury with MCL injury, you treat the ACL and the MCL takes care of itself, which is probably true. And in the early literatures, like in 2008, even in chronic ACL injuries with grade 3 MCL injury, ACL was reconstructed, MCL was treated conservatively, slightly for a longer period in brace, and the results were pretty similar. It was similar to the isolated ACL injuries in a cohort of something like 200 patients. Again, operative for ACL, non-operative for MCL, waiting for a certain period of time for the MCL to be asymptomatic, like we heard earlier. Again, the results were pretty good, which meant that in these situations, the MCL was not repaired, was treated conservatively altogether. Then ACL in 2010, Laprat and Wisdix, when they already described the anatomic MCL medial side reconstruction, in JBJ's reported that for combined ACL and MCL injury, the consensus is that you fix the ACL, and conserve the MCL. In the rare circumstances when you do decide to do something for the MCL, you go ahead and do either an anatomic repair or an anatomic reconstruction. That was in 2010. Again in 2011, chronic MCL laxity, chronic ACL tear, you repaired the ACL, or you repaired the MCL and end the ACL. Is there any difference? At the end of 3-year follow-up, there's no difference between the two groups. But now you come to a systematic review in 2022, MCL and ACL reconstruction. The ACL has been reconstructed on all situations. MCL has been treated conservatively, has been treated with repair, has been treated with reconstruction, and all of them have kind of similar outcomes. So the onus lies on you to decide what you want to do. Whichever you do, if you do it with good faith and good understanding, you are still on the right side of the law. You won't be probably taken to court for either one of them. PCL and MCL again is slightly different. In most situations, the MCL will need to be addressed either together with MCL or on different situations. But in most situations, when you have a PCL grade 3 with MCL, it will need to be addressed one way or the other. When we look at the MCL reconstructions, among the first reconstruction that was reported in literature was by Bosworth in 1952, where he used the semitendinosus attached distally. But it was the distal attachment was a little anterior. He initially reconstructed that part of the MCL. The first modification was looping it back and creating a second layer on it. The next one was an anatomic of Pagnani. Again, this is a free semity tendon, a semity graft, single point at the femur and 2 at the tibia. Then 2010 and 11, Laprade described his technique where he used 2 separate grafts to reconstruct the proximal and distal attachments of the MCL, the tibia and the femur, and a separate for the posterior oblique ligament. There have been some variations of which one is very popular with a lot of us, the one that Amit Joshi has described as weave technique, where you leave the semitendinosus attached distally, weave it around so that the tibial attachment approximates the tibial attachment posteriorly, bring it up to the femur, attach it femur, but you have only one attachment to the femur, not 2, and then loop it down again and do the POL with it. There are a few other variations. All these rely on a couple of important factors, that the MCL has to be reconstructed according to its original route, as anatomical as possible, and the POL needs to be reconstructed. Whether you want to reconstruct or you want to repair, the literature says that you probably have good outcomes with both repair and reconstruction, but the failure rate of repair is more and the stiffness rate of repair is more than that of reconstruction. In operative management, medial collateral ligament and multiligament injuries, it has to be case-based decision. Nobody really still knows if you have all the 4 ligaments gone, whether you want to do the cruciates first or the collaterals first. So it's case-based, and all of them in their own ways have good results, provided you keep the axis right, whenever you reconstruct, whichever ligaments you're reconstructing. The prime complications of the medial side injury are both residual laxity if you've not corrected it properly, and stiffness if you're repairing it too often. In summary, isolated MCL injury can almost always be treated conservatively. Look for the presence of ACL. Always treat each case on its individual merit. And MCL is a part of a multiligament injury, is a completely different animal that needs to be addressed more actively. Thank you very much.
So all the 3 talks are open for discussion.
Hello, Sheetal. Sheetal, why didn't you reconstruct the ACL in these cases? What was the rationale behind reconstructing the MCL and leaving the ACL repaired?
Because in acute stage, I don't do ACL reconstruction. So ACL is always reconstruction is always a delayed procedure, and repair is always the acute procedure. MCL is an extra-articular structure; it's not an intra-articular structure. So if you do a reconstruction at the same time, you need a real good rehab. You want to protect the MCL. So combining acute ACL reconstruction along with MCL repair, I think is not very feasible. Lot of chances of orthofibrosis is there. Although LaParade is doing everything in acute, all reconstruction, ACL, PCL, MCL, LCL in acute within 7 days.
When you repaired, so your rehab was
Rehab is almost same like you do for MCL. It's a non-weight bearing strictly for 6 weeks. So I'm just giving a chance. If that heals ACL, well and good. Otherwise, I will go ahead in second stage and do ACL. Imagine it this way, any patient with acute ACL and MCL, what is current treatment protocol? Current treatment protocol is either 2-stage, you repair ACL and do ACL reconstruction to second stage, or option is acutely you do MCL repair with augmentation and do ACL reconstruction, which in literature show there are a lot of chances of orthofibrosis. So few people are doing it. So what is my thought process is, once you're doing a MCL repair, let's go ahead and do ACL repair. If it doesn't work, I will go ahead and do ACL reconstruction.
So you think that ACL repair is gonna cause less arthroplasty vis-a-vis reconstruction? That is a
absolutely.
thought process.
Yeah,
behind
because ACL reconstruction is the end procedure. You understand one thing. If orthofibrosis happens, then you don't have anything in hand. If ACL repair, something happen, you still have got a lot of options because there is no implant is there. You can very well take care of that orthofibrosis and go for reconstruction in the second stage.
Two thoughts, Sheetal.
ACL reconstruction after MCL, once acute ACL instead, when the patient has got a full range of motion, maybe 5 days, 15 days, 1 month, a good course control.
Exactly. So Sheetal,
I actually don't do ACL immediately, but I make sure the patient has got range of movement at least 120 degree. Swelling has settled down.
Absolutely.
And they are having good quadriceps
So
power.
that will happen when this patient has got an isolated ACL. If you see a patient who's got both ACL and MCL, there are few chances that patient will have a good range of motion. So
if in case we are able to achieve this ACL 120-degree movement, good quadriceps function, and less swelling, you can do ACL.
Absolutely. So if patient comes to me, say at around 20 days, 15, 20 days, and has got a good range of motion, I will do ACL reconstruction and MCL repair. So depend on case to case. No, if MCL is gone for femoral side, I will not do any surgery. So this is only when there is a tibial side. Yeah, absolutely. So ACL, MCL, acute, where MCL is gone from the femoral side, I would like to conserve, like Kanchan sir was also suggesting, wait for MCL to heal, wait for 4 weeks, 6 weeks. If you feel that MCL is healed, go for a valgus stress view. It has healed completely. Go for isolated ACL reconstruction at 6 weeks. If valgus stress is suggesting that MCL is not healed, I will go with the ACL, MCL reconstruction.
So you will, so in case of multiligamentous, you will do collaterals first, and in second stage you will do cruciates.
So again, if patient is coming to me with acute ACL and LCL, I will just wait for 6 weeks. I will not do anything. I will go ahead and do a reconstruction of ACL and LCL because result failure rate of LCL repair is 30%. And if you compare with the MCL, the results are quite good.
What if instead of ACL, you have got PCL?
So PCL along with MCL you're talking
PCL
about?
along with-
PCL along with MCL again remains the same. If the MCL is on the tibial side, I will do the MCL repair in stage 1, put the patient on a brace, let the thing settle down, and then second stage PCL reconstruction.
So my question to Subra sir. Sir, do you do LaParedes in all your PLCs, or do you have a rationale to select that? Because
No,
if it's a combined injury, ACL, PCL, and an LCL or a PLC injury, there are too many
majority of them
tunnels
will
to
get
handle.
LaParade.
So,
But somebody having only isolated LCL, like without much sectional rotation deficit, or not dialysis much positive, the mild one, then I just do Larsen technique.
10
Yeah.
years. I haven't.
Same. Arcerio.
I'm
Same.
doing Arthroscopy from last 10 years, almost more than 10 years. And I don't face any problem.
You're talking about Larson's or Arcerio technique?
Arthroscopy.
Arcerio, yeah. I'm doing the same.
And the literature says you do LaParade or you do Larsen. Result are the same till now.
No, I mean, Larson is different from Arcerio because Arcerio.
No, I'm talking about LaParade and Larsens.
Okay.
The result of both are same till now.
I've been doing only Larson's and results are good.
Larson's.
Yeah.
So in the Larson's, you don't reconstruct, you don't put the popliteus tendon tunnel. In
Larson is-
arterial, you add on a popliteus. So that is more anatomical as
purely for
compared to.
LCL.
Yeah.
Larson doesn't address the
Yeah.
popliteus.
Larson's, yeah, Larson doesn't address. So if you got a proper dial test with grade 3 posterolateral, I think Larson probably may not work.
So it depends on clinical assessment.
But literature is giving equally.
Literature is giving for Arvind for arterial with laparate. But
No,
if you compare
Larson
also.
and Laprade having
Literature
equal
has Larson's also same. Long-term results same.
that is modified Larson's. Yeah, 2 femoral, yeah. 2 femoral, 1 fibula, yeah.
Modified Larson will have a tunnel for PLC also on the femoral side, not on the tibial side.
Message, I mean, when to do Larson, to do Laprade.
So Laprade is more anatomical.
More anatomical.
Though it
But it's very
requires
complex, I mean,
a bit-
very
though it
confusing.
requires
It's
a bit more
totally-
effort as well as graft. So if you have shortage of graft and all that, you can think of modified
So,
Larson all that. But
It depends on the demand of
clinical
the patient.
evaluation. If you
Yeah,
clinically
absolutely.
only varus test is positive, then I do for Larson.
Yeah.
If there is element of dial test positive, then I definitely go for Laprade also.
So one more point, if patient is having a hyperextension, that is a recurvatum test positive, I will do a classical anatomical Laprade. If that recurvatum is
Correct.
not there, I will do arterial.
Yes, yes.
Yeah. So a reconstruction of all, yeah. And
That way you could need to do all ligaments if you do Laprade. Then you would need access.
yeah, now with the peroneus, we got a contralateral two-sided peroneus, opposite sides, semity gracilis, BTB opposite side, CQT opposite side. So at least 8-9 grafts are still available. But I agree. I mean, Laprade is this thing. So a patient is, I think, low demand. You can very well manage with anything. But high demand patient, definitely anatomical Laprade would be a better answer.
Himanshu, I think this discussion can go on. Okay, one last question, and then we.
The classical teaching of waiting for a couple of weeks in a multi-ligament scenario still exists.
Yes. So there are.
So
there are-
again, if there is an acute tear and avulsions either from femoral side or if there is a detachment from the bony side, you should intervene early because the chances of healing is better.
See there, initial MRIs for the extension, there is a cross stability. Patient has been put in plaster for a couple of weeks and they have certain amount of it. And that makes your job very difficult. So maybe sometimes in high velocity injuries, so much of bone fractures and everything, we are intervening early, we are netting up a lot of arthropendrosis.
Absolutely, I agree.
Still, I think a couple of weeks just in slab, etc.
Absolutely. So acute ACL, MCL, and posterolateral corner, I will wait. I will just do a reconstruction, everything after.
I think one word of important thing is any acute injury, I don't operate within 3-4 days. Leave for 5 to 7 days. Any capsular tear would have healed.
Absolutely.
So wait for 7 days. That is also still comes under acute category. Up to 3 weeks, it comes under the acute category, and then only becomes a chronic one.
No, posterolateral corner, you will never repair. Posterolateral corner, always go for reconstruction. That is proven worldwide that PLC never repair.
If you are repairing, repair and
So,
augment.
Yeah,
Augment,
you
correct.
do reconstruction.
So I think with this, we stop this session and we move on to the next one.
Thank you, Chairperson. We are going to start the next session, osteotomy and cartilage session. So we are inviting the Chairperson, Dr. Subramaniam, Dr. Bhattacharya, and Dr. Vinod Thakur. Please come on, guys.
So first speaker is osteotomy for the failed LC, Dr. Neeraj Saxena. Sorry, Dr. Neeraj Srivastava, please. Sorry, I'm sorry.
Thank you, sir. I would like to thank Dr. John, sir, and Dr. Arvind for this invitation. It was a wonderful course. So I have 2 cases to present. Sir asked me to present 1 case. Cases of failed LCL injuries and what we should look for failed LCL and chronic LCL injuries. Dr. Subramaniam has already told in his talk in the last 2 slides what we should look for. So I'll just skip this. I'll just go to the cases directly. So this was a case which was LCL with PLC, and there was an avulsion which was fixed and it failed after weight bearing. As we know in the literature, the failure rates are almost 30%. Second surgery, La Prade anatomical fixation was done and PCL reconstruction was done. And as we all see that after seeing the La Prade reconstruction, we feel that it is very strong and very robust and it is not going to fail. Of course, the weight bearing was delayed for this patient almost 1.5 months. But again, once he started walking slowly, in 3 months, it failed. And there was a gross varus, thirst when he was walking. He was not able to walk without a long knee brace. So what went wrong? When he came to us, we got a standing scanogram done. So this was the knee. You can see there was a gross varus in his knee. And this was the reason, which was the reason for the failure. This was his intra-op under anesthesia. You can see almost 45-degree we can go. So we planned for medial open wedge HTO with slope changing because the PCL was also failed in this patient, the reconstruction. So simple HTO with slope changing was done. And on the table itself, the knee became stable and we didn't add any soft tissue procedure for the lateral side. The knee was stable even in the valgus stress after medial open wedge with slope changing for the PCL and for the PLC injury. This was another case which was a ACL reconstruction with reconstruction for lateral structures. I don't have scanogram for this patient. I just have a long leg X-ray. And in this also we can see there was cross varus, which was probably missed during the initial surgery. Again, middle open wedge osteotomy with a plate was done. In this, I added a Larsen procedure also because it was not very stable after the osteotomy alone. And this patient also on table, it was stable after osteotomy. So look for varus malalignment in cases of PLC injuries. And if there's gross varus, you can compare it with the opposite knee. Go for primary correction because, once the patient starts walking, there'll be thirst on the lateral side and eventually the soft tissue graft will fail. If there's malalignment, no soft tissue procedure, however robust, can hold it for long. Thank you.
Thank you, Neeraj. We'll have questions at the end of the session. So Dr. Srivastav has some issues with his laptop. So can I call Dr. Ratnesh Singh, HTO with oats? Dr. Ratnesh Singh, not here. HTO with medial meniscus root repair, Dr. Vineet Jain. Vineet was here. Oh, Vineet ready? Yeah. Okay. Dr. Avinash, are you ready? Okay, we'll have you. Dr. Avinash. Patellar tendon injury? Right. So Dr. Avinash Kumar will tell us about patellar tendon avulsion.
It's a chronic patellar tendon tear, not a avulsion.
Meanwhile, Dr. Sasi, can you join on the dais as a chairperson?
क्या करूं मैं? So good evening, everyone. Thank you, Arvind sir and John sir, for giving me a chance to present my case. I'm presenting a chronic patellar tendon rupture in a geriatric patient. This patient was 70 years old. Normally, patellar tendon rupture happens below 40 years of age, and generally it is mid-substantial. Avulsion is very, very rare, and if it happens in older age group. So this patient was 70 years old, was a hypertensive diagnosed 2 years back, was diabetic diagnosed 2 years back, had a road traffic accident. He was walking by side and hit by a bike. And he presented after about 25 days post-injury with a difficulty in extending the knee. You can see only about 20-30 degrees extending, then he's using his thigh and the hip to extend the knee. Then in radiology, it showed that there's a patellar rupture. It's a mid-substance rupture in a 70-year-old guy. There was also a partial retinaculum tear. On X-ray, there's a patella alta with CD ratio about 1.3. So indicating that there's a patella alta. In literature, for acute tear, tendon to tendon suturing can be done, but healing is not good tendon to tendon. That's why it's now recommended to always do a tendon augmentation for a better outcomes. And if it is avulsion, then we can use suture anchors for that same. For chronic or neglected patellar tendon tear, we use either hamstring or BTB. Hamstring is more common. And a different configuration, like we can go for a figure of 8 configuration, or we can do a parallel rectangular configuration. So in my case, there was definitely a retinaculum tear. The tendon margins were flimsy, but I was able to oppose the tendon margins. So I sutured the tendon margin and augmented with a hamstring graft, tunneled in the tibial tuberosity, and then the two ends was passed through the 2 parallel longitudinal tunnels in the patella and sutured on the superior side along with the retinaculum. Somewhat like this. So it was a doubled semi-tendon gracilis, about 4.5 mm was the diameter. 2 tunnels were made it, and it was the tendon was removed from the tibial tuberosity and it was made rectangular. It was sutured superiorly, and all the extensor apparatus were sutured. There was a gross retinaculum tear. Incidentally, there was a quadriceps rent also in the superior part, as you can see there. Might be that helped me to oppose the patellar tendon better. And later it was sutured too. In the post-op, a cylindrical slab was given for 3 weeks. Patient was diabetic, went home after 3 weeks, presented with the infection. It was superficial infection. It was debrided, it settled down. I gave cylindrical slab more for 2 to 3 weeks more I gave it. And then gradually ROM exercise was started. The post-op X-ray, the patella alta was rectified. The CD ratio came to 1. And the extension was increased, but still some lag was there about 10-20 degree. In literature, I searched the oldest patient they have reported is 47 years and 57 years. I've never seen an article where the 70 years of a patient, geriatric patient has a mid-substance tear of a patellar tendon. So for a geriatric patient, even if we are able to oppose the patellar tendon, it's better to always augment the tendon with hamstring graft. Retinaculum and extensor apparatus must be repaired thoroughly, and over-tightening of the tendon should be avoided to avoid patella baha. Thank you.
Thank you. I think we'll go for the next talk by Dr.
Hello.
Jain.
While you are repairing the torn part of the tendon, how could you decide that this is the exact level of the patella?
So intra-op CM, I checked it to look for the patellar, whether it has come down or not. The alta was there. So
Yes.
So lateral view of this CM, if it is at the Bloomshed line, it means I'm not over tightened or not loosened it.
So it is from the house.
And Patellar tendon. Like ratio is 1.2.
It is better way to compare from the opposite side. Okay.
Yes.
I think we'll invite Dr. Vineet Jain for his talk on HTO with medial meniscus root repair.
Thank you, everybody. I'd like to extend my thanks to Dr. John Mukhopadhyay and Dr. Arvind for inviting me here, giving me a chance in this case. Do we have a pointer with us? So I'm just going to present a knee case as an case scenario. So the case I'm presenting is a 48-year-old female who presented with the history of pain in a right knee for last 1 year with difficulty in activities of daily living. It's something a very common scenario which comes to us in an OPD on a regular basis. A middle-aged fat female comes with knee pain. Patient has been on conservative treatment for quite some time, but still had no relief in her symptoms. Well, while we examined her, she had a mild genuverum, crepitus in the right knee. She had some medial joint line tenderness. Lachman test, McMurray was negative. Varus and valgus stress test is negative. Range of movement was 0 to 120 degrees, which was terminally painful. And her BMI was around 28. Again, just I said, a middle-aged female having knee pain. Now, the next investigation, which most of us do, is the X-ray of the patient. So when we did the X-ray of the patient in AP standing lateral view, what we found was that it was a medial jointless, medial joint was decreased. On the lateral view, there was no significant patellofemoral arthritis. The lateral view was normal, just a medial compartment osteoarthritis. We went for a scanogram. Now, scanogram showed us an 8-degree varus between the mechanical axis of femur and tibia, and the medial proximal tibial angle was, well, this is wrongly mentioned, it was 79 degrees on the right side, and it was 83 degrees on the left side. Next, we got an MRI done. Now, why did we got an MRI done? Normally, in these patients, you do not get an MRI done. You treat them like a patient who has a medial compartment osteoarthritis, middle-aged female, you treat them conservatively. But what I have realized in my practice is that a lot of these patients who come with an early osteoarthritis have a root tear, and that's what we found. So you look at here, you got a medial meniscus posterior root tear, and there's extrusion of the medial meniscus. Now, it is this extrusion of the medial meniscus which makes their MCL painful. And this is what causes them pain. And after some time, you will see there's a small amount of subchondral edema, which now develops on both the femoral and the tibial side because of the loss of the cartilage in here. See the T1 images. This is the medial compartment. You can appreciate the some amount of subchondral edema and the loss of cartilage. Well, in the lateral side, you see a good cartilage on both the femur and tibia. So this is the lateral side. This is the medial side. So again, you've got a medial compartment away with a medial meniscus root tear. Now, how we are going to manage this patient? Usually do not get an MRI done. You got an MRI done, you get a root tear. So we had a case in the beginning of our conference today. Usually what we do is we continue with conservative treatment. Now, what does this conservative treatment consist of? Usually you have analgesics, fomentation, rehab. Maybe few people will go for an intra-articular injection if the patient persists with the complaints of painful knee. Surgical management. Do you go for a medial meniscus root tear repair or not? Now, when we talk about surgical management, how are we going to deal with this? Are you going to offer a UKR to this patient? Well, some might even offer a TKR to this patient. A medial meniscus root repair alone, a HTO alone, an HTO with a medial meniscus root repair combined. Well, this is what we did. So we did a high tibial osteotomy. I usually put a iliac crest graft in my patients whom I do a osteotomy. and I do a root repair. So this button just shows the center button is the part where we did a root repair, we did an HTO, and we fixed it with a Tomofix type of plate. Now, what is the significance of these root tears? Now, the problem is that they act as total meniscectomy. So they lead to very rapid deterioration of the knee and may even lead to SONC. And this is what we are calling it now as a silent epidemic. Silent because you do not expect it. Patient does not have any significant history of trauma. They just come with pain on the medial aspect. And you see them, they got a middle compartment away. You get an MRI done. You might find a root tear. In some patients, you do not see a root tear. But there is extrusion of the medial meniscus. The root is getting stretched out. It's a degenerative thing. Now, this is a small video of the medial meniscus root repair. So this is the root tear that you're seeing. We're using a fiber wire. We use a cinch. We create a cinch. So this is the first cinch which come in. We usually use 2 fiber wires, 2 cinch we create. You see the medial compartment osteoarthritis. This is the second cinch that we are passing. The second cinch goes in. We use a suture pull-out technique. We remove the cartilage and pull it through. And besides this, we have started doing centralization also. Now, centralization procedure becomes more important in cases we have a lateral loss of cartilage also. So we use a all suture anchor. We put it on the edge. This is the first suture which comes. You use a simple lasso which you use in your instability repairs to shuttle the sutures. This is the first sutures get shuttled in. And this is the second suture we shuttled in. And you simply tie the knot. So now we come to the technical points when we're doing an HTO with a medial meniscus root repair. So you do a diagnostic arthroscopy, you do an HTO, you fix the posterior most screws and you leave the interior and the middle screws. You fix them distally, and now you do an arthroscopy, you do a root repair and shuttle the screw, pass them down. Once you pass them down, you leave the drill bit inside it. Now you put in the interior screws so that they do not coincide with the tibial tunnel. And then you pull the sutures through. So this is a technical point when you're doing an HTO with the medial meniscus root repair, almost like that you do an HTO with an ACL reconstruction. Now, we had a query in the morning. I think Dr. Praveen had talked to us about this scenario, and there was an issue whether we do a medial meniscus root repair along with an HTO or not. Now, Hian et al. Said that HTO alone is good enough and specific meniscus treatment is not required and medial meniscus will heal on its own. And whereas deformities has been identified as a risk factor for a medial posterior root tear. Another author, Kyang et al. Reported 20 patients who had HTO with medial meniscus root tear without a meniscectomy or a pull-out repair, and they were available for a second look arthroscopic surgery. And they found that a lot of these patients had a high rate of medial meniscus root healing following HTO with no attempted repair. But the degree of healing of medial meniscus root was variable in these patients. Now, it has been argued that HTO alone is sufficient and medial meniscus root repair is not required. But recently, 3 recent studies, the total of 303 patients have reported that medial meniscus root repair did not influence clinical neurological outcome. So theoretically, deformity correction combined with root repair makes sense, but it can result in better outcomes. So as expected, comparing root repair alone with root repair combined with HTO has shown greater healing rates and regeneration of articular cartilage. So if you look at biomechanically, if you do a root repair along with an HTO, that will have a better outcome as compared to an HTO alone. But if you do an HTO alone and do not do a root repair, well, you're not committing a sin. But if you do a root repair along with an HTO, that will likely to have a better biomechanical outcome. So the take-home message is a middle compartment away in middle-aged patients can be accompanied with a medial meniscus root tear. Long-term outcome results of HTO with root repair are awaited, and jury is still out on the final verdict whether you need to combine root repair with HTO or not, though it is technically challenging. Thank you.
So thank you, Vineet, for your nice talk. Now I call Dr. John Mukhopadhyay for his expert talk on evolution of HTO, tibial osteotomy.
So I guess everyone must be impatient to get back, hoping that they don't get stuck on the roads back. So I'm going to try and be brief. Okay, so we're going to talk about high tibial osteotomy and its evolution. And really, there's been a long history. And in the English literature, it was first written up by Jackson way back in 1958. However, the osteotomy of the knee has really a long history dating back to the 19th century in the German literature. Since the 2000s, there have been various articles which have been looking at the progression of osteoarthritis with malalignment. And these articles by Sharma et al., Miyazaki et al. Show that when you have a significant varus, the osteoarthritis will progress over a period of time. Similarly, the study by Felsen et al. Showed that a frontal plane deformity of more than 3 degrees leads to osteoarthritis and should be corrected. And if you have 4 degrees or more, then the odds are 3 times to get osteoarthritis in these patients. And progression can go 10 to 20 times faster if you have a significant deformity. Interestingly, osteotomies really became popular after this article by Coventry in 1965. This was also followed by, which was a closing wedge osteotomy, high osteotomy. The opening wedge osteotomy was popularized by Honeygu in France. Of course, at that time, you needed bone graft because you did not have a very good way to fix it. Pudu introduced the interpositional plate, and then the Ilizarov methods of correction using gradual distraction also came about. Honeygu's paper came out in 1987. Mackay's paper came out in 1986, and this was a dome osteotomy. Interestingly, the dome had its apex distally, and so you ended up having to get more translation than you required because the center of rotation was further away from the region of the deformity. Interestingly, Coventry wrote a second paper in 1993, and subsequently there were other papers which showed that the results of the osteotomy petered out with time. So if in Coventry's series at 5 years, he had a successful result of 87%, by 10 years, it was down to 69%. Similarly, in papers by Ritter and Feckman and Honeygu, etc., the good results of 5 years tapered down significantly by 10 years. So one looked at the results of these osteotomies, and they found that, Berman et al. Found that the 10 poor results were really related to, one was the poor indications and selections for the osteotomy. And similarly, this paper by Chilag et al. Found that the ones that had poor results probably did not have proper technical corrections that were required. So there were either undercorrections or overcorrections and joint penetrations. While the ones with good results all had technically correctly performed osteotomies. So the inference was that for the HTO to be successful, you had to have the right indication in the right patient with the right amount of correction obtained, and your technique and your soft tissue considerations all needed to be taken into account. One can keep looking for the ideal candidate and never find them, because if you look at these, you very rarely get a thin, active patient who only has unicompartment problem with no patellofemoral symptoms and a perfectly stable knee with full extension. So you do stretch the indications a bit, and obviously your results are going to be compromised. But what is important is your preoperative planning in terms of the level of deformity. You need to be sure that your deformity is in the tibia, not in the femur. You need to look at the joint line. You need to look at the sagittal plane and also at any ligamentous laxity. And these principles were brought forward by Dropelli in his article in 1994. So the question was, is 5 to 7 years really the endpoint? What are the inherent limitations? And the other fact was that people talked about TKR after HTO being a problem. So if you look at the more recent studies, Naudi et al. Showed a 10 to 22-year follow-up of closing wedge osteotomies with 80% survivorship at 10 years. Sprenger et al. Had 90% survivorship at 10 years. And then there were various papers from various Asian authors in Korea and Japan, which showed really fairly good results, even as long as 24 years after the surgery. And most of them relied on precise restoration of the valgus angle. So what about TKR after HTO? So Pavisi et al. Came out with this paper which showed that there was a high rate of radiographic loosening and high revision rates if you did a TKR after an HTO. And subsequently, however, there have been papers by Ritter et al. Which showed really no difference in knee scores or functional scores or the X-ray of patients who had an HTO or not had an HTO. One of the problems with the high tibial osteotomy using the lateral closing wedge was that you did have a certain incidence of peroneal nerve palsies. Not all of them were overt palsies, but if you did nerve conduction studies, you would have some problems seen on the studies. The reverse dome osteotomy was introduced by Dropelli using the Elizarov frame. And here you had what he called a smiling dome osteotomy, where the center of rotation was closer to the joint line, and therefore you needed less translation. And this was actually quite a simple procedure to do, because you could mark out your arc of your osteotomy with a pin placed at the center of the knee joint, and then you just connected the dots and put in your Elizarov, and you could correct the osteotomy, correct the deformity. However, over the last 15 or 20 years, what's become most popular is the opening wedge osteotomy, especially with the angle stable implants, which is the Tomofix. And this is what is currently still the most popular method of osteotomy for these patients, because even with fairly large corrections, you do not need to use bone graft with the opening wedge osteotomy. And because your cora is very close to the joint, it does not create a problem. So this is a biplanar osteotomy, which allows rapid healing of the joint. Okay, so you do your osteotomy just above the pes. You release the medial collateral ligament posteriorly. You mark out your line of your osteotomy. You do this biplanar osteotomy, which is transverse here and oblique here. You end up with gradually increasing the wedge, and then you do your correction, you check your correction, hold it with your laminar spreader, and then you go on and put your plate. So this is what you get as a result. And we've done multiple cases, which we've also presented in the past. However, more recently, this method of osteotomy has been called into question for some of the cases. And the Japanese have come out with this tibial condylar valgus osteotomy, which is an intra-articular osteotomy, where you have, especially when you have a pagoda-shaped proximal tibia, you rather than do a standard opening wedge osteotomy, you do what you call a transcondylar intra-articular valgus osteotomy, so that you get a better correction of the joint line. And this can be combined with a tibial tuberosity osteotomy. You also have anatomical plates, which allow you to fix the fixation more posteriorly, and you have various separate plate for the left and right side, which gives you a more anatomical position of your plates. So we still don't know the answer in young patients. I think newer techniques, which we have discussed in the past, especially with the use of chondroprotective substances, microfractures, reimplantation of cultural chondrocytes, meniscal grafts, and cartilage transposition, it is possible to salvage the knee joint. So I think the take-home message is that HTO works. There's a resurgence of interest worldwide. The opening wedge osteotomy has been increasingly used, but you have to select your cases carefully. The number of implants available are increasing, and this can be combined with other procedures. So you can combine an osteotomy with an ACL reconstruction, with meniscal problem, with meniscal reconstructions or repairs. You can combine it with chondrocyte implantation. And I think for all these various procedures to succeed, you need a good alignment in your knee joint. And that is where the osteotomy comes into place. Thank you very much.
So, thank you, John, for an interesting and elaborating talk. Very nice. Our next speaker. Dr. Devashish Chandra, osteotomies around the knee.
Hi, everyone. I think everyone is more eager to go. And before anything, I am just disclosing it that I am not an arthroscopy surgeon. And I think most of them, that's why I left. No one knows me about what I'm going to present. I'm going to present something to preserve the knee. And it is a very interesting topic. Those who are here, please bear with me. I'm going to take 10 minutes. I'm going to present something which is about knee preservation. So this is our team at CK Birla Hospital, Gurgaon. This is the whole team with 4 orthopedic surgeons. There are 40 physiotherapists working together. So for knee preservation, there are 2 types of things which are available: is 1-stage procedure and 2-stage procedure for cartilage things. Cartilage preservation is a very significant and difficult thing. So 2-stage, you all know, like ACI, and 1-stage is like chondrofillers, autocards, OATs, and some metal implants like epicillars. Along with, we have osteotomies around the knee like supracondylar osteotomy, distal femoral osteotomy, high tibial osteotomy, tibial tuberosity osteotomy, as well as trochleoplasty. Some additives we do often use is like PRP, BMAC, fibrin glues, and some amniotic membranes. So let me start with some cases. So first case, if you see, this is a very benign looking X-ray. And if you see the screws on the other side, you will always feel the problem is happening in the right knee. But the patient came with a left knee problem after 10 years of initial injury in the right side of the limb. So what happened in this case is that after 10 years of initial injury, he started having pain and limping. On evaluation, his scanogram was normal. When we did MRI of this patient, you can see there's a big cartilage lesion, which is almost grade 4 damage. So he's now at age of 41. And at this age, we are not thinking about unicondylar replacements or something else. We are thinking about how to preserve this joint from further osteoarthritis. So in this case, we went on to do 2-stage procedure. In first stage, we have taken ACI plug, done an arthroscopic procedure and take a bone plug along with the cartilage sample. And second stage, we did open procedure for cartilage implantation as well as high tibial osteotomy in one sitting. So this is the cartilage lesion you can see. It's a big lesion, 1.5 to 0.5 centimeter cartilage lesion on medial femoral condyle, and which was grade 4, including denuded subchondral bone. So in this procedure, we did HTO. Then we have implanted the ACI along with, to prevent that ACI from falling, we have used a amniotic membrane to prevent the falling out of that ACI implant. This is immediate next day where the patient is able to walk without putting weight on the side, non-weight bearing walking with walker. And you can see the HTO, we usually use peak plate whenever it is possible so that we can see all the 4 quadrants which are uniting or not. This is at 3 months where the patient has gained full range of motion. And this is at 3 months MRI. You can still see the cartilage edema, subchondral bone edema is there, but you can see a linear cartilage shadow, which we confirmed again at 6 months and 2 years. Now this is at 6 months where we have started doing all the high level of activities like gymming activities and all. And this is at 6 months. You can still see the edema. There's a faint line of cartilage. And this is at somewhere down the line 2 years where the cartilage is completely grown and he is pain-free and symptom-free. So our idea of combining two procedure was that whenever there's a young patient, doing something for the cartilage may not be very fruitful if we put full weight on the implanted cartilage. So along with high table osteotomy, whenever we change the alignment, there's a possibility that we can save the cartilage from further damage or whatever we have implanted. Similar way, Dr. Vinny told, like HTO with meniscus root repair. No, usually nobody does these cases for root repair. So HTO with repair, root repair, you are going to protect that root. Another case, difficult case where patella is dislocating as well as there's a valgus deformity. Okay, this type of patients are very common and you'll see a lot of patients started having patellar dislocations at the age of somewhere 13, 14 in young females, mild valgus, going into subluxated patella or habitual patellar dislocation and presenting to us somewhere around 26, 30 with a patella dislocated, and you can see large osteophytes on the sides. You can see the grade 4 cartilage damages there and there are large osteophytes. Now this lady is a sister of an orthopedic surgeon. So he advised that these surgeries are usually a failure and you have to live with it. And she was living till 13 to 26 when she got married. Her husband brought her to us. And this is the pre-operative video. You can see valgus and knee range of motion from 10 to 30 degree was possible, pain-free, and beyond that it was completely painful. You can see the cartilage damage. It is almost 80-90% of the patella, the cartilage is gone. This is the condition of the cartilage. In this patient, we grafted the cartilage with one-stage chondro filler. This is the end point along with the amniotic membrane. And we corrected the valgus as well as we have done the tibial tuberosity transfer for this patient. This is the pre-operative X-ray and you can see the corrected alignment as well as the tibial tuberosity transfer. These patients, there is a concern that we should do open wedge or closed wedge. I think open wedge are equally rewarding. The only better part of opening wedge is we don't lose height. And this is at 3 months down the line. You can see she is walking well. Her range of motion is back, pain-free movement. And this is at 1.5 years. You can see the cartilage. Sorry. You can see the cartilage growing back even behind the patella, which was almost 80% grade 4 cartilage damage. Another 2-stage ACI procedure I'm going to show you. This is a patient with a meniscectomy done at age of 18. Partial meniscectomy done for some knee injury at 18 years age. Repeated meniscectomy was done at somewhere down the line, 2 years down the line. He had another injury leading to a meniscus injury. Now this time complete meniscus was removed. He presented again at 24 age with a large condylar defect. Now this is a grade 4 condylar, lateral femoral condylar defect. And with mild valgus deformity getting created because of lateral meniscus was completely removed. In the other side, the alignment is completely okay. In this, it is mild valgus. So in this patient, we did 2-stage ACI. You can see the patellar J sign, you will be able to see. This is patellar J sign, which is usually present on valgus knee. So if there is a condylar defect or there is a meniscus defect, changing the alignment leading to valgus, you might get a patellar J sign as well. So this is the plug of ACI, which we send for culture and we grow cartilage from this one. And this is the condition of the cartilage in arthroscopy. This is at second stage, you can see grade 4 cartilage lesion. This is the ACI plug we have taken. So after removing the cartilage, the subchondral bone was also lost. We were thinking about bone grafting as well, but we went with osteotomy as well as ACI along with the amniotic membrane. You can see the amniotic membrane here. And this is with supracondylar open wedge osteotomy. in one stage. And this is range of motion achieved by the end of 3 months. He is walking well without pain. And now he is down the line somewhere around 1 year. So he is able to do all the activities, even he is back to running activities as well. Again, there are some other cartilage deformities like osteochondritis dissecans. So if you see this MRI, you will see a large condylar defect in this, which is an acute episode. Patient started having pain after an injury and it persisted up to 3 months. Then on MRI, we were able to locate there is a big chunk of cartilage which is missing, and he has mild valgus deformity. This is the condition of the cartilage. When we opened, there is a big cartilage lesion. In this patient, we did supracondylar open wedge osteotomy along with chondro filler. So in this condition, in this patient, we are filling the cartilage. And this is the end point after the surgery. And this is the walking, non-weight bearing walking in the same day, evening. This is 3 months down the line. He is able to bend with full range of motion without pain. This is him doing exercises at 6 months. And this is after 1 month, you can see the cartilage growing, but the bone marrow edema is still not settled. So somewhere down the line, 2 years, cartilage is visible very good, very well. So that's it. I think a lot number of cases are there. I think people are getting bored because they have to go home as well. So I think I would request everyone, please don't think these osteotomies and cartilage procedures are very difficult. We have done somewhere around 26 to 27 cases till now. They have crossed 2 to 3 years of period with osteotomy, with cartilage procedure done along with them. They are surviving well. They are doing all the activities. They are going back to all sporting activities even. So please do not discourage even up to the age of 45. These are successful procedures. Don't let them wait for the knee replacement or wait for the age they reach to knee replacement. If you don't do it, send it to someone who does it and they have fairly good results. So my request is please do not discourage your patient from these type of procedures. Thank you.
Thank you, Dr. Devashish Chandra, for the last lecture and very wonderful lecture. Now we are concluding, no?
Yeah. Thank you, Chairperson. So this was the last talk of this CME. Thank you all. So there is some felicitation program is still left. So may I request Dr. Amit Joshi kindly come on the dais. Dr. Devashish Chandra kindly come on the dais, please. Dr. Binod Thakur, sir, please. Dr. J. Chaudhary, sir, please. Dr. Avinash Kumar, sir, please. Dr. Sasi Kumar, sir, please. And those who are here, kindly come on the dais for just one group photo. Alok boss, Rakesh boss, please. Samir. Thank you all. And in the last, all person from the Paras, the Arthrex people, and the staff from the Maurya Hotel. Thank you very much.
Thank you.